And can you hear me? Hey,
All right. Good morning, everybody. Good afternoon, depending in each part of the world you are. My name is Semir, and I'm very happy to and pleased to open the 15th Bryan Warren School of Pathology that has been continuously running since 2007, thanks to the joint efforts of the Bosnian colleagues and colleagues from British division of the International Academy of Pathology. Unfortunately, this year it was actually 10 years since the founder of this school, Dr. Bryan Warren of Oxford University, actually passed away. And Bryan was really great mind, brilliant pathologist, colleague, friend, who was really very enthusiastic and very supportive to pathologists worldwide, and especially to pathology community in Bosnia. And we are very thankful for all his efforts he did and the legacy he left in the form of the Bryan Warren School of Pathology. Particularly, it was in that hard time in 2005, and actually or late 2005, and the school was actually established when the Bosnian pathology community was really very underserved at that time. And we are also very thankful to his friend and our mutual friend Mike Frenny, also from UK, who is also a great friend and great supporter of Bosnia, actually, who actually initiated all this support with the late Bryan and later with the British division of the International Academy of Pathology. During the previous 15 years, I believe the school has been recognized as an important regional event, pathology event, aiming to improve the quality of pathology service in Bosnia and neighboring countries. Now, since COVID-19, I believe Bryan Warren School of Pathology has also become a more international event, and I'm so happy this year, just likewise last year in 21, having the colleagues really from all over the world. Speaking of this year's school, I'm very happy to introduce head and neck pathology topic and having two excellent speakers. One of them, Dr. N. Sandison, is with us for the second time, and we are very happy to have N back with us. For those who don't know Dr. N. Sandison, she's consultant in head and neck pathology in St. Thomas and Guy Hospital in London. She's also honorary senior lecturer in oral and maxillofacial pathology at King's College in London. Second excellent speaker this year is Dr. Selvam Thavaraj, who is honorary consultant in head and neck pathology at the Guy's and St. Thomas Hospital, and he's also senior lecturer in oral and maxillofacial pathology at King's College in London. Just like all previous years, the aims of the school remain the same. And in this context, in the context of head and neck pathology, our excellent speakers will focus the most important and practical issues in head and neck pathology, but particularly those that are relevant to young pathologists and trainees in pathology. I sincerely hope that this year's school, like previous 14 schools, will meet your expectations, and I expect your active contribution to make this year's school a great and unforgettable event. Thank you very much again, and welcome everybody to the 15th Bryan Warren School of Pathology. Thank you very much. Now we can proceed with the first session, and it's coming from both speakers will speak in this first session. It's about grossing or macroscopic handling of in head and neck pathology. So please, Dr. Sandison and Dr. Thavaraj, it's your turn. Thank you very much.
Thank you.
thank you. I wonder, can you see my screen?
Not yet?
Okay. I'm just, okay. And we go. Yes. I am having the message that my screen is being shared.
Could you start presenting, please?
Yes.
That's good.
Okay.
Excellent.
Thank you. On behalf of Selvam and myself, I'd like to say welcome to everybody and good morning. 10 years ago, I was in Sarajevo in person, and I'm very sorry that we can't be together. But actually, Selvam sits next door to me, and we still can't be together because of the train strike. So life is like that for us. Before I start talking about larynx, because this is my first topic today is larynx. This is the one that we have really an SOP for if you're a trainee pathologist. I'd like to give you some general considerations about head and neck pathology. So I have this picture of the skull. And this is because when you think about the head, it's a bony box effectively. And inside that bony box are the organs of hearing, of sight, of smell, and of taste. So, unlike anywhere else in the body, the concept of function, preserving function, is very important in head and neck pathology. And while I have this view of the base of skull, you can see this is where the brain stem would come through, the spinal cord would come through. You have the rim of the mandible. There is soft tissue all the way down from the base of skull into your neck. So high lymph nodes in the neck, lumps high up in the neck, are usually indicative of perhaps head and neck cancer, whereas those lower in the supraclavicular fossa and at the lower levels might indicate a cancer elsewhere, like in the lung or perhaps from the stomach. So these are the levels in the neck, and Selvam will be explaining all about neck dissection. But it's just to stress again, the high levels, level 1, level 2, level 3, might be coming from a cancer in the ear or the nose or part of the face or inside the oral cavity. So this is another view, this time from the skull, from the aspect of the brain. So if the brain is lifted out, this is the base of the skull from the brain aspect. And you will see there's a lot of crossover with neuropathology, especially here at the top of the nose where the cribriform plate is, and inside the temporal bone. And you can see the cranial nerves by which all these head and neck tumours can abseil into different parts of the brain. So also for each area inside the head and neck, there's a best practice guideline. So different colleges have them, the American colleges, the Australian colleges, and we have in the Royal College of Pathologists. And this is the minimum amount of data that you as pathologists should share with your surgical and oncology colleagues to help them best treat the head and neck cancer. So we need the size, we need the laterality, we need whether there's vascular or perineural invasion. You would record information about the neck nodes, etc. And because these diseases are quite rare, it's quite important to standardize the information that we take and the information that we keep. So we are involved in working with the ICCR, so the International Collaboration of Cancer Reporting, with our colleges to write data sets that people can follow and standardize the information that they collect. Okay, so when you think about tumour size, so the T stage, that stands T for tumour, you find out how big the tumour is from when you can't see it at all, right up to when it's absolutely massive and involving the local sites. So let's stop witching on about the general considerations and do what I am come here to talk about, and that's laryngeal resection specimens, the larynx. So let's have some anatomical considerations. So in your neck, you can feel the landmarks of the larynx. You can feel the superior hyoid bone. You can feel the thyroid cartilage. Those of you who've seen people with a tracheostomy will know it's below the cricoid cartilage and sits about here. These are your clavicles and there's the jugular notch. So you try and put the stoma in the safest possible place where you don't injure the voice box. Because when you think about what the larynx does, it's important for communication, and having this stoma in your neck is another very important cosmetic consideration. And that's something that I meant to mention as well, that how you look your face, is how you present yourself to the world. And unlike any other area, head and neck is very important cosmesis considerations. So just like there's surface anatomy and there's gross anatomy, there's microanatomy. So this is a whole mouth section taken at the level of the glottis, the vocal cords. And there is a microanatomy within the vocal cords, and surgeons will try to operate and with organ preservation to save the voice and save the larynx. And they will follow the microanatomy in order to preserve the contours of the vocal cords and voice preservation. So here's a excised total laryngectomy, and this is a posterior view, and we can see the vocal cords here. And this is a tumor that is transglottic, but also almost circumferential. So the anatomy of the larynx as we know it are in three areas. You have the area where the voice box is, the glottis, the vocal cords, the supraglottis, which is about a centimetre above the glottis, and the subglottis, which is about a centimetre below the glottis. And this is a fresh specimen, an unfixed specimen, viewed from the posterior aspect and the anterior aspect. So these three anatomical sites carry their own minimum data set. They have different connotations for survival. If you have a tumour on the vocal cords, it will affect your voice or make you cough, and you may present early. A carcinoma presenting in the supraglottis will grow quite big before it's going to affect your voice or swallowing. And similar in the subglottis, but it must be said that squamous carcinomas, which is the usual cancer in the larynx, is rare in the subglottis, and actually adenoid cystic carcinoma is the most common. But again, a tumour presenting in the subglottis gets very big before it causes the problems. So again, there are site-specific considerations for the different subsites. Here in the glottis, a T4 tumour would go into soft tissue of the neck, trachea, thyroid, and esophagus. But deeper down in the subglottis, it might involve the cricoid areas and even get down into mediastinum and the lower anatomical structures. So voice preservation is important, and there's a big push to detect larynx cancer early. So this is a very, very early change in the larynx, erythroplakia, and it's a harbinger often of dysplasia and sometimes carcinoma in situ. And they'll try and treat that superficially by stripping the vocal cords. So this shows de-epithelialization or stripping of the vocal cords. If it gets past that stage and it's still small, they will try very much to just excise the lesion locally with laser. So you might have vocal cord polyps or inflammatory conditions that you will take away with a laser. But this procedure is also used for cancers. And remember, at the back of your mind, you've got the minimum data set. So even though this might be a small resection, you have to think about, can I tell them about the posterior, the inferior, the lateral and the medial margins, all of which have different connotations. So if you think about any head and neck specimen, there are 6 margins: anterior, posterior, medial, lateral, superior, and inferior. And that's a very good stead when you get a specimen that you think you can't cope with. You think about these 6 margins. And here you can see a very helpful clinical diagram and information that the clinician's not sure if this is dysplasia or if this is cancer. And if it's cancer, then we should really give them the minimum data set information. So T1 lesions, even bigger lesions, might be excised by laser, like you can see here. And if the clinician orientates the specimen, it can be in different ways. Some people say, oh, I like to use a slice of cucumber. Other people say, I'll put a suture anteriorly and I'll put some ink laterally. It doesn't matter. As we say, there's many ways to skin a cat, but you need to communicate with your clinicians. And if you're going to provide them with the information for the minimum data set, you need to be clear what their orientation as they understand it is. So here you can see a small lesion excised. We can tell which is anterior, which is posterior, medial, lateral, etc. Now this is a T2 tumour, excuse me, excised by laser. And with the bigger tumours, the first thing the clinician does is get a feel for the malignant areas. So he'll put a laser through the tumour specimens. And therefore, by definition, some of these margins are not true surgical margins. And there will be tumour at the excision margin in some areas because of the way the tumour has been resected. But with careful communication, you can overcome that and you can differentially ink the areas which are not the true margins, as shown here. So I know that this is a true margin, this is a true margin, these are true margins, but this area is where the surgeon has gone through the tumour with the laser. So let's look at a total laryngectomy specimen. So I hope I've let you know now that if you're in the exam and you get a picture of a larynx, you can guess the tumour is going to be at least T3 and possibly T4, because they like to try and preserve the larynx for as long as possible. So this is the posterior and the anterior aspect, and you can see these interarytenoid muscles, finger-like sort of stripes at the back of the larynx. That's an important thing to look for. And you can see the piriform fossae, because they usually try to preserve as much of the hypopharynx as they possibly can. So normally this is your average total laryngectomy specimen, and you can't see the tumour in the subglottic area here. And if you look inferiorly, you can't see it in the subglottis, and it may be centered on the glottis. But it isn't until you slice the specimen really that you can see the tumor. So I hope you can see that I've sliced this in the axial plane. So this is my approach, and you can all tweak it or communicate with your clinicians or have different tutors with different preferences. But what we like to do is ink right and left, so we know which is the right side, which is the left side, and we slice after decalcification. You can do it, or we use a bandsaw to slice about 4 or 5 millimeter slices from the top to the bottom. And here you can see the thyroid cartilage pointing anteriorly, and you can see the shape, the change in the lumen in the larynx. And thank you to Selvam for this lovely slide. So you can see how the airway changes some superiorly, where the tissue is quite open to let the air in, down to the glottis, where the vocal cords have to knock together. So the lumen of the larynx changes its shape from round to slit-like at the level of the glottis. And then you have the smile of the cricoid cartilage. So the cricoid's smiling at you, and the trachea is a round lumen with interrupted cartilage all the way around. So if you get panicky in the exam, you think, where are the vocal cords? You look for the area where the vocal cords are going to be able to oppose each other. So it's a slit-like space normally in the larynx specimen. So why do we cut them in the axial plane? It's for communication to the MDT. So you can see here these axial slices. You can see the tumor in this larynx slice, which will correspond directly to the CT scan. And the surgeon and the radiologist can directly compare margins, and they can say whether it's a significant margin, if it's a true margin, whether it opens directly into the space. Now I have two larynxes here. This larynx we've seen before, this one we haven't. And can you see those strap muscles? You can't see them. And that's because there's an awful lot more mucosa here. The surgeons have excised a tumour that's not actually within the larynx, but in the piriform fossa. So these are missing. And if you see these missing, you think to yourself, why can't I see the piriform fossa and these strap muscles clearly? It's because it's a different operation. And if we look at that lesion inferiorly, you can see that there's the esophageal margin to consider, because they've taken out part of the hypopharynx and the cricoid esophagus. So there's the cricoid esophagus and the trachea. And if we look superiorly, you can see the tumour sitting in the piriform fossa. So this superior mucosal margin is important to consider, as well as your lateral margins, your shave margin of the trachea. So here are slices through that larynx. You can see the tumour, and it's going all the way around in the hypopharynx and encircling the level of the glottis is here. You can see the cricoid and you can see the tumour, and this is the cricoid esophagus. a different tumour where you can see this tumour. Again, it's not within the supraglottis, but it's in the piriform fossa, and you can see it at the top, and they've excised some of the esophagus. Inferiorly, if you look at the bottom end of the larynx, you can see the mucosal margin you need to consider. So here is the superior slices, and you can see a massive tumour encircling the hypopharynx and into the trachea. Higher power view with a hole mount, so you can see the tumour and going into the larynx at the level of the vocal cords. And this is just another view where you can see it deeper down the level of the cricoid. So I hope I've convinced you that these axial slices are very clear and it's easy to follow the anatomy. So yet another, the hyoid bone is here on the anterior aspect and posterior aspect, as before, and you can see this is a massive tumour. So we've taken here a shave, a longitudinal section of the epiglottis. I will have taken a shave margin of the trachea, and you can take these blocks either in mega blocks or you can cut them into smaller slices for smaller blocks. So here you can see the tracheostomy site, the thyroid lobules. You can see a supraglottic tumour. So you need to consider that superior margin. Again, the axial slices, the tracheostomy site is quite clearly seen. And this is the hole mount. And if you decal it carefully, you can get beautiful histology. You can still see the perineural invasion that you need to report upon, and you can see your vascular invasion, and there should be no problem for your histological considerations. But what's important to note is once the specimen is in decal, you have impaired any molecular analysis you'd like to do. So I would like to put a vote in for getting specimens fresh where you can, examining the specimen, see if you can sample the tumour for tissue banking or for molecular studies before you dump the whole thing into formalin and then acid. So I think that's a race through from my larynx specimens. So Selvam's got nicer pictures, but this is where I am at the moment. And I'll hand over to my colleague, Selvam, to take over the macroscopic description.
Thank you, Anne. Just bear with me, everyone, while I set myself up with. And just confirming from the audience that you can actually see.
Yeah.
Excellent, thank you. And that's a nice segue. Thank you very much, Anne, for that lovely overview. And I thought I'd put this series of three total laryngectomies in continuity with bilateral neck dissections as a little segue to reinforce your point, really, Anne, that that there is more than one way to skin a cat, and I think with the larynx, it's really helpful that there is an SOP. But I think unfortunately with the oral cavity, we do not yet have an SOP. I beg your pardon. Sorry, was that a message from anyone? I can proceed. Yeah. Okay. Thank you. Let me just get me laser pointer out. So let's talk a little bit about the oral cavity. The thing is with the oral cavity, it has the tongue, the floor of the mouth, the lingual and buccal sulci, the cheeks, the maxilla, the palate, and on it goes. And so it is really difficult when I was putting this talk together to think about a standardized approach to any specimen that you receive for malignancies of the oral cavity. It can range from a simple wide local excision of the lateral tongue, as you can see here, in this case a suture marking anterior, to slightly larger partial glossectomies, as demonstrated here. Incidentally, while I've got this slide up, sometimes our surgical colleagues not necessarily always go through too much trouble in orientating the specimen, but with a lateral tongue or a subtotal glossectomy, an important pointer is that on the dorsal surface of the tongue, you have the filiform papillae. It's roughened whereas on the ventral surface of the tongue, it's smooth. So knowing what the dorsal and the ventral surface is will indeed help you orientate your specimen. So here's a lateral partial glossectomy with the malignancy in this aspect here. And in this case, I have sliced the specimen in the coronal plane as demonstrated here. But just again, to reinforce the point, there's more than one way to skin a cat. So you could bread slice this specimen from anterior to posterior, which is entirely appropriate. An alternative would be to take a horizontal slice through the center of the tumor. That will give you your maximum anteroposterior dimension of the tumor microscopically. It will also then allow you to measure your deep margins. You can then come at perpendicular slices to the ventral and dorsal tongue. Or yet another way, you could take some central coronal slices and then radial slices to various margins around the edge. So really, I cannot be prescriptive about this in any way. Each specimen is different, and one has to handle it in the best way that one can. I put this slide up just as a quick reminder. In TNM7 era, pre-2017, we as pathologists used to agonize a lot of the time in trying to determine what may be the intrinsic muscles of the tongue versus what are the extrinsic muscles of the tongue. Our radiology colleagues can determine this quite a lot more accurately than we can once the specimen is out of the patient. But pre-TNM8, pre-2017, whether or not a malignancy invaded the extrinsic muscles of the tongue influenced its stage. I'm thankful that with TNM8, we have done away with that criterion, so it's no longer something to agonize about. However, I just put this slide up just to show you the lingual view of the floor of the mouth and the lingual gingiva in its relation to the submandibular gland, just to point out how close the floor of the mouth and the structures subjacent to the epithelium in the mucosa and the floor of the mouth, how close it is to the submandibular gland. Because that if you have a specimen where the primary site is separated from the neck, it's important to be aware that the tumor may be in very close proximity to the tissues in the neck dissection. And when you separate out your neck, or if you've received your specimens already separated out, your tumor may actually the excision margin may be quite a lot further away than what you think if your plane of separation is just along there. This is a coronal view of the tongue and the mandible with the mylohyoid muscles and the hyoid bone just here. And often with a tumor in the lateral tongue, as demonstrated here, a wide local excision or a hemiglossectomy would be like so. It may include the floor of the mouth, and inevitably the junction between the floor of the mouth and ventral tongue, the sort of the lingual pouch, as it were, is often where the closest margin is. And so this is something, again, to be aware about as you sample your glossectomy section. So here's a case to illustrate that point. A hemiglossectomy in continuity with the floor of the mouth, and I've peeled that back to show the irregularity of the tumor. And having sliced the specimen from anterior to posterior in the coronal plane to demonstrate the tumor, in most of these instances where you have a bit of the floor of the mouth, the tumor often encroaches or becomes very close to the reflection, the junction of the ventral tongue with the floor of the mouth. And so this is sometimes surprises our surgical colleagues, but as pathologists, we need to be aware that the neck dissection may often start at that point. And it is very difficult to standardize and to have a standard protocol for sampling the specimens in the oral cavity, primarily because they come in all sorts of shapes and sizes. Even soft tissues of the floor of the mouth and lateral tongue often encroach very close to the bony structures, for example, the mandible, and you may receive a hemiglossectomy in continuity with part of the mandible with teeth in it. And the mandible itself may come in various extents. So here, for example, you have a lateral glossectomy and a segmental mandibulectomy, which includes the whole of the inferior border of the mandible, or a smaller specimen which just includes the mandibular alveolus, like so. So you already know that in that specimen you have an inferior bone margin if there is bone involvement, whereas in this specimen you do not have one because the surgeon has included the lower border of the mandible. A very, very basic view of the anatomy of the mandible with the sigmoid notch, the coronoid process, and the condyle, ramus, angle, and body. And when your specimen includes the bony mandible, it may be, like I mentioned before, a partial mandibulectomy that includes the lower border. We call that a segmental mandibulectomy if it includes the lower border. Where the surgeon takes the cut may vary. They may disarticulate the condyle to give you the whole of the posterior border, or their cut may come anterior to the coronoid process. But again, often it goes through the sigmoid notch. And if it does, obviously, there will be a bony margin to report on. And that bony margin will carry a part of the infrabony part of the inferior dental nerve, which may need to be sampled. By contrast, a marginal mandibulectomy will not include the lower border of the mandible, and therefore it's important to be aware that you will have an inferior border. Both Anne and I are very privileged to work in a specialist head and neck pathology laboratory, and we've come to treasure our bandsaw, which is a dedicated tissue bandsaw in our department, because this allows us to slice up our fixed specimen, which includes the bone and the teeth, prior to decalcification. It speeds up the decalcification process, but I am aware that not all departments have access to this, and so you might have to resort to decalcifying the specimen in toto prior to slicing it up. A staple for head and neck pathology, being as there are a lot of hard tissue, is decalcification. As Anne mentioned earlier, we have the option. We usually use either 10% formic acid for slightly slower decalcification. There is much better preservation of the tissue architecture and tissue quality, useful for diagnosis, and less damage of the antigens with formic acid, but you do sacrifice time. For more rapid decalcification, we use 10% nitric acid, but again, we are very privileged to work with highly skilled biomedical scientists who've got it down to a fine art, who know that sometimes you only need to leave a specimen in nitric acid for several hours to get the optimal cutting consistency. We do our endpoint testing, i.e., when we know that the specimen is sufficiently decalcified, with the use of X-rays. And again, that is something of an art that requires quite a bit of experience to know exactly when the specimen is ready for microtomy. So this is a rather broad approach to how I may handle specimens of the oral cavity. Having orientated the specimen, I try and correlate it with imaging as best I can. If you have access to clinical images or radiology, as in this case here, you have an edentulous mandible with a mandibular alveolar carcinoma that's been resected. And the clinician has provided the clinical image, and that's really good because I can correlate the specimen and orientate it accordingly. In this instance, they've done a mandibulectomy that's gone through the sigmoid notch. Plain radiography may also be helpful. In this case, I can see that there is an irregularity on the superior part of the mandibular alveolus, and I can therefore assume that there is already bone involvement. So having these radiographs, it then helps me to decide where I might, how I might approach my specimen. In this case, because I know that there is bony involvement, I might come in the coronal plane in this way to capture at the very earlier stage microscopic confirmation of bone invasion, which automatically upstages the tumor. Another subtotal glossectomy specimen here, and in this case, very useful to have the coronal MR slice, and where I was able to estimate the largest mediolateral dimension of the tumor, and therefore put my first slice and try and correlate it with that, and therefore take my measurements of the largest mediolateral dimension of the tumor in order to see if it matches up with the radiological dimensions. So imaging or access to imaging is often very, very useful and handy to decide how you might approach the specimen. Again, in this case, a superficial parotid in continuity with a neck dissection. And I couldn't really palpate any mass lesions in this instance. And so resorting to the imaging was very useful because our radiology colleagues pointed out that small tumor, like so in the posterior part of the parotid, which corresponds to this rather pale region. And so, again, very handy to have the imaging. Otherwise, I might have taken too thicker slices and possibly missed the lesion. Okay, separating out the neck I've already mentioned. Just be aware that you want to try and avoid cutting through tumor and bearing in mind that it may add additional margin. We have the privilege as well of being able to take lots of macroscopic images. And I often tell our more junior colleagues and trainees, you don't lose anything by taking lots and lots of macroscopic photographs, and try and do that in all possible views if you can. This is a hemimandible, which includes the lower teeth and the lingual mucosa coming into the floor of the mouth. This is the uh, surgical bone cut in the symphyseal area, a tumor in the buccal mucosa, and the surgeons have removed part of the posterior maxilla like so. And here we are viewing the specimen from inside the mouth, from the lingual aspect, which is very handy. It looks slightly different from the anterior aspect, but if you have access to multiple digital photography, then you can take lots of photographs, you can print them out, and that allows you to make lots of annotations on the printed paper, so that your block key doesn't become too confusing. You don't lose your orientation as you go along. So lingual view or intraoral view, anterior view, and lateral view, which in this case include part of the skin of the cheek. So lots of photographs is always helpful. Another specimen here, clinical photographs help to orientate it. So the teeth, the lower canine teeth, are included in the specimen, lingual view of the tumor, and superior view, intraoral view. Okay, so that matches up quite nicely. Having taken lots and lots of photographs, we then need to make our measurements and then decide where our macroscopic margins might be, and then consider taking soft tissue margins either separately or in continuity with the bone. And so because it's quite difficult to be prescriptive on a diagram, I'll try and talk you through how I might approach a specimen like this. So a partial mandibulectomy, in this case, the cut going through the sigmoid notch anteriorly in the lower canine region. I might, in the first instance, say, actually, this margin here, which is the macroscopic buccal mucosal margin corresponding to the buccal mucosa in this region, looks a bit close. I might want to sample soft tissue specimens in the coronal plane like so and submit those separate from the bone. Otherwise, I might decalcify the whole specimen and then take buccolingual slices right through the bone. If you have a bandsaw, then you can do exactly that, and you have both bone and soft tissue together. I might then come perpendicular, try and track the inferior alveolar nerve, the inferior dental nerve, to the posterior bony resection margin through the bone, and correspondingly do the same for the anterior margin. And here are some further slices from another case, actually. And in this instance, I just wanted to highlight the point that sometimes, if the situation allows, I might, to speed up the process, separate out my soft tissue from the bone. So here, for example, we have a slice in the sagittal plane through the anterior teeth. This is the lower incisor teeth, with part of the floor of the mouth and part of the tongue. And these are your genial tubercles, and this is probably genioglossus muscle. The tumor is quite superficial, and I can see no evidence of macroscopic infiltration. I can see that most of the lingual cortex is intact. And what I might do in this case is to separate out, do a blunt dissection in the subperiosteal plane to submit soft tissue separate from the bone. Another handy point is that teeth are much harder than bone. Enamel is much more dense than bone. And if the crowns of the teeth are not going to be useful diagnostically, I just lop them off either in the bandsaw or once they're partially decalcified, because it just speeds up the decalcification process. So I lob off the crowns of the teeth where necessary. In this case, on the other hand, it looks like tumor comes very close to the bone, and I need to assess whether there's any bone invasion in the lingual cortex here. I wouldn't necessarily separate this out because I think it might disrupt the continuity of the bone with the tumor. Okay. So these are my sagittal slices of this particular case. So I beg your pardon, these are my coronal slices. So you can see the tumor, in this case, a more broad pushing invasion front of the bone of the mandibular alveolus. And this is my slice perpendicular, and this is more luck than judgment, I think, but I've caught the inferior alveolar, inferior dental canal, sorry, the inferior dental neurovascular bundle in its canal, which I can then sample. I might, I beg your pardon, some other cases here where we've tracked the nerve to the posterior bone resection margin. In this case, the tumor encroaching quite close to the ID canal, and we might be able to therefore sample where our surgical colleagues have amputated the stump of the inferior alveolar nerve, just to exclude perineural invasion tracking up into the base of the skull. Quick point as well about the mandible. It is an arch, and I beg your pardon, it is an arch, so if you're going to come entirely in the coronal plane, you're not necessarily going to follow the arch. One consideration is actually, therefore, to take your slices radially. And if you do that, you might not necessarily have parallel slices as you go around the mandible. Here, for example, the buccal or lingual gingiva might be the closest margin. And if you come in the entirely coronal plane, you might miss that. And in this instance, this is what I've done. I've sort of taken radial slices where I've been able to take a parallel slice in one instance, but the next slice had to be more of a wedge just to maintain the continuity around the arch. Okay, so that in essence is a rough guide to how I might approach a mandibulectomy with carcinoma of the soft tissues that are related to it. I might then come radially to go into my posterior margins, my posterolateral and posterior medial margin, and likewise anteriorly. Now, the other thing that you might want to do, because your gingival tissues here and your lingual and buccal sulcus tissues are indeed surgical margins, if you did that, you may not be able to make microscopic measurements to the anterior soft tissue margins. What you might want to do as an alternative is to take soft tissue slices in the lingual and buccal sulci so that you can have an accurate measurement of the microscopic margins in this instance. Okay, so I'm just going to speed up a little bit because otherwise I might run out of time. So I'm going to go on ahead to mention some of the larger specimens. I thought I'd illustrate this. Sometimes you might need to come sagittally if you have a subtotal glossectomy in continuity of an angle to angle mandible. Just to bear in mind that occasionally you might want to go in the coronal plane, not just sagittally. And in this instance, the coronal plane was quite nice. It showed the tumor in the floor of the mouth, and it was held back by this mylohyoid muscle. And so this was quite handy to demonstrate that although the tumor originated in the floor of the mouth and went up into the ventral tongue and into the floor of the mouth, it did not extend down into the neck and respected the mylohyoid muscle, which separated it out from the submandibular gland. Okay. For some of these larger specimens, I rely heavily on our surgical colleagues to help us out with their orientation so that we can match it back to the surgical specimens. In this subtotal glossectomy, which was rather asymmetrical, as you can see, it included, I think that's the coronoid process on the right-hand side, but ended up in the body of the mandible on the contralateral side, and only contained the lingual plate. So a rather asymmetrical specimen with a rather awkward V-shaped soft tissue margin posteriorly. But it was handy to see the perioperative images. So what they've done, what our surgical colleagues have done, is that they've preserved the lower border of the mandible and the buccal plate and dropped the whole specimen down. And this margin going into the pharynx corresponds to this margin on the specimen. Another view to demonstrate the same thing. And so in this instance, I knew that this was going to be my close margin, and therefore, rather than coming straight in the sagittal plane, I went radially because I knew that this was covered by mucosa, and therefore I was able then to pronounce on the posterior margin. So all this is really just to emphasize the point that there is no definite prescriptive way to sample a specimen. One has to be guided by the variety that the oral cavity specimens provide us. I just briefly want to mention the maxillectomy specimens, or specimens that include the part or the entire maxilla, just to emphasize the point that a lot of the superior part of the maxilla encroaches onto the maxillary antrum and the floor of the nose and may not be true surgical specimens. They're not a true margin because at one point they would have been covered by mucosa. So just bear that in mind, because sometimes when you get your specimen, it's difficult to remember that, especially when a lot of the mucosa has been eroded by carcinoma. Cut-up atlases or Grothic atlases are always very handy to show you how to approach a specimen. But do bear in mind that it's nice to have a diagram, but in reality, specimens are a lot more irregular and ragged. And once you start with your specimen handling, it often falls apart, as in this case, where I've taken some coronal slices, and this is what was intended. In reality, because the tumor was rather advanced, the specimen started to disintegrate. So that's something to be aware of and prepared for. But I think having careful annotated macroscopic images help to mitigate that slightly. Superior view of a maxilla here, just to say that sometimes it's a little difficult to know exactly where the airspace would have been. Here we have a little polyp coming up into the maxillary antrum. More posteriorly, there is no airspace, and these would be true margins. Maxillectomy specimens may or may not contain part of the pterygoid plate posteriorly. It's important to note that you should gain this information from our surgical colleagues, because the pterygoid plates or the pterygomaxillary fissure that separates the pterygoid bone from the maxilla is the junction between the pterygopalatine fossa and the infratemporal fossa, and it's a very important anatomical junction, because if tumor breaches this junction, there is a potential for it to go into the base of the skull and the pterygopalatine fossa, or into the infratemporal fossa soft tissues. And so this is an example just here where I've tried to go in that plane just to capture in this slice the pterygomaxillary, pterygomaxillary fissure, because this is the entry point, if you like, of the posterior superior alveolar nerve. And in this case, it was rather important because this poor patient had an adenoid cystic carcinoma with propensity for perineural invasion. Again, just to highlight the point that it's difficult to be prescriptive. In this instance, I felt that it was important to go coronally more anteriorly and then more radially posteriorly. I'll just move on in the interest of time, just to very briefly mention that sometimes the maxillectomy specimens are rather harrowing. Do not be put off by that. Again, judicious use of grossing photographs do help you to orientate your specimen and to keep your orientation as you start cutting up so that it all doesn't become too difficult and you don't lose your orientation. So I try and remember to number my slices in sequence so that when I take my blocks, I annotate them on the diagram and know exactly where I need to be. Uh, More challenging are these specimens that I'll very briefly touch on. This is what my dear colleague Anne calls the maximal specimens, which contains part of the maxilla and the mandible. I find these to be most challenging. We had one that Anne, you presented not too long ago, where tumors in the retromolar trigone or in the posterior maxilla encroaches on the mandible as well. And so you might have part of the maxilla in continuity with the mandible, in this instance here, or a more exaggerated specimen like this. And really, the only way to approach this is to separate the maxilla from the mandible and then deal with them separately. But when you do so along this, if you like, the occlusal plane where the teeth separate, you just need to remember that you will cut through the mandible, and therefore your superior half of the specimen not only has the maxilla, but has part of the mandible, the coronoid process. So this is where I've separated it out and I'm viewing the specimen from the inferior aspect. So although this is the maxilla, I have part of the body of the mandible horizontally, like so, just there. Okay, I beg your pardon. Another more larger specimen. So again, plenty of macroscopic images to help, just to help you orientate. Here we have maxilla, mandible, uvula, pharynx coming into palate. So a rather complex specimen, but separating the maxilla from the mandible and dealing with them separately may be useful, like so. Okay. So I just want to highlight a few points as I round off the oral cavity. I've probably taken far too much time already. Just want to highlight and emphasize that I think there's clinical and radiological information are invaluable. No two specimens are the same, and it's very difficult to be prescriptive. You need to be guided by both the location of the tumor, the site of where it's located, the type of specimen, and the extent of the tumor, and where you think your closest macroscopic margins are will determine how you approach them. And each case is different, and therefore basic knowledge of head and neck anatomy is helpful as it helps you navigate through your spaces. Um, I'm very briefly going to mention a couple of points about neck dissections before handing back to Anne. Sorry, Anne, please bear with me and thank you for your patience. Neck dissections are bread and butter, and I just want to highlight just one or two important points just to remind you that the neck is divided into levels using anatomical structures. The point I want to make here is that in neck dissection specimens, a lot of the time, the anatomical structures that separate the levels remain in the patient. And so if your surgical colleagues have not separated out the levels for you, or if they've given you a neck dissection in total, you will need them to delimit where the various levels are, because otherwise doing it in the pathology laboratory will be nothing more than arbitrary. Another point to note is that level 2, which is usually where a lot of the metastases are identified for oral cavity cancers, level 2A is separated from level 2 by the accessory nerve, the spinal accessory nerve, and they're not equal halves. Level 2B is often very small, and not often, the lymph nodes of level 2B are not often involved in oral cavity cancers, and surgeons often don't include that. So important to know whether they have or have not included that. There are different types of neck dissections. Briefly speaking, there are ones that are radical, that extend from levels 1 to 5, but more selective ones do not. And there are various surgical classifications of neck dissections, and I won't bore you with that. You can get that from any standard text. just to highlight the point that unless your surgeons have separated out and annotated the neck dissection for you, it's very difficult for us to do that arbitrarily ourselves. I was privileged to work with a surgeon who was also a very good artist, and I thought I'd put these two images up because I found them to be extremely helpful. How he's um, annotated his diagrams with the anatomical separations. So that's a little tribute to a dear surgical colleague. Where there are large metastases, conglomerates, I sometimes open up the neck just to view whether we have a group of matted lymph nodes and what its relationship is with the internal jugular vein. So here, for example, the tumor is large. They've included the internal jugular vein, and I can see it's encroaching onto the wall of the eye of the internal jugular vein, and it'll be useful for me to sample the tumor in continuity with the wall of the vein. Excuse me. And here it's gone through the sternomastoid muscle. So a radical neck dissection would include the bulk of the sternomastoid with a post-irradiation residual carcinoma in the neck in level 2, which has gone extranodally into the sternomastoid muscle and encroaching onto the internal jugular vein. So be aware that sometimes you might need to sample areas that have spread extranodally, especially in the TNM8 area, where extranodal extension upstages the end stage significantly. I think at that point, I've probably taken too much time, and I will hopefully hand back to Anne to take over. Thank you very much for your patience.
Thank you, Selvam. I thought that was really a masterclass and very, very clear. I'm going to what was the word, segue to go with your mandibulectomy specimens and into the nose. So I hope, can people see my screen?
Not yet. You're not sharing it
No.
yet.
Okay. I'm going to do it again, and I'm here and in presentation mode. Are we on?
Not yet.
Okay, try again.
So share screen, entire screen.
Entire screen, yeah, got it. And share
That's it, we're
and
getting there.
there
Now we need to go to
and
PowerPoint.
presentation mode.
Brilliant.
Okay.
Just
I'm
one
in
more.
my NHS office between two great big high buildings, so you have to forgive me. Often the internet does what it likes. It's
Yeah,
not
we're there
it's
now.
not my incompetence. Okay, well, that's my story and I'm sticking to it. So as we say, I'm going to move on now to above the oral cavity into the nose and paranasal sinuses. Now, not often will you get a specimen like this. This was a woman from the north of England who couldn't face having surgery to this part of her nose where a squamous cell carcinoma had developed inside the columella. And she tried, first of all, radiotherapy and chemotherapy, and it didn't work. So she had this subtotal rhinectomy. So if you saw this in the exam, you might sort of have a slight miss of the heartbeat, but you remember 6 margins. So there's a superior and inferior. There's an anterior margin, which would be in midair here, but it's quite important in the skin above the lip. There's the posterior margin. There's the medial and lateral margins, superficial and deep. So whatever you want to call them, there are 6 margins. So for the plastic surgeon, this margin was very important to maintain the contours of the mouth, because, as you know, people ask you if you think someone's had a stroke, their mouth may change, their mouth may fall. And so when you think about cosmesis and reconstruction, it's good to be aware of your plastic surgery colleagues and what their requirements may be in order to put the patient back together again. And Selvam's explanation there of communication, orientation was really a masterclass. So you can see here, this is the view from the left side, and this is the view from above. So these margins, posterior, superior, right and left, are very important. So if we take a slice through this nose, you can see there's the tumor in the columella. It's coming down through the nasal septum, and it's actually positive at that margin. which would be the posterior septum. So mid-facial degloving. I'd like to talk about the craniofacial surgery so that you're aware, because sometimes we as pathologists, we don't understand what goes on. So in a mid-facial degloving, it's exactly as it sounds. They do a cut above the upper lip and pull back the skin to access tumors in the floor of the nose. So here you can see them excising a tumor and part of the septum there. They have in theatre a CT scanner because your bony prominences don't change, so they can monitor where they want to put their cuts. So in this particular case, this is a hemimaxillectomy specimen. They have taken out, left a huge gap then, which they need then to repair. So from your point of view, there are 6 margins, both bony and soft tissue, anterior, posterior, superior. Inferior will be the oral cavity and therefore into mid-air. And the medial aspect may well be into the nasal cavity, which is again mid-air. So how to put the patient back together again? The prosthetics people make a mold for an obturator. The surgeons can put in implants into the bone and they put in a flap, and then combination of the obturator, the implants can make a very, very good cosmetic outcome, because people can see when you laugh and when you smile, about what the top of your mouth looks like. Craniofacial resections, they are in several types. A type 1 is the mid-facial degloving I just showed you. Type 2, they might come down the edge of the eye and around the nose and open up the mid-face. And type 3 I call the headectomies, where they actually get the saws out and they cut part of the skull bone to lift off part of the cranium when they need to access those tumors which have gone through the cribriform plate or into the brain via other routes that you've been seeing. This was a young person, had a tumor in the nose, so you know what's coming. Wide local excision, they say. And in other sites, that doesn't matter. If you think about soft tissue, breast or colon, you've got 32 feet of colon, you haven't got much face. So a wide local excision for this meant this. This was a woman who'd gone to the polyp doctor, and he wasn't a cancer doctor. I wrote back saying I thought the polyp on the right side was actually very worrying, but he didn't get the message for about 4 months. By the time she came back, it was in the cheek, and this was the operation that she needed. Again, you can see this papillomatous lesion on the septum of the nose. 6 margins, as we've said. The plastic surgeon really wanted to know whether he had a clear margin in the inferior skin, and you can see a section in that plane shows the tooth with the bit of skin, and you can see that was a good 5 millimeters away from the tumor, which was sitting in this area here. Now, this was another specimen where you can see Selvam has shown you many of these so-called commando procedures. This poor woman had a tumour inside the nose, which was fungating out through the top medial aspect, lateral wall of the nose and through onto the dorsum of the nose, and required this operation. This is the fresh and the fixed specimen. Again, 6 margins, superior, inferior. Inferior was the side of the nose and the palate. Anterior doesn't matter so much, but posterior and lateral do. So that was the sections we took in the soft tissue, and then you consider the bony margins. And here are some sections through. And as Selvam says, we number our slices, we write all over the printouts, and you can see the tumour here, and you could see that the margins were really quite good. Then that's what it was. It was a non-keratinizing squamous cell carcinoma, and there was lots of perineural invasion. So moving quickly to the ears, because I realise that we're pushed for time. And again, those of you who don't wear head coverings for religious reasons, expose your ears and even put earrings in. And men have short haircuts quite often. So the ears are very visible, and the surgeons will try to preserve the ear. And if you get a wedge excision, it would be nice to know which way up. So which is superior, which is inferior. You can see that this margin doesn't matter, it goes into midair, but this medial margin does matter. So I would take my sections this way, and you could potentially do a coronal or a sagittal section in the opposite extreme. Sometimes, in the interest of preserving the ear, they will do a very complex excision, but with a diagram and some sutures, you can see which way round it is, and you can give your minimum data set margins as to what's superior, inferior, medial, lateral, etc. So this is a total pinectomy. And again, if you put your finger in your ear canal, move your jaw up and down, you can feel that the temporal mandibular joint is at the bottom of just above the ear canal. So that often comes out with the specimen. So there may be a lot of bone on the posterior aspect. This was taken out for recurrent mucoepidermoid carcinoma that had gone into the ear canal. Here's the temporomandibular joint, and you would again take the specimens from superior to inferior. Your margin into mid-air doesn't matter, but the medial and the deep margin matter quite a lot. So here you can see your posterior, you can see your skin margin. The anterior doesn't matter, that will go into mid-air. Eyes quickly. So orbital exenterations, again, 6 margins. You have superior, inferior, medial, lateral. Anterior will be into mid-air, but posterior matters. And on the posterior deep aspect, you'll see the optic nerve. That's an important route into the brain, and you should always sample it. So again, how I would sample this would be to look at the medial margin, look at the lateral margin, and take sections through the globe. And I hope you can see there's the tumour in the lower eyelid. The deep margin is good, the posterior margin is clear, the superior margin's fine, and you're able to confidently say to the surgeon the size of the tumour, the depth of invasion, and whether or not you think your margins are macroscopically and microscopically clear. So this was a so-called commando procedure for a poor man who hadn't sought help because his wife was dying of cancer, and then he was very afraid. So eventually he came to see one of my colleagues, Mr. Clark, at Imperial, and they decided that this basal cell carcinoma, for that is what it was resectable. So this was excised, as you can see, again, 6 margins, superior, inferior, medial, lateral. He was left with this defect to fill. They built up the orbital bone. They put in magnets. They put in metal in order to be able to attach a prosthesis magnetically. They took out a huge rim of skin, as you can see, and all those peripheral margins were important: superior, medial, inferior, lateral or posterior, and anterior. And this is the wall of the nose, which is not a true margin. The anterior skin is not a true margin, and the palate is not a true margin. That will open into the oral cavity. That will open into the side of the nose. This opens into air. And eventually they put in the flap. They attached their metal scaffold by magnets to the implants that you saw. And that's the prosthesis, and that's gone from this to this, which I think you'll agree is a fantastic outcome, both for the surgeons, the whole team, and the patient, who can have look forward to a better quality of life by far, see his grandkids without scaring them. So basically that's a whip through. I hope we're in time. And we have another message I'd like to superimpose on Selvam's messages. Careful orientation and communication is the key. Don't be afraid of the specimens. Don't be afraid to let them wait until the surgeon has told you which way up. Just ask which way up. And they're very happy to show off their skills both in artistry and in surgery. And we found our colleagues' help and advice invaluable in handling these specimens. So I hope we've taken away some of the fear. So I think I will stop sharing my screen there, and hopefully we're caught up a little bit in the time.
Yes, I think we have. Thank you so much, Anne. I am going to come back on, hopefully, and
Yeah.
having similar problems and not being able to share. I tell you what, probably because I need to go to, yes, there we are. I trust you can now see my screen. Yes, I think so. No, thanks so much, and no, I think we are on time, and thanks so much for really highlighting those important points. I think uh, cementing it in terms of the patients really sort of helps us. I think sometimes
Yeah.
we don't have the opportunity, the privilege that our surgical colleagues have of seeing these patients pre or
Mm,
post operatively, and,
absolutely.
and and contextualizing them has been really important. And in the last few minutes, really, I just wanted to uh, emphasize your point about communication and clinical pathological correlation, because um, we often invite our surgical colleagues up to the lab so when they bring the specimens, they discuss it with us, they help orientate the specimen with us. And I've already mentioned this before. Perioperative photographs and correlating that with the specimen can be extremely useful. Um, in this instance, for example, uh, just about before the surgeon was about to deliver this lateral petrosectomy with part of the pinna and total parotoidectomy in continuity with the neck. Um, they've taken this photograph, and then this is the fixed specimen which I've superimposed on the clinic on the surgical photograph, and that really was helpful because I knew where everything fit. And this is the deep part of the same specimen that's been fixed, and the surgeon has again helpfully taken a photograph of the bed, the surgical bed, having delivered the specimen. And it's almost we have the opportunity there to put the pieces back together again. For example, this is the head of the mandibular condyle. I knew it would have sat in the glenoid fossa there. This is the surgeon's cut through the sigmoid notch of the mandible, like so. And I know that that bit would have fit onto that bit just there, the glossopharyngeal nerve. And having these structures, I was then been able to locate the external auditory meatus and the mastoid behind it. And I know all that would have located in that direction. And therefore, when I sliced the specimen and where the tumor went to close margins, I was then able to communicate these using photographs back to the um, to our surgical colleagues. So in this case, you can see the tumor extending to the deep surface here, and we tried to locate that back, and would have been in this roughly in this region here. So it just really, emphasizing your point, and that communication is absolutely key. And communication doesn't necessarily always need to be verbal or written. It can be pictorial like this. Another instance here where the fixed specimen I've tried to superimpose on the clinical image. And just in a couple of minutes, I just want to introduce a growing branch of head and neck surgery, which is the use of the robot, the oropharyngeal specimens, oropharyngeal resections now are done largely with the use of a transoral approach using a robot, which is double jointed. In the past, surgeons would have had to do a lip split, open up the mandible, do a tongue split, separate everything out just to get to a small tumor in the oropharynx in the tonsil region. Nowadays, this is largely done by robots, but it's become really important, therefore, to have really close communication. So here we see a tumor. So we're looking at the patient from the surgeon's view. So we've got apparatus going down into the airway. This is the tip of the epiglottis. This is the vallecular region, and so the tonsil is round about here, going down into the vallecula. And this is what the surgeon was left with after they removed robotically the tumor, and they brought the specimen up to us and said there was a little bit more tissue in that aspect. And having this against that, we were then able to really closely correlate where we felt a deep margin was involved. And in this case, it was going down into the vallecula. And we took these images back to our tumor board meeting, and that helped the surgeon and helped us to really pinpoint where the margins were. So clinical pathological correlation, I really advocate that. In this instance here, a total maxillectomy. I showed you the specimen earlier. The frozen sections were taken in various parts of the tumor bed. The surgeon has very helpfully numbered these where they've taken it from, corresponding to the tumor, to the bed of the resection, as well as to the resected specimen. This is the fresh specimen, and this is the fixed specimen. And so that was really helpful. These were the areas that they were concerned about, and we were therefore able to pronounce exactly where the tumor did or did not extend to. Okay, so I think I'll wrap it up to that. I've already gone through these points, and I just want to add this additional point and underpin what Anne has just said. Clear communication is essential. Preoperative, perioperative, and post-surgical are absolutely essential. I think I'll end the talk there. Thank you very much for listening, and thank you for your attention. We're right on time. Excellent. So I think, shall I then move smoothly on to the next presentation, which is HPV testing in head and neck cancer? If there are no objections, I think I'll do that. So let me just call up my next presentation, which is that.
Perfect.
I take it that the audience can see my screen now, which is a panoramic view of a early sunrise in late autumn in London.
Yeah.
Thank you
Yes, we
very
can
much.
see.
And bearing in mind that the audience is from all across the world, so I just thought at this point I'd send some further greetings to everyone across the world. And just to show you where both Anne and I we work, this is a very well-known landmark in London, Tower Bridge, sitting on the River Thames. This is a very new building. I think at one point it was the tallest building in Europe. It's called the Shard, brand new shiny building. I'd like to say to you that this is where we work, but unfortunately not. We work in the somewhat older building next to it, which is Guy's Hospital, and we're located on the fourth floor there. So greetings to everybody. But just to give you some context to where we're coming from. Anyway, in the next hour or so, I just wanted to give you a sort of a cook's tour of HPV testing in head and neck cancer, and I've subtitled this "The Why, How, and When of HPV Testing in Head and Neck Cancer." The why is somewhat easy. We know why, because since 2017, with TNM8, cancers of the oropharynx have been subdivided into those that are HPV mediated and those that are not. And they have different staging systems. They have different staging systems because they have different prognosis and probably soon to be different treatment options. And following on from the TNM8 classification in 2017, the new WHO classification, which has come out online earlier this year and hopefully coming out in print early next year, WHO 5th edition, have separated HPV associated from HPV independent squamous cell carcinomas of the oropharynx. So at least for oropharyngeal carcinomas, we are supposed, both for classification and for staging, need to undertake HPV testing. This is data from our own center here at Guy's and St. Thomas's Hospital. I've already mentioned that prognosis separates out HPV positive from HPV negative cancers. So these are post-treatment oropharyngeal squamous cell carcinomas that have been followed up for a period of 5 years. And you can see that in HPV positive cancers, we've got a rough sort of overall survival rate of about 90%. So 90% survival after 5 years. In contrast to HPV negative cancers, these patients only survive, on average, about 50% of them only survive on average after 5 years. So prognostically, This is very strong. In fact, HPV status is probably one of the most powerful prognostic indicators in head and neck cancer. Just bear with me 1 second while I adjust slightly the. There we are. Great. But this only relates to cancers of the oropharynx. The oropharynx is that bit which is at the back of the mouth, the bit of the tongue that faces the pharynx, the tongue base, the pharyngeal part of the tongue, the palatine tonsils, the uvula, the posterior pharyngeal wall, and part of the lymphoepithelial tissues, sometimes of the soft palate as well. So when it comes to HPV testing in head and neck cancer, I suppose in most centers nowadays, we're obliged to undertake HPV testing if we diagnose a squamous cell carcinoma arising from any one of these anatomical structures in the oropharynx. But just bear in mind that there is a global variation for those oropharyngeal squamous cell carcinomas that are HPV positive. Its highest prevalence is that in North America and parts of Western Europe. Apologies that the area of Bosnia is somewhat diminished there, but it's reasonable to say that this is one of the medium prevalence countries in southern Europe. But there is a great variation in the prevalence of HPV in oropharyngeal carcinoma. So HPV testing being mandated in oropharynx carcinoma is largely driven by colleagues in North America and Western Europe. This is a coronal slice through a tonsil squamous cell carcinoma. HPV positive oropharyngeal squamous cell carcinomas arise from the reticulated crypt of the epithelium. And this is highlighted here quite nicely because you can see that the surface non-keratinizing squamous epithelium is largely intact. Underneath it, in this sort of ramifying network, is where the carcinoma has developed. It has taken origin in the reticulated crypt. A higher power view, just to emphasize the point that often there is no or little surface dysplasia in HPV positive oropharynx squamous cell carcinomas. These cancers, at least in their early stages, tend to be submucosal and can be often missed just on plain pan endoscopy with visual inspection. That is not to say that as they grow, they don't colonize the surface. They may do that. They may ulcerate. They may go and extend onto the surface, and this is where you might be able to biopsy them. Okay, so those are some of the points to remember in terms of the origin of HPV positive oropharyngeal squamous cell carcinoma. Well, how do we test for HPV? I put this slide up for some of my undergraduate teaching just to remind everybody that DNA makes RNA, RNA makes protein, protein interacts with other protein, both in a forward and backward direction. And you can test HPV at any one of these points. You can test HPV DNA, high-risk HPV DNA. You can test it at the RNA level. You can test it at the viral protein level, or you can use one of the downstream proteins that are induced by viral oncoproteins, a surrogate protein. To test at the DNA level, we can use standard PCR or real-time PCR, or more frequently for us histopathologists, in situ hybridization for DNA. At the RNA level, we can use RT-PCR or in situ hybridization as well for the RNA. Occasionally, we might want to use immunohistochemistry directed at the viral oncoproteins. Now, we're not quite there yet in terms of specificity nor sensitivity for looking at viral oncoproteins. That's still in development, so we can't test directly. But we often test for a surrogate protein of HPV oncoprotein expression. So these are our options, and I'll go through them in terms of their advantages and disadvantages in a little while. Just a very brief one slide. I'm told by my virology colleagues that this is a highly simplified slide, if you can believe that, of how HPV induces cancer. You have the common HPV oncoproteins E6 and E7, and they have lots and lots of interacting pathways that act on downstream tumor suppressor genes to suppress them or activate oncogenes. But don't get too bogged down with this busy slide. I just want to highlight the fact that somewhere in amongst that is P16, and P16 gets overexpressed in certain situations directly because the HPVE7 oncoprotein sequesters the RB tumor suppressor gene. RB tumor suppressor gene releases the E2F transcription factor, and that induces the expression of P16. Under normal circumstances, once RB is degraded and recycled, it then binds back. There is a negative feedback loop. But if RB is sequestered, P16 gets accumulated and expressed, and that's how P16 becomes overexpressed. So if we go back to our previous chrono slice through this tonsillar tumor and superimpose P16 on it, you can see how it highlights rather nicely the HPV-induced, HPV-associated oropharyngeal squamous cell carcinoma while preserving the surface epithelium. So P16 is highly useful as a surrogate protein for active viral oncogene expression. Some more representative photomicrographs of P16. It really has to have both strong and diffuse nuclear and cytoplasmic expression of P16 as demonstrated here. A few more slides here just to show the tumor highlighted by P16, whereas the surface stratified squamous epithelium remains negative. Highlights the more undifferentiated carcinoma cells while preserving the tumor infiltrating lymphocytes in this sort of lattice-like network, and yet more cystic changes in the neck metastases can also be tested by P16. I find P16 to be highly useful, not only in terms of a surrogate protein for HPV detection, but also diagnostically in tissue sections, because that can be quite tricky sometimes. In this case, a patient presented with a carcinoma of an unknown primary. And on panendoscopy, with diagnostic tonsillectomy, no tumor was detected, and yet the PET scan still showed an avid signal in the tongue base. The tongue base was sampled on first instance, and nothing was detected, no carcinoma was detected. And so the surgeons went back into the theater and took much deeper biopsies, and this is what I had. And so we have, a slight ulcerated surface, skeletal muscle, the compound glands of the base of the tongue, and crushed islands of epithelium, which I found quite difficult sometimes to distinguish from metaplastic. Remember, this site had already been previously operated, so there was a bit of squamous metaplasia of ducts, and I really couldn't tell really when this was crushed, whether this was tumor or metaplastic ducts. And so a P16 was really useful. It highlighted islands of this atypical squamous epithelium that was carcinoma, but the more metaplastic areas of the ducts was negative. In resection specimens, in small resection specimens, in transoral robotic surgical specimens, where there is often crush artifact, where epithelium is stretched and pulled, morphologically on the H&E, it can be almost impossible to say whether that's normal epithelium, normal reticulated crypt epithelium, or tumor. And in these instances, I find P16 to be very useful. This diagram just highlights the fact that P16 sort of sits in between its sensitivity and specificity between PCR and DNA in situ hybridization. It has really optimal sensitivity as a surrogate protein for high-risk HPV infection. Its specificity is somewhat less optimal. PCR is highly sensitive and I would argue oversensitive, therefore resulting in quite a number of false positive results, whereas DNA in situ hybridization on its own, although highly specific, lacks sensitivity. In other words, quite a high number of false negative results. So P16 is a nice screening upfront test as a surrogate protein for HPV positivity. which then begs the question, what is P16 positivity? And if you look at the literature from about 2007, where it was first, the gold standard was set, and in subsequent studies right up until 2015, the head and neck pathology community were using sort of different cutoffs, different levels, either 50% or greater than 50%. In some cases, a 1 plus, 2 plus, 3 plus, or some cases as low as 25%, and not really defining whether it was nuclear or cytoplasmic or both. And so there was a degree of heterogeneity in terms of what people were calling P16 positivity. And when I say P16 positivity in this context, I mean as a surrogate for high-risk HPV infection. So the consensus now, and that's filtering down into various guidelines, both the College of American Pathologists and the Royal College of Pathologists, is this definition for P16 positivity. Strong and diffuse nuclear and cytoplasmic staining in greater than 70% of tumor cells. In other words, something like this, which is a non-keratinizing squamous cell carcinoma also from the tonsil, would be negative because there just isn't enough strong and diffuse positivity. Similarly, in this squamous cell carcinoma, you would consider this as P16 negative as a surrogate marker for HPV positivity. Similarly, this again would be negative because it just doesn't meet the cutoff of strong and diffuse nuclear and cytoplasmic positivity. In our laboratory, we have an on-slide control, one that has been tested against the actual copy numbers of HPV, and we use that as a useful benchmark. Another example of P16 negativity, you wouldn't consider this as P16 positive as a surrogate for HPV. What about this? Well, looks like it's greater than 70% of cells, but the catch here is that it seems to be nuclear only and doesn't include the cytoplasm. I owe this slide to my colleague in Edinburgh, Dr. Brendan Conn, for highlighting the fact that sometimes nuclear only positivity is present. This again does not qualify for P16 positivity. I would regard this as negative for P16 as a surrogate marker for high-risk HPV infection. Just to highlight potential pitfalls. The normal reticulated crypt epithelium, as you can see here highlighted in this tonsil, has variable P16 expression. Just bear that in mind. And in the context of P16 testing in cystic metastases in the neck, again, bear in mind that some branchial cysts, lymphoepithelial cysts, developmental cysts in the neck does demonstrate patchy P16 positivity, sometimes reasonably strong, as in this case here. So those are potential pitfalls that's useful to remember when you are using P16 alone as a surrogate marker for high-risk HPV infection. And don't forget, it is antibody specific. The last time I checked, there was only 2 FDA or CE-IVD approved antibodies. The main one that I think that most laboratories use is the Syntec that's produced by Roche. Leica have come up with the, I think it's the, I can't remember the clone number, but the Roche E6H4 is what the standard is used, because bear in mind, these are 2 P16 stained oropharyngeal squamous cell carcinomas using different antibodies showing you very different results. You'd call this one positive, but no one would call that positive. So it's highly antibody dependent. So please do bear that in mind. So back to our P16 overexpression as a result of high-risk HPV infection. That's the mechanism. I'm going to superimpose that against a simplified diagram, another simplified diagram of a few selected pathways that go on in a normal cell, let alone a cancer cell. Just to show you that P16 is not, P16 regulation is by no means exclusive to HPV infection. P16 can be expressed in a whole host of other ways. high-risk HPV infection is just one of them. That's another way of saying P16 can be overexpressed by HPV-independent mechanisms. And that's an important point to remember. When HPV-positive oropharynx cancer was sort of just making its introduction into the community, we were deciding whether P16 was useful on its own. And so in our laboratory, we undertook a study which looked at the overall prevalence of this group of tumors, i.e., those that are P16 positive. Remember, P16 is highly sensitive against DNA in situ hybridization. Remember, that is highly specific but not very sensitive. And in our hands, about 10%, i.e., 1 in 10 P16 positive tumors was negative by HPV DNA in situ hybridization. So ours was about 10%, 11%, but across the pond in North America, in the early days at least, the highly esteemed head and neck pathologist Professor James Lewis, in his laboratory, it was slightly higher. It was about 1 in 5. So that's another way of saying that if you use P16 alone, you may miss between 5 and 20% of, I beg your pardon. If you use P16 alone, there is a possibility that you may be wrongly classifying up to 20% of oropharyngeal squamous cell carcinomas as HPV driven. In other words, there is a potential for there to be about a 20% false positive if you use P16 alone. But does it matter? Who cares? Does it work? Again, back in 2010, from Professor Lewis's laboratory, I think at that time in St. Louis, his point was, yes, okay, there is a subgroup of tumors that are P16 positive, but negative when you look for the HPV DNA, i.e. false positive. But in terms of survival, it doesn't matter because these tumors perform just as well as those that are P16 positive as well as DNA-ish positive. So it doesn't matter, just use P16 alone. That was what Professor Lewis was advocating in those days. But hot on those heels from this North American cohort, several other groups actually said, well, actually, not really, because in this Italian group, for example, they showed that the P16 positive but DNA negative patients actually performed more like the P16 negative patients. And soon after that, several other European groups, I think that's a German group, and I think it's probably another German group, said actually there is this halfway house of P16 positive but HPV DNA negative patients that don't do as well as P16 positive patients alone. And this is data from our center. We combined our data with those from Newcastle at the time. And in our hands, yes, the group that is P16 positive but DNA negative doesn't quite do as well as those that are P16 positive alone. Okay, so there is this halfway house, but again, the community is still trying to resolve it. I was just looking at this in preparation for this talk. In the early days, almost, well, not almost, but exactly 10 years ago, Professor Lewis edited the special issue of Head and Neck Pathology looking at HPV and head and neck cancer with a focus on controversial topics. And he, in a debate, proposed P16 alone as a standalone. So just use P16 alone, that's good enough. And he was very kind to invite us to rebut that, to put forward the opposing view. And there was this nice debate that was going on. It took 4 of us to one of Professor Lewis, so that probably says a little bit of the caliber of Professor Lewis's research and opinion. So where are we now? Well, 10 years later, the College of American Pathologists are still advocating that P16 alone is maybe not perfect, but good enough. And the College of American Pathologists, in their recommendation statement, said that additional HPV-specific testing, and you can do that by PCR or DNA, may be done at the discretion of the pathologist and or the treating clinician, or in the context of clinical trials. So our North American colleagues across the pond have still left that as an option, not mandated. And this again is reflected in the UICC and AJCC staging, because we don't stage this, strictly speaking, by HPV DNA. We stage these tumors according to P16 positivity. So at least in terms of staging, maybe not quite so in terms of treatment, at least in terms of staging, P16 alone is enough. However, on this side of the pond, we might hold a slightly different view. Because this is the recommendation from our National Institute of Health and Care Excellence, which was published in 2016. Yes, they say, use P16 on all squamous cell carcinomas of the oropharynx, and it's given you that 70% cutoff. But then went slightly further and say, consider. So in nice speak, you are mandated in point 1, but you are encouraged, I suppose, you're recommended to undertake it when they say consider. So consider HPV DNA or RNA in situ hybridization only on all those that are P16 positive. And then last year, our Royal College of Pathologists, and this data set was co-authored by Anne, amongst other pathologists. So thank you, Anne, for making this point and for investigating this data. Our Royal College of Pathologists actually states that that they recommend the implementation of HPV-specific testing in addition to the assessment of P16 expression in oropharyngeal squamous cell carcinoma. So to cut a long story short, I think our American colleagues say P16 positivity is enough, at least for purposes of staging. We say, well, P16 should be followed up by HPV-specific testing. And so this is the algorithm that we suggest. Any oropharyngeal squamous cell carcinoma gets upfront testing for HPV immunohistochemistry. If it's negative, the testing stops there, because remember, it's highly sensitive but not terribly specific. So if it's P16 negative, we can safely assume that it's going to be HPV negative. If it's P16 positive, we recommend following that up with an HPV specific test, either by PCR, DNA, or RNA in situ hybridization. Excuse me one sec. Just checking my time. Great, thank you. So in our laboratory, anything that comes to us as P16 positive, we then undertake HPV DNA in situ hybridization, and we use that on our automated Roche Ventana benchmark platform using their cocktail of probes. Their cocktail of probes includes pretty much most high-risk HPV DNA, most high-risk HPV subtypes, including the commonest one in head and neck cancer, which is HPV16. I beg your pardon, the most common one in oropharynx cancer, which is HPV16. The manufacturers provide on-slide control buttons using cell line xenografts with a high copy number, a medium copy number, and a negative. And so that's useful because sometimes there's quite a lot of artifacts. So we often benchmark ourselves against the negative so that we're not overcalling things. And these are examples of the staining pattern using DNA in situ hybridization on the Roche Ventana platform. The two main staining types, the diffuse nuclear stain pattern, where the whole of the nucleus stains a diffuse blush like so, in contrast to a more punctate or dot-like positivity using the same platform. In terms of head and neck cancer, in terms of deciding whether something's HPV positive or negative, it doesn't matter in head and neck cancer. The manufacturer suggests that the virus is in its episomal form when you have this diffuse pattern, whereas it's integrated in this punctate pattern. In terms of stratification, treatment de-escalation, staging, it does not matter. And very often you find a combination of both in oropharynx cancer. Remember, I showed you this island of tumor and the diagnostic utility of HPV. The same island showed this nice punctate positivity using DNA in situ hybridization. Quick note of caution, though. While P16 is reliable and reproducible and sensitive, in situ hybridization is a lot more fickle and often very focally positive. So I've put these three slides up, the H&E, the P16 of the tumor islands, and the DNA in situ hybridization. And you can see, hopefully, that while this island is positive both for P16 and the HPV DNA in situ hybridization, these other islands, at least in my eyes, at least in our threshold, was negative. So these would have been false negative, because remember, although in situ hybridization is highly specific, it has suboptimal sensitivity. Just something to bear in mind. Yeah, especially on small or core biopsies. Nevertheless, DNA in situ hybridization still has a false negative rate, and sometimes the RNA in situ hybridization, because you remember there is always far more transcripts than there are genome copy numbers. In this case, it was an obvious non-keratinizing squamous cell carcinoma that was P16 positive. We did the DNA in situ hybridization, it was negative, and we thought, oh, this is one of those false positive P16 cases. Well, actually, no, it was just a bad run or a false negative on the DNA in situ hybridization, because it was positive on our automated RNAscope platform. In the next sort of half an hour or so, just allow me perhaps to indulge in a few points about HPV-associated oropharyngeal squamous cell carcinoma, which is now its own category in the WHO classification. I just want to highlight a few points which are quite novel in terms of how we as pathologists might go about reporting this. And so, thank you, Anne, again for this seminal work that I think is a bit of a game changer, which is our Royal College of Pathologists data set for histopathological reporting of cancers of the oropharynx and nasopharynx. And it's made some significant changes compared to the previous edition, which was I can't remember now, probably 2011, I think it was, so a good 10 years ago. We have moved away in grading oropharyngeal squamous cell carcinomas really as poorly differentiated, moderately differentiated, and well differentiated in the area of HPV positive oropharynx cancer. And so now we categorize this as either keratinizing or non-keratinizing, and then there's this sort of halfway point, which is non-keratinizing with maturation or partially keratinizing. This is how we ought to be grading them, rather than the HPV positive cases, at least. This is a typical non-keratinizing HPV positive squamous cell carcinoma. This, on the other hand, would be one of those hybrid or non-keratinizing carcinoma with maturation. So although largely non-keratinizing, there are areas of more sort of prickle cell differentiation, a bit of maturation, and small islands of keratinization. One thing that I found really intriguing and also rather consistent in HPV positive non-keratinizing squamous cell carcinomas that do mature, they have this sort of inside out pattern of maturation, because you remember your standard your conventional HPV negative squamous cell carcinomas, if they keratinize, you have a peripheral basal layer and then they mature towards the middle, and so your islands of keratin, your islands of more differentiated cells, are usually towards the center of these islands. In HPV driven cancers, if there is maturation, it's towards the outside. You can see how these are maturing towards the outside, and yeah, similarly here you can see how, if they do mature, it's sort of what Professor Lewis calls inverse pattern of keratinization, like so. So you almost have a basal layer in the middle and a maturing layer on the outside. Something to look for, a little curiosity. HPV-driven oropharyngeal carcinomas may also be basaloid. They may be adenosquamous, or they may be adenocarcinomas. At the moment, we think there is no prognostic differences between conventional non-keratinizing and one of these other variants. They should be still considered to be treated in a similar way. Not so if they have any neuroendocrine differentiation. Very occasionally, HPV-driven carcinomas of the oropharynx may be neuroendocrine in origin or have a neuroendocrine differentiation. And if so, it abrogates, it overturns, it obviates any potential prognostic benefit. So if there is neuroendocrine differentiation, prognosis diminishes considerably. Excuse me. Right. Another interesting point, this time a non-core item in our dataset, is mention or comment on tumor-infiltrating lymphocytes, because both we and others have found that in oropharyngeal squamous cell carcinomas, where there is a dense both intratumoral and stromal lymphocyte population, that confers a better prognosis, as opposed to those that have a very poor lymphoid infiltrate, both in the stroma and in the tumor component. And this is a study that was led by a colleague who came over from Thailand as a fellow, who was working very closely with Anne, and Anne and I, together with this fellow, put together the study, and we showed that actually there is a high, a middle, and a low TIL category. Patients with high TILs do better than patients with low TILs. Right. One last point, very briefly, then, is just to make mention: we do not have a category for carcinoma in situ for HPV positive squamous cell carcinomas. There is no category for there is no distinction between invasive and in situ. So something like this, which looks like it's very superficial and perhaps in continuity and arising in the reticulated crypt, you may be tempted to call that carcinoma in situ, but both the College of American Pathologists and the Royal College of Pathologists in the UK do not make that distinction between one that is invasive and one that is in situ. Right. In the next sort of, I think I've got another sort of 20 minutes or so. Maybe we can touch on HPV testing in non-oropharyngeal cancer. Should we? Shouldn't we? Well, what about the prevalence? If you look at the literature, sinonasal, oral cavity, nasopharyngeal, laryngeal cancers, several groups have reported up to 100% of squamous cell carcinomas at these sites to be positive for HPV. But when you look more closely at the method, a lot of these studies have just used PCR alone. PCR alone. Using more stringent criteria, yes, there are certain carcinomas that arise in the oral cavity in the sinonasal tract, nasopharynx and larynx that are HPV driven, but the proportions are very low in comparison to the oropharynx. In our center, about 70% of oropharyngeal squamous cell carcinomas are HPV positive. So we already know that we are mandated, I suppose, to test for HPV routinely in oropharyngeal squamous cell carcinomas for purposes of staging. What about these other sites? Let's have a look at the oral cavity. Both our college and the College of American Pathologists suggest that there should be no routine testing for squamous cell carcinomas of the oral cavity. Epidemiological data looking at its prognostic value is a bit conflicted. Some groups have shown some prognostic benefit and others haven't. But I just want to mention this I wouldn't say emerging entity, but we've known HPV to be associated with oral epithelial dysplasia for some time, but I suppose it's becoming increasingly more recognized and more established. Because in the fourth edition, 2017, of a WHO classification under the section on oral premalignancy or potentially malignant disorders, oral dysplasia, there's mention of an unusual subset of oral epithelial dysplasia that qualify as severe dysplasia that are HPV driven. But in the most current edition, in the new edition, this came out this year, that's been taken out and put in a separate category. So now we have a separate category, a separate chapter in the oral cavity section under OPMDs and oral epithelial dysplasia of HPV-associated oral epithelial dysplasia. And I just want to make a couple of points about that while we're on the topic of HPV testing. This is, I suppose, a typical oral dysplasia that should sort of highlight the potential for HPV testing. So Professor Soon-Bik Wu in Harvard, I think, was the first to put the larger series together in 2014. And one of the many things she noted about this peculiar group of oral epithelial dysplasias as opposed to conventional dysplasias is the very brightly eosinophilic keratin layer. So it's orange keratin is something that should highlight your attention. But you can see even at this sort of medium power, rather bizarre cells, the abortive mitosis, karyorrhexis, isolated apoptosis, but these are not clustered. These seem to be quite spontaneous and quite, I suppose, random throughout the thickness of the dysplasia, still with a bit of background maturation. So randomly abortive mitosis and random karyorrhexis is typical of HPV-driven oral epithelial dysplasia. Another example here. So very high level mitoses, but still with a level of maturation. Bizarre cells, isolated apoptotic cells, karyorrhexis, and interestingly, a somewhat intact basal layer. So you can still see the sort of the cuboidal morphology of the basal layer, which would not have been present if this were a conventional dysplasia. Higher power view of these apoptotic cells or karyorrhectic cells, as Professor Wu describes them. Yet more examples, sort of bizarre mitoses. Sometimes you can see nuclear molding. I can't see any immediately here, but odd pattern of apoptosis that are not clustering, that go throughout the thickness of the epithelium, reminiscent of the cell cycle of the virus. Again, just to mention, sometimes you get this intact basal layer with these cases. Very bizarre mitotic figures, but again, rather isolated. Just running through these quickly, just as I mentioned before, sometimes you get rather pleomorphic cells or even nuclear molding, perhaps. These are some of the things that are much more rare, I suppose, in conventional dysplasia that should highlight your attention for you to consider it being HPV driven. So back to our previous slide, if we tested this for P16, we get this pattern of staining. Now, we can't apply the same criteria for P16 positivity like we did for the oropharynx. And I think the community is still sort of deciding what the appropriate P16 cutoff should be for HPV-driven oral epithelial dysplasia. So often you get this pattern that sort of stops short in the sort of the basal third, quite demarcated. Here again, it involves the sort of the basal 2/3 in most areas. Similarly here, the basal 2/3, and if we did our DNA in situ hybridization, it sort of co-localizes with our P16. Sometimes they occur over a longer stretch. Here's one case where there was a wide local excision for dysplasia following incisional biopsy. And if we did the P16 on the whole mount, you can see quite nicely how it co-localizes with areas of dysplasia. Now, one of the useful diagnostic criteria that has actually become a criterion in the WHO Blue Book is what we describe as sharp demarcation, sharp lateral demarcation of block positivity in P16 expression. So you get a stretch of strong and diffuse nuclear and cytoplasmic P16 positivity that just stops short immediately. And that's a useful diagnostic criteria. It's to do with the way the virus replicates and spreads laterally. Again, curiously, a degree of heterogeneity in terms of the expression of the DNA. Unlike the previous slide that I showed you, in some cases, you have this inverse pattern of P16 expressions, so strong and diffuse P16 expression that actually doesn't co-localize with the HPV DNA. This is sort of over the top. And so something like this would be more replicative infection. So we know here, for example, that the early genes, the oncoproteins, are expressed earlier on. So you got very low copy number of the DNA here. And once the virus replicates ready for shedding, you have much higher expression. So this is interesting. So what this tells us is that in some HPV-driven dysplasias, there is actually productive infection. The virus is being produced and shed, which raises the possibility of sort of auto-inoculation or infectivity. You often get skip lesions, like in this case here. So, block positivity, sharp lateral demarcation with long stretches of negativity. More examples here, both punctate pattern as well as more diffuse pattern, but in both cases, quite nice, sharp demarcation. Okay, so again, if you did the immunohistochemistry in our laboratory, we have access to immunohistochemistry against the capsid protein to suggest that it is productive. It doesn't often co-localize with your P16 or DNA-ish. So this is basically productive virus that is not detectable, where the early genes, the viral E7 is switched off, but the virus is being actively produced and shed. Just also to remember that these things do transform. Sometimes they go down cell redux, and sometimes they actually do invade and transform into malignancy. So just to round up and just to summarize this entity of HPV-associated oral epithelial dysplasia, back in the sort of 1980s and early 1990s, when there was a lot of HIV infection around, several groups have described this as coilocytic dysplasia or oral bonoid papillosis, oral Bowen's disease. Those terminology is now considered archaic and been superseded by HPV-associated oral epithelial dysplasia. The WHO have stipulated that PCR alone, without strong P16 reaction and supportive histopathologic criteria, is insufficient. So you can't just look at a dysplasia, conventional dysplasia, do PCR and call it HPV related. You need several criteria, including strong P16, sharp lateral demarcation, block positivity, as well as, importantly, your viral cytopathic changes as criteria. In the early days, when people identified this, they raised the possibility of HIV infection in the report. We're not sure what the what the correlation is at the moment. In our series, I think about 25 to 30% of patients with HPV-associated or epithelial dysplasia are actually HIV positive. So there's still that possibility. What do you do if it's previously been undiagnosed? I think that's something our clinicians should consider. We still don't know exactly what the malignant transformation rate is. We know that they do transform, but we don't know how often. And I suppose most importantly, we haven't developed a grading criterion like we have for conventional dysplasia. We haven't quite decided what mild, moderate, severe, high-grade, low-grade dysplasia is when considering HPV-associated oral epithelial dysplasia. So there we are with oral cavity. What about some of the other sites? What about larynx and hypopharynx? Well, if you look at the 2005 edition of the WHO Blue Book, there was mention about conflicting evidence implicating HPV-16 in anything between 3 and 85% of laryngeal SCCs. Well, that's a huge range, isn't it? Again, the reason for that is because people were not using standardized testing criteria. A lot of these 85%, I suspect, were just detected by standard PCR alone. Anyway, they thought that it had a minor causative role, or it may be incidental. And then in 2000 and when was this? This was 2017. Yeah, 2017. WHO said that it probably played a limited role, and they tightened up on their testing criterion, transcriptionally active, and suggested somewhere between 4 and 15% of cases. But in the most current edition, again, there's just passing reference to it to suggest that it has a minor role in dysplasia and a marginal contribution in conventional squamous cell carcinoma. So it's still, possible, but definitely routine testing is by no means recommended. But are there any instances where we might want to be testing for HPV in laryngeal squamous cell carcinoma? Well, I would suggest possibly. We have a series of patients who are young with no associated risk factors of smoking or alcohol consumption who develop conventional squamous cell carcinomas. And this is one case from our files where when we tested for P16, there was strong and diffuse positivity. Incidentally, an intact surface epithelium there with weak expression of DNA by in situ hybridization. So, several groups have then supported these findings. So a recent study here by this group, which looked at clinical and biologic characteristics of those laryngeal cancers in young and middle-aged patients with no associated risk factors, and suggests basically, well, there is a possibility that if you don't, not your classical older patient with a smoking and alcohol history develops a laryngeal cancer, it may be possibly that it is HPV driven. But nevertheless, routine testing is still not recommended for high risk HPV. The caveat, obviously, is in recurrent respiratory papillomatosis, where low risk HPV testing type 6 and 11 may be used, especially if our clinical colleagues are considering therapeutic vaccination. So I should mention really that I think low risk HPV testing has got very limited use in head and neck pathology, apart from where there is a suspicion of recurrent respiratory or recurrent laryngeal papillomatosis. What about the nasopharynx? Well, again, routine testing is not recommended, either by the Royal College of Pathologists or the College of American Pathologists. It is present in a subgroup of EBV negative patients, but it is by no means prognostic. In fact, there is no prognostic value because these patients perform just as radio responsive as those that are EBV positive. So we, going back into our files, we find patients who develop nasopharyngeal carcinoma that look just like EBV-driven cancers, the sort of the non-keratinizing undifferentiated type. In this patient here, the tumor was localized in the fossa of Rosenmuller. There was no evidence of any oropharyngeal involvement, so there wasn't nasopharyngeal spread from an oropharynx cancer. And this tumor was EBV negative, but HPV positive. And in our files, up to 17% of nasopharyngeal cancers are HPV driven, which is quite a high number. I suppose one thing to note is that EBV, Epstein-Barr virus, and HPV in nasopharyngeal context are mutually exclusive, at least in our hands, and other groups have confirmed it. And there is no survival benefit in comparison to EBV-driven cancers. You also might want to note that we live in a rather diverse population in London where lots of different ethnic groups are represented. EBV is strongly implicated in those from Far East and Southeast Asia, whereas HPV seems to be a lot more prevalent in those of the sort of the Caucasian population, at least in our files. Right, briefly then, what about sinonasal cancers? What about squamous cell carcinomas of the sinonasal tract? Again, neither the College of American Pathologists nor the College of Royal College of Pathologists suggest routine testing. But there is emerging evidence that quite a number of these are actually HPV positive, and there may be a prognostic implication. This patient, again, from our center, as you can see in both the sagittal and the coronal reformats, a tumor occupying pretty much all of the nasal cavity and the ethmoid complex, and this, in this case, had perforated the cribriform plate and gone and extended intracranially. So a rather aggressive sinonasal carcinoma, in this case a non-keratinizing squamous cell carcinoma, P16 positive and high-risk HPV DNA positive. Just one example here. At the time, we collected our cases and we thought, well, is there any survival benefit? And in our hands, all those HPV-associated sinonasal squamous cell carcinomas, we looked at the survival, and in our center at least, there was no survival benefit of defining HPV positivity in sinonasal squamous cell carcinomas. But other groups are showing that there was a benefit. And so we did a meta-analysis, and we used data from other groups and put our data together, and actually it did come out as favorable. And since then, a rather recent meta-analysis from last year showed pretty much the same, where there was a overall survival benefit of HPV positivity in sinonasal squamous cell carcinomas. I need to emphasize squamous cell carcinomas. And so here are a couple of statements from the most recent WHO Blue Book. Between 36 and 58% of non-keratinizing squamous cell carcinomas in the sinonasal tract are HPV positivity. Again, P16 alone is not useful. So it needs to be, more robustly tested. And I think this is an interesting statement. While single institution and large database studies have often shown better prognosis in HPV-associated tumors, the benefit has not translated in clinical practice. And I think that's probably because, as you well know, the sinonasal tract is rather diverse in terms of the histopathological types of tumors, a very heterogeneous group, rare cancers, non-standard testing, non-standardized treatment. So it's very difficult to get robust data. But I think watch this space, I think, is the answer when it comes to the sinonasal tract. I just want to finish off. I think I've got about 5 minutes or so. I just want to finish off with an interesting case study from in our center from about a couple of years ago. I think a 49-year-old patient presented with possible metastatic carcinoma, which they felt was centered in his parotid gland. This is the tumor here. There were multiple lymph nodes. They did a superficial, they did a total parotidectomy in continuity with a neck dissection, which showed bad disease, multiple metastatic squamous cell carcinoma in throughout all levels of the neck with extensive extranodal extension. And when we looked at it, it's your typical non-keratinizing squame with P16 positivity. And excuse the slide, it's a bit pale, but still positive for high-risk HPV DNA. But interestingly, usually when we find metastatic squamous cell carcinoma to the neck, they're usually in level 2. They usually, as a result, they often be the first presentation of carcinomas in the oropharynx. But this was a really rather odd presentation. Why would the epicenter be in the parotid? On panendoscopy, the oropharynx, sinonasal tract, larynx and oral cavity were all clear. And what we hadn't known at the time was that there was a previous history 6 months previously of conjunctival squamous cell carcinoma in the upper eyelid. So we managed in another hospital to get those sections and showed. So that's the conjunctiva on the top there. Very similar carcinoma to what I showed earlier, which was P16 positive and high risk HPV DNA positivity. And so having exhausted the upper aerodigestive tract and given you some of the recommendations, don't forget the conjunctiva as a potential source of HPV positive squamous cell carcinoma. And several groups have published on this. We don't know the overall prevalence of HPV in conjunctival intraepithelial neoplasia or ocular surface squamous cell carcinoma in this country. And I think that there is scope there for further study. In certain in sub-Saharan Africa, for example, it's a huge problem. Both the compound effects of HIV infection and ultraviolet irradiation, HPV-driven ocular surface carcinomas are much more prominent. So that's the overall summary. I hope I haven't gone through this too quickly, and I hope I haven't bored you. But I suppose this summarizes everything. Recommendation is for routine testing in the oral cavity. Testing should be at least by P16 for staging purposes. At the moment, our oncological colleagues do not de-escalate or de-intensify treatment based on HPV status outside of clinical trials. There are several clinical trials going on looking at whether we can reduce the escalation, reduce the dose intensity of radiation in HPV positive cancers, being as they have such good prognosis. I think ultimately we will end up reducing it because, as you well know, morbidity associated with the radiation is huge. About 10% of patients get osteoarterial necrosis. And I think eventually we will end up de-intensifying, de-escalating treatment in HPV positive cancers. In the rest of the head and neck, these are some of the routine testing is not recommended, but keep your eye out. Things develop quickly. I think I'll end it there and pretty much on time. In fact, I think I'm a couple of minutes ahead, so I will now stop sharing my screen.
Thank you very much. Thank you very much, Selvam, for this and the previous talk, as well as and previous talk. These were really great. I enjoyed them. I hope the audience enjoyed your presentations pretty much as I did. So there is a question from our colleague, Dr. Adela Cimic from New York. So thank you, Adela, for joining us so early in the morning there. Adela is asking about HPV-driven neuroendocrine carcinoma. Do you have a set of criteria to diagnose neuroendocrine HPV-related cancer? She asked, in other words, is there a percentage of tumors that needs to be positive, and do you require just one or at least two neuroendocrine markers?
Yikes. And do you want to feel this one?
Yeah,
Shall I? Yeah.
I can offer you the view from across the pond. I can offer you our view. We'd probably share the case, to be honest. It's very rare. I think we do require more than one neuroendocrine marker. And I think Justin Bishop and the crew over there keep throwing in more and more mutation analysis for these tumours. Bottom line is we wouldn't call it HPV positive without P16 and HPV. We wouldn't call it neuroendocrine differentiation without at least two neuroendocrine markers. Our basic panel for neuroendocrine would be CD56, synaptophysin, chromogranin, and NSE, neurospecific enolase. I find that NSE is really excellent in some tumours like olfactory neuroblastoma, so they're my preferred markers for that tumour, and would also find it non-specific in other tumours. So I think these tumours are incredibly rare. I think what would be good would be to have international panels. I think James Lewis is coming up with that idea now to try and agree what you're asking actually as to what would be considered the gold standard or best practice. And then perhaps we'll get a collection of these tumours from across the globe that we can look at with more secure diagnosis.
Thank you, and thank you very much.
Sorry, if I may just sort of underline that point. So I think I hope I didn't get across the fact that we would routinely undertake immunohistochemical testing for neuroendocrine markers in HPV-driven or non-keratinizing squamous cell carcinomas. We will be driven by H&E morphology. And so sometimes we see a carcinoma, we do our HPV testing, it's positive. The H&E features may suggest some neuroendocrine features that will trigger testing for neuroendocrine markers. We wouldn't routinely test for neuroendocrine markers in HPV-driven non-keratinizing squamous cell carcinomas.
But I think if I could just add, remember, Selvam, we had recently a very rare SNOC that was HPV positive. And that's very interesting. Do we care? Well, there's so few. In a series of about 5, there may be an advantage for the HPV positive one. But we're really looking at hen's teeth, and I don't think we have enough numbers yet to be secure whether or not HPV in those sort of tumours offer a prognostic advantage.
And again, just to highlight the point, in the oropharynx, once you have neuroendocrine differentiation, those patients are taken out of trial. They're not de-escalated. It's bad prognosis. They're not. No one would consider de-escalating in these patients. Yeah. So yeah.
All right. Speaking of grossing, Anne mentioned these large omega blocks. It's not widely available for many labs. How frequently do you utilize these omega blocks in a routine practice?
I'll just speak. I mean, we use them. When I first came 5 years ago to guys, they weren't using mega blocks, and that was a difficulty with processing. And a difficulty with technical ability to cut them, etc. So we did a deal. Our lab is off-site, and so what we had to do as a team was to get another processor, because processing these mega blocks takes a couple of days as well. And we had to do deals with our breast and prostate colleagues to get them processed. Now we do them on site. They're not prerequisite. They're very beautiful anatomical demonstrations. And to be honest, we use them because we can. We use them often. I probably take 2 or 3 from a larynx. I try to restrict myself for sort of one good mega block example from a larynx. And if you've got difficult commando procedures like in the maxilla where you're looking at a specific margin or a mandible, you might use them then. But they're not the be all and the end all. And if you have good photomicrography and you can document on your photograph where your small blocks are coming from, you can divide up a large block quite accurately into small blocks. I wonder if that's what the question is getting at.
Yeah, yeah. Thank you very much. Yeah. Speaking of P16, just a quick question. So you do immunohistochemistry. Which clone do you prefer? Which one do you use? Which clone for P16?
E6H4.
Okay. And you confirm that by in situ hybridization?
Yes. Yeah. So the E6H4 is the clone that is FDA CIVD badged, CIVD approved, and so that's the one that we should be using, and that's the one that's produced by Roche Ventana. If it's positive, we would then we would confirm for the presence of high-risk HPV DNA. In our lab, we do in situ hybridization. In other labs, they may do PCR or RNA in situ hybridization. If it's negative, ideally the testing algorithm should stop there. There's no need for HPV specific testing in P16 negative cases because if you do it, it sort of further confuses the issue. That's the recommended testing algorithm.
Okay. There is one more question from the audience. How do you differentiate primary versus metastatic squamous cell carcinoma in the parotid gland? History plus infiltrated lymph node in the parotid gland. Something else is helpful?
As always, a very good, thorough clinical history and examination, as always, I suppose, is absolutely prerequisite. And I
Yeah.
suppose, in one sense, it may depend on the size of the lesion, the extent on which any background lymphoid architecture is maintained in the parotid. Often, when it's enlarged, you get complete obliteration with extranodal extension is extremely difficult. So, and maybe Anne might come in and add to that. But I think very clear communication, very thorough communication with our with our clinical colleagues, thorough clinical examination. You might have to encourage them to exclude any primary cutaneous tumor. And imaging, including a full body PET scan, is how I would approach these things. And once all those have been excluded, and if you're left with nothing else, then almost by exclusion. I don't know if you have anything else to add to that.
No, it's just in my years of experience, primary squamous cell carcinoma of the parotid is very rare. So what springs to my mind is a skin primary first and foremost. I think I would exclude that first, and that's by clinical examination and PET scan, as Selvam said. And then, are you seeing a high-grade mucoepidermoid carcinoma? So therefore, you'd have to say, am I really seeing keratinization? Is it CK7 positive? Is there any other indication it could be metastasis from somewhere else, like the ear canal? So I would definitely look up the nose and in the ear, and before I would be jumping to the conclusion this is primary squamous parotid. That's all I wanted to say, really. As Selvam said, you'd look very carefully for something else and mucoepidermoid carcinoma before I would call it primary parotid.
All right. Thank you very much. Just let me check if there is more question. No more questions. The participant thanks for these answers, and I also acknowledge your great contributions in the first two sessions. So it's now time for short break, 15 minutes. So we resume in 15 minutes. Thank you very much. Thank you.
Thank you.
Thank you. There we are. Thank you very much. I hope everyone had a nice short break. I'll launch straight into the next session, which is a very broad overview of odontogenic cysts and tumors. Let me just move that out of the way slightly. There we are. Of odontogenic cysts and tumors, designed really with the sort of the generalist in mind, and by no means going into any detail. What I'd like to do in this session is just bring up a couple of important points that I hope may be of use for those of you working in the sort of the generalist context. So the first thing I ought to mention when it comes to anything in the jaws, and I suppose in the head and neck in general, in particular for odontogenic cysts and tumors, the definitive diagnosis for anything of cyst or neoplastic in origin in the jaws, the diagnosis always lies somewhere in between a good clinical history, a good clinical differential diagnosis, excellent radiological interpretation, and histology. And so at the very outstart, I'd like to say that under most circumstances, it is important to ascertain imaging to correlate that with the clinical impression before you pronounce on histology. Okay, so that is an absolute foundation for the approach to odontogenic cysts and tumors. When it comes to history, I had this one not too long ago from a valued colleague, and I thought it was an excellent way of presenting things. There was a mention of a tooth extracted 3 months ago with some swelling and pain prior to removal, and 2 courses of antibiotics. The swelling returned as soon as antibiotics were completed. Intraorally, they saw exactly where it was. The overlying mucosa was healing. They even described the radiological appearance of a large, round, radiolucent region extending inferiorly over to overlap the inferior dental canal. I thought, excellent. And what's more, they provided a clinical differential diagnosis of residual cyst or a dental abscess and enclosed radiographs. And so I've held this up as the epitome of the good clinical history and supportive clinical information. Sadly, what we often get is a very simple description, as in radiolucency, upper right Q, ASS with UE teeth, and very occasionally something like the cyst of jaw. And under these circumstances, I would exercise all of you to be highly cautious, to not be tempted to approach it without supporting clinical and radiological information, and if necessary, delay the diagnosis until you can get hold of the clinician, until you can get hold of some supporting information, because it just often isn't worth it to hedge your bets and over or undercall anything. I'm going to use the most recent WHO classification as the basis for this talk, but you can rest assured I'm not going to cover all these cysts of the jaws. I'm going to put this in a bit of a context. When you look at how common these are, the radicular cyst is by far the most common. This is followed by the dentigerous cyst and then the odontogenic keratocyst. Just by way of introduction, radicular comes from the root word root, radix. And so when we talk about a radicular cyst, what we mean is that it is associated with the root of a tooth, the root of a tooth. A dentigerous cyst, by definition, though, is one that is associated with the crown of an unerupted tooth, the crown of an unerupted tooth. And so if you haven't got this information, so it's very basic information, you may be caught out. You may be calling something a dentigerous cyst, even though it's associated with something that's fully erupted, and by definition, that would be wrong. Trust me, I've made that assumption on a couple of times, only to have to backtrack afterwards. I'm not really going to cover too much by any way of detail the more rarer cysts, because as you can see, they are considerably rare. I will touch on the lateral periodontal cyst and the glandular odontogenic cyst in the context of a case presentation at some point. So, remember I mentioned radiology. This is the classical example of a radicular cyst radiologically. Unilocular radiolucency associated with a root of what we used to call a non-vital tooth, a tooth in which the nerve and the pulp within it has died off, usually as a result of dental decay or caries, or as a result of trauma. In this case, the crown having been completely decoronated and gone. You can imagine how the pulp within this tooth has undergone necrosis to cause the development of this inflammatory cyst. Typical example, unilocular uniform radiolucency. The radicular cyst is the bread and butter for pretty much most oral and maxillofacial pathologists. We see, 2 or 3 a day usually. And the most common tooth associated with the radicular cyst is the upper lateral, the number 2 tooth, the upper lateral incisor. That probably is, I think, is because it's the smallest tooth in the jaw, where the pulp is the most frequently affected, the tooth in which the pulp dies most frequently. A whole mount view of a typical radicular cyst. Very often it has a cinder cortex, it is a fibrous cyst wall, and in most instances, especially those which are more acute, a very dense inflammatory cell infiltrate within the wall. Not necessarily visible on this low power image. The epithelium is that of a non-keratinizing stratified squamous type. In the context of inflammation, the epithelium undergoes hyperplasia, typically what we often refer to as arcading hyperplasia, but all the while non-keratinizing on the whole. They can occasionally keratinize, but we'll deal with that in a little while now. In the cyst wall of any odontogenic cyst associated with the epithelium are often what we identify as these little hyaline bodies, beautifully eosinophilic structures that are the products of odontogenic epithelium, sometimes referred to as hairpin in shape. When you see this, you know for a fact that the epithelium associated with the structures is of odontogenic origin. It is by no means specific for any type of odontogenic cyst. You get them in radicular, dentigerous, or keratocysts. You may occasionally also get them with certain types of odontogenic neoplasms, but I just highlight it because it is specific for odontogenic epithelium. More examples here of this sort of concentric, brightly eosinophilic structures, what we call hyaline bodies or Rushton bodies, after Professor Martin Rushton, who first described them, I think. Okay, you may also occasionally hear about a residual cyst. A residual cyst is essentially a dentigerous cyst, I beg your pardon, a radicular cyst. A residual cyst is essentially a radicular cyst in which the cyst persists despite the removal of the tooth. So you can imagine a tooth being present there, where the cyst developed, the tooth has been extracted, but the cyst was not enucleated and continued to grow. Okay, so really, that is all I wanted to say about the most common odontogenic cyst, the radicular cyst. By contrast, the dentigerous cyst has to occur surrounding the crown of an unerupted tooth. That is the definition. And therefore, it is most commonly associated with wisdom teeth, the lower third molars, because these are the ones that are most commonly impacted, the ones that are most commonly unerupted into adulthood. And you can see this again, unilocular, well-defined, corticated radiolucency that attaches to the crown of the tooth, attaches at the junction between the crown and the root, what we call the cemento-enamel junction. That is another defining criterion. Again, in adults, sometimes with crowded teeth, the canine teeth get buried, and here you have an unerupted tooth with this unilocular radiolucency. Very, very rarely they get removed in situ with the tooth. This rather cute tooth root sticking out with the cyst surrounding its crown. And on slicing, this is another case, the cyst wall attached to the junction between the crown and the root, between the enamel and the cementum. A decalcified section, naturally, because enamel is almost all mineralized tissue. On decalcification, almost none of it is left over. Occasionally, you get a bit of enamel matrix, that's organic matter. But you can see here the tooth in situ and the cyst wall attached to the cemento-enamel junction. Those are the definitions of a dentigerous cyst. Ideally, the dentigerous cyst should be bilaminar, and I might be able to mention a little while why that is. A bilaminar structure of cuboidal non-keratinizing epithelium. Sometimes it matures to become stratified squamous, on the whole non-keratinizing, and depends on whether there's inflammation in the wall. If there is inflammation in the wall, obviously this will proliferate. More long-standing dentigerous cyst lining may, again, like I say, occasionally stratify, but tend not to keratinize, like so. The problem with a lot of odontogenic cysts is one of inflammation, because inflammation in the wall obscures any important morphological features in the epithelium. And I've got a couple of interesting case studies to highlight why that is an issue. But you can see the difference in the bilaminar epithelium in comparison to a much more proliferative epithelium in the context of inflammation. So here's the first point, the first important point I want to sort of implant in your minds. Inflammation obscures any diagnostic clues. So be aware of over or undercalling anything of odontogenic origin in the jaws that is associated with inflammation, because tumors can look like cysts and cysts can look like tumors in the context of inflammation. We need to know about the odontogenic keratocyst because it is important, it's relatively frequent, and there is a high recurrence rate of approximately 60% in some series. Those of you who have been following the story of the odontogenic keratocyst will remember that back in 2005, the WHO decided to change its name. It for a while was no longer a cyst but a tumor. It was for a while called the keratinizing cystic odontogenic tumor, or the KCOT. And some colleagues still hold on to this terminology for various reasons. But ever since 2017, the term odontogenic keratocyst has now reverted back to odontogenic keratocyst. We no longer talk about the keratocystic odontogenic tumor. And this is why it's important to always view the radiology. And I would say two things, if you have access to radiology, if not a radiology colleague, is to look for multilocularity and or root resorption, because those are clues that usually take it out of the radicular or dentigerous cyst category and put it into either keratocyst or tumor category. And so here we have the most common site of the odontogenic keratocyst, the body and ascending ramus, a multilocular radiolucency with some root resorption of the teeth. The locularity may not be always visible or obvious, but here we have a degree of scalloping. So some of my radiology colleagues will call this a pseudolocular lesion. But any appearance like this where you have a little lip, you almost have to be highly suspicious of considering this to be a radicular cyst. It is usually something else. And keratocysts can grow quite large. So here we have on the left-hand side in the premolar region, extending all the way up to the contralateral sigmoid notch almost. So a huge cyst with multilocularity. And these things grow, and one of the clues in the way it grows is that it tends to follow the long axis, the lines of least resistance in the jaw. Now, there are always exceptions to the rule, but on the whole, odontogenic keratocysts do not expand considerably, but they erode longitudinally along the mandible. Again, not absolute, because one could argue that radiologically, this feature also could do for an ameloblastoma. But the ameloblastoma would have expanded in a buccolingual or mediolateral dimension much more prominently than the odontogenic keratocyst. So another useful clinical or radiological clue. Our surgical colleagues may mention thick white keratin, or sometimes they might mistake keratin for pus, and they may include that in the pathology request form. The cavity of an odontogenic keratocyst usually contains nice, dense, thick lamellar ortho or parakeratin. Here is the textbook photomicrograph of an odontogenic keratocyst. When it's uninflamed, it's very difficult to mistake it diagnostically for anything else. It has typical features of a parakeratinized surface, luminal surface, which is corrugated, as in corrugated iron, and a palisaded basal layer. Now, my esteemed colleague and mentor, Professor Morgan, would always also say, look out in odontogenic keratocysts for vertical orientation of the suprabasal cells. That's another key feature of an odontogenic keratocyst. Vertical orientation, like so. Often, the lumen will be much more thickly filled with lamellar keratin and flakes of keratin than in this case. So typical features are of a corrugated parakeratinized surface epithelium, palisading of basal cells. If you look close enough, some of these palisaded basal cells may show a reversal of basal polarity, and I'll discuss the importance of that in a little while. A more higher power view. Interestingly, the odontogenic keratocyst, again, grows in a different way to a radicular dentigerous cyst. It doesn't grow like a balloon, hence the multilocularity, and it can be explained by this various sort of infoldings of the epithelium. And that is one reason why it has such a high recurrence rate, because you can imagine if these cysts are enucleated, it is easy to enucleate in that plane, leaving behind some islands of epithelium. Throughout this talk, I want to sort of pepper it with several case studies, which I'm hoping would highlight pitfalls in the diagnosis of odontogenic cysts and tumors. Starting with this one, which came from a 30-year-old male. And on the request form, we were told that it was a well-defined lesion in the maxillary antrum, communing with the oral cavity with draining pus. That should have been a clue for me, but I think at that point, at least, I did not have any radiology to hand, and it was difficult to track it down. Now, surgical colleagues will often do an incisional biopsy to prior to deciding on how to manage this radiolucency in the jaw, because there are mimics. So cysts, generally speaking, can be enucleated, but most tumors might need a sort of a minor oncological procedure with a degree of normal tissue surrounding it, a small resection. So colleagues will often send a small specimen as an incisional biopsy to help them decide whether to enucleate or resect this lesion. This is the total amount of tissue that I had on this incisional biopsy with the millimeter scale here on the right. On higher power view, obviously there was a cyst wall, there was this rather non-specific stratified epithelium that was essentially non-keratinizing, but a rather dense inflammatory cell infiltrate within the wall, chronic inflammatory cells in the wall, and acute inflammatory cells within the epithelium, making it a rather wispy. I chased down the radiology to find that there was an unerupted tooth that had been displaced, an unerupted upper wisdom tooth with this radiolucency surrounding it like so. So in my estimate, I said that this was consistent with an inflamed dentigerous cyst, because I knew there was an unerupted tooth, I knew there was a radiolucency surrounding it, and there was inflammations. Inflammation may have obscured the lining of the tooth. It was essentially non-keratinizing, so I signed it out as consistent with inflamed inflamed dentigerous cyst. It was enucleated, and this was the incisional biopsy, and this was the enucleated specimen. And even at this low power, you can see that the epithelium is a lot more well defined. And under higher power, lo and behold, a typical odontogenic keratocyst with its corrugated surface parakeratinized epithelium and palisaded basal layer and its typical infoldings. And I'm going to put the enucleated specimen, a representative slide, against the incisional biopsy, and no one is hopefully going to argue that they look very, very different. Okay, they look very, very different, highlighting the point that any inflammation obscures the morphological features of cysts and tumors of the jaw. So be careful. Here is the junction, if you like, between the typical odontogenic keratocyst and a rather non-specific hyperplastic non-keratinizing squamous epithelium. You can imagine if you were just given this bit on the biopsy, it would have been impossible to call it an odontogenic keratocyst because of the inflammation. Another point to remember with the odontogenic keratocyst is proliferating islands within the wall. This can be somewhat alarming sometimes, and it can be somewhat dense, but is allowable in diagnosis of odontogenic keratocyst. So here, top right, you see part of the lining of the odontogenic keratocyst with inflammation in the wall and plentiful islands, sometimes of budding small islands of odontogenic epithelium with maturation. Don't necessarily always get too alarmed by this. This is not a feature of neoplasia. We are allowed, even in the absence of inflammation, to have proliferating islands of bland odontogenic epithelium within the wall. If odontogenic keratocysts are multiple, your surgeons may already know it, but in case they don't, you may have to raise the possibility of a syndromic patient, the Golin-Goltz or nevoid basal cell carcinoma syndrome. I won't go into any details, and it's available in any standard text. Usually, if it comes as multiple odontogenic keratocysts, bilateral in the mandible or bilateral in the maxilla or both in the maxilla and the mandible, I think we ought to raise the possibility of further investigation to exclude the Golin-Goltz or nevoid basal cell carcinoma syndrome. As a quick aside, there is this entity which is a very close relation to the odontogenic keratocyst called the orthokeratinized odontogenic cyst. It's more rare than the odontogenic keratocyst, and in the past it used to be called the orthokeratinized variant of the odontogenic keratocyst, the orthokeratinized variant of the odontogenic keratocyst, because we have noticed for a long time now that where it is orthokeratinized like this, i.e. there is no preservation of any nuclei in the surface keratin layer, and you also have a bit of hypergranulosis here. These cysts have a much lower recurrence rate compared to odontogenic keratocysts. So, simple enucleation results in less likely chance of recurrence of the orthokeratinized odontogenic cyst. So let me just clarify. The orthokeratinized odontogenic cyst is a close relation of the odontogenic keratocyst, but with a far lower recurrence rate. So if you see orthokeratinization with hypergranulosis, consider the orthokeratinized odontogenic cyst. This entity, the lateral periodontal or the botryoid odontogenic cyst, is interesting and important to note. Its most frequent site is in the mandible, in the premolar region, and this is its typical appearance where it occurs high up in between the roots of the teeth in the premolar region. So it's not at the apex of the root, and it's not surrounding the crown of an unerupted tooth. It's somewhere halfway house. And typically, these teeth on either side tend to be vital. So again, vitality status, i.e. whether or not the pulp within this teeth is alive, is important in deciding whether something, in deciding to call something developmental or inflammatory. Let me clarify. It is not possible to call something a radicular cyst by definition if it is associated with a non-vital tooth. Here are examples of the lateral periodontal cyst, typically non-keratinizing stratified epithelium, but with periodic plaques of bland epithelium that are sometimes aggregated into these rather beautiful whorl structures. So whorls and plaques should raise the possibility of the lateral periodontal cyst, and the lateral periodontal cyst has got a close cousin called the botryoid odontogenic cyst, which is essentially a multilocular variant of the same. Now, important to recognize these because there is a slightly higher chance of recurrence within these within the lateral periodontal and botryoid odontogenic cyst, and it also has a degree of similarity with another entity called the glandular odontogenic cyst. The glandular or sialo-odontogenic cyst has similar features of those periodic plaques and thickenings of whorls and often is multilocular. In addition, it has, if you like, true ductal structures, because if you stain these, it'll be positive for secretory mucin. The important issue with the glandular odontogenic cyst, despite, in addition to its multilocularity, is its propensity for recurrence and therefore requires a bit more radical treatment. And the perceived wisdom in the WHO is that if a diagnosis of glandular odontogenic cyst is made, then the surgical management would necessarily involve sacrificing a tooth on either side of the lesion in order to ensure complete excision. On that note, another case study, please. This time, all I had on the request form was multicystic lesion anterior mandible. No doubt there was an incisional biopsy, and most of it was, composed of just bland fibrous tissue, a very thinned cortex. And at this view, you can just see a bit of epithelial lining just there, a slightly higher view of the epithelial lining with an extremely thin cortex, and this rather elegant cyst lining, even at this power, of cells with cytoplasmic clearing, but no doubt some luminal structures like so. Yet another higher power view of cytoplasmic clearing, which is not unusual in a glandular odontogenic cyst. And I did the Alcyon blue PAS. Every pathologist has their favorite stain. I think for me, the Alcyon blue PAS is in my top 5 of favorite stains. I just like the colors. But in this case, it just highlighted the fact that there was a definite secretory element, so a definite glandular element to the epithelium. In places, it was ciliated, like so. All criteria that are allowed for the glandular odontogenic cyst. It was keratin 7 positive and keratin 19 positive. Keratin 19 is a very useful antibody for helping to support the odontogenic origin of epithelium. By no means absolute, but helpful. And I remembered my own maxim that never sign anything out before reviewing the radiograph. And so I got in touch with the surgeon and said, can I have a copy of the radiograph? And unfortunately, this is what they sent me, which is, I suppose, next to useless because I didn't know what all these grainy things were. I wondered if that was the surgeon's boot print. I don't know. But you could just about make out a rough, irregular lucency in the anterior mandible. Not terribly helpful. Anyway, I hedged my bets and I signed it out as being consistent with the glandular odontogenic cyst. Surgeon then decided that enucleation and curettage was the appropriate form of treatment. And the curettage specimen was like so, a lot more remodeling bone and a lot more sort of background fibrous tissue. Parts of which started to get a little bit more organized, like so. A non-keratinizing stratified epithelium with a tendency in places to have a little bit of irregularity at the luminal surface. Elsewhere, islands infiltrating the cyst wall like so, definite luminal structures, and even at this power view, you can identify definite mucus cells in places and a bit of lining, but starting to get a little bit worrying with islands infiltrating the cyst wall. More cell clearing, reminiscent of some salivary tumors, luminal structures with secretions. Elsewhere, I started to see islands of epithelium that had a squamous or epidermoid morphology in places. And even worse, this tumor was definitely infiltrating bone in places. So what I thought initially was a glandular odontogenic cyst was in real life a mammal 2 translocated, card-carrying, primary intraosseous mucoepidermoid carcinoma. And so that was the final sign-out diagnosis. Interestingly, in the WHO, these are the comments. The glandular odontogenic cyst may show similar features to a central mucoepidermoid carcinoma, and this must be considered in the differential diagnosis. Well, that's the take-home point of this case. the glandular odontogenic cyst is generally considered to be negative for mammal 2 gene rearrangements. Now, this is a bit controversial. However, recent studies have shown rearrangements in these lesions that meet the histologic criteria for glandular odontogenic cyst. These may have been central mucoepidermoid carcinomas at the outset. So I suppose there is a growing school of thought that the glandular odontogenic cyst may be at one end of the spectrum of a primary intraosseous mucoepidermoid carcinoma that ought to be considered. I think the more we test for the mammal 2 translocation, the more we will find that the so-called glandular odontogenic cysts are positive for the same. So there we are. Right, that's all I really wanted to say about cysts. Let's move on to odontogenic tumors. And I don't want to frighten you, but this is the long list of accepted WHO odontogenic tumors. Another mentor of mine, Professor John Eveson, who was key in the 2005 edition of the WHO Blue Book, used to remind me how rare some of these odontogenic tumors was. He said when they were writing what used to be called the dentinogenic ghost cell carcinoma, in the epidemiology section, it went something like this: 50% of this entity occurred in the maxilla, the other one didn't. So that just puts some sort of context to how rare a lot of these odontogenic tumors are, and that's useful to remember. If we do a pie chart of benign odontogenic tumors, at least, this doesn't. The malignant ones are even more rare than this. This is the distribution. So the odontomes are by far the most common, or is the most common, followed by the ameloblastoma. And most people would actually argue that the odontomes are no more than hamartomas. And so if we exclude hamartomas, this is the distribution of benign odontogenic tumors. If we just take the ameloblastoma and the odontogenic myxoma, we already account for more than 45% of tumors. So this is helpful to contextualize. So I suppose with anything, just remember, if you're thinking along the lines of a benign odontogenic tumor, first ask yourself, why is this not an ameloblastoma, before you start considering the others. I have not got much time to go into it, but for those of you wanting to venture into the world of odontogenic tumors, it always pays to spend a few minutes just going through the histology of the normal development of the tooth, because in a lot of odontogenic tumors, these features are recapitulated. For example, when we talk about stellate reticulum, or ameloblasts, or the dental papilla, the reversal of nuclear polarity, these are all recapitulated to greater or lesser degree in odontogenic tumors, both benign and malignant. A typical ameloblastoma, the important features being a palisaded basal layer, a reversed of basal nuclear polarity, in other words, the nuclei stand away from the basement membrane. My colleague, Professor Odell, always used to remind me to look for a well-defined basement membrane layer, which is another interesting feature of an ameloblastoma. When there is reversal of basal polarity, the cytoplasm often gets vacuolated. And importantly, an abrupt, now this may alter according to plane of section, an abrupt transition to a suprabasal stellate reticulum-like morphology. So stellate reticulum is nothing more than basically cells which are loosely cohesive, like so. Apparently, it's reminiscent of this area here, the stellate reticulum. Diagnostic features of the ameloblastoma. But there are ameloblastomas and there are ameloblastomas. There is a trend amongst our surgical colleagues to introduce more conservative management of these tumors, and in some cases, I'm sure that's correct, because as you well know, ameloblastomas may grow to such a frightening size, and the more we can do to limit surgical management, the better. And so there is a trend away from oncological approach to ameloblastomas to a more sort of enucleation benign management. So enucleation, decompression, marsupialization are starting to come into vogue in ameloblastomas because it's far less mutilating. Two things to remember about that is a lot of ameloblastomas are slow growing. So a 5-year follow-up period or even a 10-year follow-up period is probably insufficient. So surgery isn't successful until you follow that patient up for about 10 years. But the second point is ameloblastomas, conventional types, although they may be histologically indistinguishable, may have a variable growth pattern. In this instance here, it is sort of respecting the bone. It hasn't sent islands into the marrow spaces in these two examples. There's a clear line of demarcation between the tumor, however large, and the bone. Whereas in other cases, ameloblastomas, conventional types, may be highly infiltrative into bone marrow spaces. So one could argue that something like this may be amenable to more conservative resection, where something like this would probably need a more oncological procedure. Okay, so this is something that we might need to keep repeating as pathologists to our surgical colleagues, that it really depends on what type at the infiltrative front before you decide on the best way to manage. Also, a lot of the time, the ameloblastomas can look a lot more cellular. It can lose its stellate reticulum-like morphology, and ameloblastomas in the maxilla tend to have this more solid appearance, not much by way of typical stellate reticulum, and you can expect and allow a degree of multilayering and a slightly increased nucleocytoplasmic ratio of the basal cells in more solid ameloblastomas. The point here being, don't overcall these as malignant. Allow, especially in the maxilla, for more solid areas. The unicystic ameloblastoma is an interesting entity. There are several types. The luminal type, which is no more than a cyst, where the neoplastic odontogenic epithelium is confined to the luminal surface of a unilocular unicystic radiolucency. Okay, so there is the luminal type, where it just affects the lumen, and this is an example. Now, these entities are really tricky, and I find this probably one of the most challenging areas in odontogenic pathology. Not much by way of solid islands of odontogenic epithelium within the wall. A typical odontogenic, unilocular ameloblastoma would have this lining. You can see a subtle palisading of the basal cells in this region here. You see that? And somewhat reminiscent of stellate reticulum in here. Loosely cohesive cells often being shed into the lumen. And attempts as well at vague V-shaped rete processes are some clues. All, and I can't emphasize this enough, all in areas that lack an inflammatory cell infiltrate. If this is associated with inflammation, it really is non-specific. Look out for cells we call parachute or umbrella cells. These cells that that are shed nuclei and all into the lumen. These are clues of ameloblastoma lining. Again, the sort of V-shaped pointed rete processes like so. And these are typical ones where you can get hyperchromatic basal cells. Palisading and reversal of nuclear polarity, not so subtle, not so obvious, and no one really would argue that looks anything like stellate reticulum. But in this instance, the radiology was paramount because there's this rather marked resorption of the roots. And so, you wouldn't call this a radicular cyst with that degree of root resorption. This becomes very tricky because all this are, if you like, variation on a theme. So is this the lining of a unicystic ameloblastoma? I've been a bit selective and a bit naughty by taking areas that resemble other areas. Here, for example, inflammation with inflammatory cells within the epithelium, a vague resemblance to this one on the left, but no, you can't really call that with any confidence because of the inflammation. Likewise, in this instance, these two photomicrographs are those that have come from inflamed dentigerous cysts, just highlighting the point that how these can sometimes mimic the lining of a unicystic ameloblastoma. This one here, a bit more stellate reticulum-like morphology. So this is a long way of me saying um, this is a huge pitfall. The lining of a unicystic ameloblastoma being undercalled as dentigerous or radicular cyst, a huge pitfall to be aware of. There is the intraluminal type of the unicystic ameloblastoma, where more solid islands grow into the lumen. Both the luminal and intraluminal type can be enucleated, i.e. conservative management, no need for oncological procedure. And then there's this halfway house of the mural type, where you have luminal components, you have intraluminal components, and then the tumor puts buds of epithelium within the wall of the unicyst. My difficulty is, where does the wall end? So here's an example of what initially I thought on whole mount was a unicystic ameloblastoma, intraluminal type. You can see how islands of epithelium are growing into the lumen. But on higher inspection, on higher power, you can see islands being put off into the cyst wall. So, mural type. But the question is, where does the wall end? What if it lies somewhere there? And so this is probably the most controversial area, the mural type. In 2005, the WHO had two categories of the unicystic ameloblastoma, the luminal stroke intraluminal and the mural. In 2017, the mural type, for reasons I've just mentioned, was sort of taken out temporarily, at least, and sort of a suggestion that they should be regarded as more conventional ameloblastomas, i.e. enucleation is inappropriate. And there's the statement that says whether mural involvement should remain a more aggressive subtype of unicystic ameloblastoma or reclassify as conventional ameloblastoma requires further study. And so the further study in 2022 didn't help much. We still have three subtypes, and a passing reference to the mural unicystic ameloblastoma appears to be intermediate between unicystic and conventional. So that's a long and short way of saying that really you can call something a unicystic ameloblastoma, but be careful when you see islands in the wall. You may only have a small representation of it, and there is a chance that it may be masking more conventional ameloblastoma elsewhere. Time for another case study to highlight another pitfall. A 42-year-old female, and on presentation, a cyst in the region of the lower right number 4 tooth. And all I had at that point was some information that previous surgery at this site. And the clinical working diagnosis was that of a residual radicular cyst, the lower right 4 having been removed. This was the attempt at enucleation. So a fibrous cyst wall, you can see the lining of the epithelium, quite a lot of inflammatory cells, some foreign body type reaction there, suggestive of communication with the oral cavity. Very nondescript, wispy appearance to the cyst lining here. A bit of shedding into the surface, but nothing by way of stratification, let alone palisading of the basal layer. And typical, this was typical of the rest of the specimen. Elsewhere, there was a little bit of hyperchromasia and loss of intercellular cohesion. I suppose a little bit of umbrella cells, but certainly by no means areas of palisading or reversal of basal polarity. Hunted everywhere, and typical elsewhere is this sort of appearance. Maybe a little bit of hyperchromatism, the odd mitotic figure, but certainly nothing to suggest that this would qualify as the lining of a unicystic ameloblastoma. And so I noted this at the time, a little bit of vacillation, but I thought on balance, look, the surgeons thought this is a residual cyst, they've enucleated it. It might be a bit perverse of me to call it a unicystic ameloblastoma. And I went along the line of, yes, it's consistent with a inflamed odontogenic cyst, i.e. a residual cyst. Unbeknownst to me at the time, because the radiograph wasn't provided, this was its radiographic appearance. That was the area just there. There was resorption of the teeth on either side, but not only that, there was a degree of multilocularity. You could see several other smaller islands on each side. A cone beam CT image highlights these multicystic areas. There was perforation of the cortex in that area, and certainly this really doesn't look, let alone sound like, a residual radicular cyst. At that time, having been furnished with this information, I would certainly not have called it consistent with inflamed odontogenic cyst. 2 years later, the lesion had grown to this sort of appearance, definitely multilocular, further resorption of roots, and expansion now to include that number 6 tooth. This was biopsied, and undoubtedly a conventional ameloblastoma. I just draw your attention to this area just here. You see that? There was a large cyst associated with this conventional ameloblastoma, as they do. In the past, used to be called the solid multicystic type. And all I had was biopsy from that region. None of this was sampled. So that's a huge pitfall that I unfortunately fell into. Elsewhere, a conventional ameloblastoma with your peripheral palisading and reversal of nuclear polarity. So this was an ameloblastoma. So just bear in mind, when you're looking at a cyst, look for signs and histological signs of ameloblastoma. They can be masked by inflammation, but the radiograph was of absolute importance at that diagnostic stage. Recent developments in the world of ameloblastomas have come to the fore. Again, my colleague at our institution was one of the first to be part of a collaboration to describe the BRAF mutation in ameloblastomas. In up to about 65-70% of conventional ameloblastomas have the consistent V600E mutation, which makes them targetable. The melanoma drugs that you get for targeting BRAF mutation V600E. And there is huge interest at the moment for using BRAF inhibition or MEK inhibition, at least in a concomitant or neoadjuvant setting for the management of ameloblastomas. And this article in 2007 in JNCI, an interesting case report where systemic BRAF inhibition shrunk this large mass without any need for surgery at that time to this much smaller lesion. So, they measured the dimensions and they estimated about 70% tumor shrinkage. Now, this was then much more amenable to a conservative excision. So huge interest at the moment of BRAF inhibition treatment, at least as part of the treatment of ameloblastomas. And in our institution now, it's almost reflex testing. Every time we get an ameloblastoma, we send it off for V600E mutation analysis, because that then becomes part of the multidisciplinary team discussion on whether shrinkage prior to surgical excision may be useful. Just very briefly, in the next few minutes or so, just to allow time for questions, I just want to highlight the second most common benign odontogenic tumor, the odontogenic myxoma. Really bland and not terribly photogenic. This is a tooth with the normal dental pulp overlying a myxoma, which is just here. And the point I'm making is that it looks just like dental pulp, bland, hypocellular, myxoid tissue that sits in a sea of myxoid glycosaminose glycans that is highlighted by the Alcian blue. This is a typical appearance of the odontogenic myxoma. The main differential of the odontogenic myxoma is basically developing tooth. Remember, the developing dental papilla, or the follicle of a developing tooth, or the myxoid neurofibroma, also found sometimes in the mandible. Those are the two main differential diagnoses. It does cause root resorption, and typically in the sort of parallel-sided, almost intersecting bits of bone resorption. And radiographically, this gives the sort of the tennis racket appearance to the lesion. And the point I want to make with this slide is that the lesion, if you like, oozes between the trabecular spaces of the bone at the advancing front. In other words, it cannot just be scooped out because it does permeate in between trabecular bone to replace the marrow spaces. There is a new kid on the block, which I won't spend too much time with because I suppose it's extremely rare, called the adenoid ameloblastoma. I think it's probably going to be the most controversial area in the next, in the current classification, the most recent classification, because I expect in time that this will be considered a variant of ameloblastoma. But it was given a separate category, mainly to highlight it to diagnostic pathologists, but also to highlight the point that it behaves in a more aggressive fashion. And this is a typical example. It has this typical cribriform appearance, reminiscent of salivary tumors, like so. Areas of epithelial holes. We said that this is reminiscent of the enamel not developing tooth. And you get areas which look like ameloblastoma, the peripheral palisading, etc. A significant proportion of them have induction of dental hard tissue, what we call dentinoid. When you think of dentinoid, think of osteoid that mineralizes, and it's dentinoid because it preserves the tubules of the odontoblasts. So it's pre-mineralized dentine essentially. They can have ghost cells, and the long and short of it is that it has overlapping features with a whole host of other odontogenic tumors. I just mention it because it's a new entity that you may come across in time. I've got a few more minutes, and I just need to mention the problems with the ameloblastic carcinoma. Difficult to diagnose primarily, and I quote the WHO here, because the threshold for diagnosis of malignancy is poorly defined. In other words, the cutoff for a ameloblastoma that's solid, that's a bit more aggressive, from that of an ameloblastic carcinoma is very, very blur. The WHO stipulate that you need at least moderate cellular or nuclear atypia. Well, that's highly subjective as well. You need increased mitotic activity. Again, that's subjective because what is the cutoff per high power field or per square millimeter? Another subjective field of increased nuclear cytoplasmic ratio, hyperchromatic vesicular nuclei, crowding of basal cells, and expansion of the basal compartment with disordered polarity. I find this probably the most useful. Expansion of atypical cells into the sterate reticulum, and probably most helpful is the presence of necrosis. Okay, bear in mind, extension into mucosa or medullary space infiltration do not distinguish benign ameloblastoma from ameloblastic carcinoma. So we can't use local invasion, as it were, to say that this is a carcinoma as opposed to a benign tumor. And this is true if it goes in the maxilla posteriorly into the infratemporal fossa or the masticator space or the pterygopalatine fossa. Just because it's invaded those spaces doesn't mean it's malignant. Oh yes, increased mitotic activity cannot define ameloblastic carcinoma. So you need an emphasis on identifying combination of architectural and cytomorphologic abnormalities. So here's an example of necrosis. Atypia, complete loss of stellate reticulum-like morphology with mitosis. And this multi-layering of the basal cells, like you see. So really untidy, crowded, loss of polarity presentation of the basal cells are helpful clues. So in summary, without exception, clinical and radiological features are essential. Inflammation can obscure diagnostic features, and beware of radiological and histological mimics of the ameloblastoma. And at that point, I think I shall stop. Thank you very much. Perhaps we might have some time for questions.
Yeah, waiting for Samir to come back in. Perhaps he was expecting you to. Oh, here he comes.
I had 11:05 is it was my sorry 12:05 UK time and 13:05 Central European time. So I hope I haven't run considerably over time.
You're muted.
Samir, you're muted.
Still muted, Samir.
Samir, you're
Oh, you
muted.
cannot hear me. Sorry,
Yeah,
I was
We can
muted.
now.
that's
Sorry.
right.
Thank you very much for this nice talk about odontogenic tumors and great images as well. There was a question from the audience asking about the use of immunohistochemistry when you suspect dysplastic changes.
I assume they're referring to um, um, the distinction between ameloblastic carcinoma and the benign ameloblastoma. I'm going to assume that for now, and I just essentially just highlight the point. I know that some people, look at proliferation indices, look at loss of cytokeratin 19, etc., in helping support the diagnosis of carcinoma over, an atypical ameloblastoma, a particular solid variant. But I just, at least in my experience, and maybe Anne, you can come in there. Although immunohistochemistry may be helpful, and we looked at some odontogenic tumors mimicking salivary type tumors. They may be helpful, keratin 7 and keratin 19. None of these, at least in my experience, are absolute. You need a combination of histomorphological features. In fact, histomorphological features are on the simple H&E is the most important in distinguishing an ameloblastoma from an ameloblastic carcinoma because we know increased activity. We don't know what the cutoffs are. So perhaps loss of cytokeratin 19 may be useful within the context of other histomorphological features. Is the only instance I can think of. But there may be others. I don't know. Have you any thoughts, Anne, about use of histochemistry?
My knee-jerk response is whenever I see a tumour that I'm worried about, I do a proliferation marker. The problem with the odontogenic tumours is they've often been in decal. And your immuno may be unreliable, number one. Number two is if they've had inflammation around the teeth, if they've had a previous biopsy, there are all factors. And I think what Selvam said with the first what's it called, Selvam, diagrammatic abstract, where you had that Venn diagram, and it's the combination of radiology, combination of clinical suspicion, and your histology. So I think we often ended up what I would call a weasel worded report saying, oh, it might be this, but it might be that. I'm a bit worried. And if it's a small cyst, you can advise conservative local excision. So it's all this about guiding your colleagues. And I have a very low threshold of showing it to Selvam and my other dentally trained colleagues as well, who have a lot more experience in the jaw cysts and tumours. So I would have a low threshold, especially in the age of digital photography and Teams like we're doing now. You could show people things on camera.
Yeah.
Yeah, just to support that, and I sometimes resort to phrasing things like no definite histological contraindications to enucleation,
Yeah.
that kind of thing. So, look, don't give us half a jaw. Maybe enucleation in the first instance for us to
Mm,
then rule out infiltrative violence elsewhere. So that's
yeah.
how I say it, and then leaving the option open for a revision following evaluation of the complete specimen. That kind of approach. Thank you.
Thank you. There is another question about use and utility of BCL2 in the case of odontogenic cysts.
Yes, again, distinction between those sort of loss of. Yeah, I'm aware of publications looking at BCL2
Mm,
in distinguishing um, those sort of inflamed benign odontogenic cysts, which have that mimicking of that loosening, loss of intercellular cohesion, um, that may mimic the ameloblastoma. Um, but I think until we have large-scale prospective studies, um, we tend not to rely on that too much. But I am aware that there are some colleagues
mm.
elsewhere globally who find it particularly useful. I would say yes, you can use BCL2, but again, as in a supportive capacity, but not in an absolute capacity.
All right, thank you. One more question about, do you routinely perform BRAF V600E analysis in case of ameloblastomas?
Um, in recent months, yes. Now, I think the I can't remember the MEC or the BRAF, the particular MEC or BRAF inhibitor that's been used. It's currently not licensed for use in ameloblastoma, but people have reported case series and case studies of shrinkages worldwide with striking improvement. And colleagues in Tel Aviv, in Israel at the moment, are leading the way in using that to shrink, using BRAF inhibition to shrink the tumor prior to a more conservative excision. Now, um, the short answer is yes. I know it's an expensive test. We are regularly requested to do the V600E mutation analysis by our oncological colleagues, especially in those large ameloblastomas. So, partly because of interest, partly in the way the UK health system is set up, where the costing is incorporated in the overall service. At the moment, yes, but I know not all units are. Have access to that, yeah, because we have an interest, and because our clinical colleagues have an interest. The short answer is yes.
Can I make a comment? There are two types of tests. There's the immunotest that they use in melanomas in skin, and then there's the genetic test. We tend to go for the DNA extraction and the genetic test.
Yeah,
I once had and if you've put your specimen in decal, you can forget that really. And
yeah,
then to the most extent. And then I had a case which was a very, very small biopsy where we were desperate to, it was a recurrence in a young person, and we were desperate to get the answer, where I sent it over for immunostain to be looked at by the skin people where they have experience in using the immuno. And that was on a biopsy that hadn't been decalcified. And I think it worked quite well because they came up that the answer was positive, and on a further biopsy, that was confirmed. So I think at the moment, I wouldn't go for immuno. I think it's
yeah,
unreliable, and I think
yeah.
we would find it difficult to interpret. So if you've got derm path colleagues, it might be asked if you're really stuck. And don't and if you're going to be asked to do this, don't use a decalcified biopsy.
I'm aware of a very recent Japanese study looking at the accuracy of immunohistochemistry for the detection of that variant in ameloblastomas actually, if I can get my hand on that, I might
Okay.
just pop it in the chat if I can,
Mm,
because they caution against it because there's too
mm,
high a false positive and false negative.
right.
Just relying on immunohistochemistry for the exact reasons you say, and the
Mm,
decalcification, the lack of
yeah.
validation, etc. So yeah,
Mm,
yeah. No, thank you for making that point.
mm.
All
Mm.
right. I don't see any more questions related to the odontogenic cysts, but there is one remaining question about larynx to N. It was the question about cases where radical laryngectomy was performed, and uh, the participant was asking you how, if you can explain in more details about the decalcification process of the specimen and for how long time the decalcification does take time, and about getting axial cuts that you shown in your presentation.
Okay, so the axial cut started a while ago with my mentor, Professor Leslie Michaels, who used a bacon slicer like they use in a delicatessen. And you can take off the hyoid bone, and you can actually use these bacon slicers or these meat slicers that they use in delicatessens. And we couldn't use that machine after the lab chief cut his finger on it. So now they say you have to decalcify the specimen. So as Selvam beautifully demonstrated in that the oral talk about the mandibles, etc., we have a 10% buffered formalin solution. We can use our bandsaw set at 5 or 4 millimeter intervals, and we can take our axial slices using the bandsaw. And those slices can be decalcified in 3 or 4 days. So if a larynx came in on the Friday, it could well be ready for the following Friday. In our minimum data sets from the college, they're saying those sort of specimens, you give yourself a 10-day or 2-week period. If you have to put the entire larynx into decal, it takes about a week. It takes about 7 days, 5 to 7 days to decalcify in the formic acid. And then you can cut it easily in axial slices. You might find the hyoid bone a bit tough, but you can disconnect the hyoid bone and ink the area and still do the axial slices. I think Selvam will agree with me, but we are spoilt because we've got the bandsaw. So the bandsaw decalcifies, those slices can be decalcified in a few days. I wouldn't
All
put it
right.
in nitric. Yeah, I wouldn't put it in nitric acid. That would take it down in literally 48 hours or something like that, but it would ruin the soft tissue and all your analysis.
All right. Thank you very much. I think you answered the participants' question. I think we are just perfect on time. It's here it's 3:15, European 1:15, in UK 12:15. I think we are just ready for a half an hour break with lunch break. So thank you very much. Thank you very much, and Salman, for great talks. And I hope we will continue in half an hour, which means 1:45 Central European time with the next sessions. Thank you very much, everybody. Thank you.
Thank you.
Thank you.
Okay, Anne, you're ready to go. If you could just click on that hide button, you know, the little, and then you're off.
Okay. Good afternoon again, everybody. You have me now for a couple of talks, and the first one I'd like to start with is about neck cysts in the neck, and differential diagnosis. So, as Selvam has stressed, and myself, when in head and neck, more than almost anywhere else in the body, clinico-pathological correlation is essential. So you need to get the clinical setting. So if you look at this list, in infants and children, malignancy is not going to be high on your list. But in adults, it's going to be probably the first thing you think of. And so in both infants and children, thyroid metastases is quite rare, but thyroglossal duct cyst is top of the list. So let's look at this clinical scenario. So a patient presents with a cyst in the neck. You have to think, how old are they? Where is it? And 90% are benign in children. And there's a mixture of congenital cysts, inflammatory, malignant is very rare, 11%, and others will be other things like infections or whatever. Now, in adults, 80% are going to be neoplastic, and 80% of those are malignant. So the most important thing not to miss is metastatic disease. And if you remember that when we talked about levels in the neck, 80% of Mets in the neck will come from head and neck cancers. So I liked this diagram. It's a fairly recent publication. So if you look at the geographic location of the cyst, it can really help you with the diagnosis. So you ask your clinical colleagues, where exactly is it? So a ranula or a mucus retention cyst will be in the region of the submandibular gland just below the mandible. A thyroglossal duct cyst is in the midline. A branchial cyst is medial to the muscle there. A lymphangioma would be more lateral. So let's look at some examples. So here's a branchial cleft cyst on the left, and you can see where that's situated, and a thyroglossal duct cyst in the midline of the neck here. So this is the area, level 2, you might think, in the neck, that you might be worried about a lymph node and a lymph node metastasis. And here, further down, just above the clavicles, you'd be thinking of thyroid nodules or cysts. So a thyroglossal duct cyst, you can see when they take this out, it's a benign lesion, a benign developmental lesion. They take a little scraping of the hyoid bone because the journey of the thyroid down into the neck passes just past the hyoid bone. So in your resection specimen, there'll be a little area of hyoid bone to which the cyst wall may well be attached. So this is the so-called cyst trunk procedure. So, you know, be careful and feel for the bone, because they ruin your sections if you leave it in for one point. And the second point is clinically, you can be able to assess whether this lesion is excised and there isn't any residual left, spilled out, if you like, around the hyoid. So it looks quite bland. It's often mucoid or colloid material within it. And the lining of the cyst may be just fibrous tissue that's inflamed. You may be easily be able to see the thyroid gland as here, or it may be more difficult and just be a few follicles. So here are the thyroid follicles. This is a very thin-walled cyst, convoluted outline. Now, when we look at the epithelial lining, and it's important to sample them very carefully and to look at the lining, because that way you're less likely to miss a cystic metastasis, for example. So the lining epithelium can be quite variable. It can be respiratory type with cilia, as you can see here. Also, if you are trying to find the thyroid tissue and it isn't as obvious as it is here, then you might want to use immunohistochemistry. But just looking at this, we've got respiratory epithelium, squamous epithelium, thyroid tissue in the wall. And TTF1 will be positive in a thyroglossal duct cyst lining, but thyroglobulin will be negative. So if you're worried about, say, a cystic metastasis from papillary thyroid carcinoma, it's important to do both stains, because a thyroglossal duct cyst will stain for TTF1, but it won't stain for thyroglobulin. And the thyroid tissue will stain for both TTF1 and thyroglobulin. So it's quite useful if you're looking for the thyroid tissue, but also to exclude a cystic papillary thyroid carcinoma. So, okay, we've looked at thyroglossal duct cyst. Now let's think about these lymphoepithelial lesions. And there's a list of those as well. So branchial cleft cyst falls into that category. But we also have to think about lymphoepithelial cysts of salivary glands, those in the floor of the mouth, other developmental or inflammatory cysts. And the most important things to exclude would be cystic salivary tumours, maltomas, HIV, and of course, again, the perennial metastatic disease. So this is a lymphoepithelial cyst, cystic hygroma, associated with babies and young people. So you can see that it's a translucent cyst. If you transilluminate these, even if you use the light on your mobile phone or a X-ray box, you can see that it's not turbid, it's filled with quite clear fluid. This all collapses down when you sample it. And you just get this convoluted cyst wall with some lymphoid tissue in the wall of the cyst. Clinically, this is what it looks like. There's the baby with the swelling in the neck, and on ultrasound scan, multilocular cyst wall. And this is it on MRI scan here, CT scan rather. You can see this multilocular cyst quite well demarcated in the surrounding tissue. So again, sorry about the fuzzy picture. You can see this lymphoid tissue and these vascular spaces. And some of those spaces will contain lymph fluid. But everything's bland, cytologically bland. There shouldn't be much inflammation unless it's ruptured and you have an inflammatory or foreign body response. And the architecture is quite characteristic. So this is our differential. And the scary thing is that metastatic SCC can look very like any other of these cysts, branchial cyst or lymphoepithelial cysts or a parotid cyst. It can all resemble, metastatic SCC can easily resemble these. And so you have to pay attention to the cyst lining and sample it very, very carefully. So again, there's a clinical presentation and an anatomical position to these cysts. So this is a young patient. You wouldn't necessarily think he's at risk of metastatic SCC, but in this clinical scenario, even if you see a bit worrying rough cyst wall and the outline is a little bit thick and thin, you wouldn't worry too much. And if you see this dense lymphoid tissue in the wall, well-formed germinal centers and mantle zones, The architecture of the lymphoid tissue is quite good, and the epithelium is fairly thin, and there is a very nice clean basal layer. Often, if I'm concerned about the basal layer or the lining epithelium, I'll do some markers. CK14 is quite useful. And here you can see there's absolutely no hint of an abnormal epithelial proliferation. So branchial cysts will have variable linings. It can be keratinizing, it can be non-keratinizing, it can be very, very thin, or it can be respiratory and ciliated. So the lining itself is quite variable, but what it is uniform. So branchial cyst epithelium, the contours may be irregular, but the actual epithelial basal layer is fairly uniform. When you start seeing thick and thin epithelium basal layers, irregular contours, you have to look carefully and on high power. If you're lucky, you might be able to see these malignant islands dropping off, but often you don't see that. And you may have to look at quite high power to see this dysplasia, if you like, and these rete and this deep disc keratosis. So Selvam has given you that really excellent summary of HPV and P16 testing. And this is a series of photographs to show a patient that presented with a lymph node metastasis long before the tumor recurred and showed up in the tonsil. So base of tongue and tonsillar HPV positive tumors often present as cystic metastases in the neck. You really need to look at that epithelial lining before you dismiss it as a branchial cyst. So you see that the cystic metastases will be positive for P16 for both P16 and HPV. So that's excellent. When you get this combination, you can be quite confident of an HPV-associated SCC, probably in oropharynx. But somebody asked the question, is P16 positive in branchial cysts? Do branchial cysts stain for HPV and P16? And the answer is that branchial cysts are P16 positive. But as Selvam explained, if you're really strict about the criteria, the nuclear and the cytoplasmic positivity for P16 expression, the 70% nuclear, strong nuclear and cytoplasmic positivity, you might get away with it. But you really should do HPV at the same time, because HPV is negative in branchial cysts, most definitely, and P16 can be positive or equivocal. So it's a limited role for P16 by itself. But if you do a combination of P16 and HPV-ish, you should be able to distinguish between a branchial cyst and a cystic metastatic SCC. But again, I keep harping on about this. There's nothing beats the clinico-pathological correlation. So if you have an upper lymph node involved, you'll think about metastases from the ear and the nasopharynx, posterior triangle, again, ear, temporal bone, and the lower ones, you would be thinking about upper esophagus, larynx, thyroid, etc. So pay attention in the MDT as to where the lymph node metastasis is presenting. So remember that the oropharynx, tonsil, tongue base are usually here around level 2 and 3. Okay, you can see this cystic metastasis here in the neck. So, okay, can we do this on cytology? Because the world is changing. So all you cytopathologists out there, you're becoming crucial to the management of patients. What you do is quick. It can be very accurate. And if you use your liquid-based cytology and make your cell blocks, you can even make the equivalent of a histological diagnosis. So here is a patient who presented with a lump in the neck, definite malignant on cytology. And in the cell block, they were able to do P16 immunostain and also HPV-ish. And nowadays, even molecular testing can be done. So our friend, Professor Lewis, looked at these. And also, we needed to ask, can we rely on HPV-associated SCC diagnosis made on FNA? And the outcome from this paper was, if you have the appropriate clinical setting, if you've got secure P16 positivity and HPV testing, then you can make a secure diagnosis of HPV-associated SCC on FNA. And another Dutch study said that FNAC biopsy cytology material can be reliably assessed to determine the HPV status of a tumour. So a metastatic tumour that's HPV positive, even if you can't see the primary, hints at a primary HPV positive tumour in oropharynx. There are some caveats in that some squamous cancers and some other tumours will be P16 positive. So you must do both HPV and P16. So this is metastatic SCC. It can look very much like a branchial cyst, but it's often filled with thick keratin rather than mucoid material. Again, it can be very cystic and the epithelial lining might be quite thin, but you look for these irregular outgrowths and this hyperplasia. And look at high power and you should be able to convince yourself that you can see invasive, highly malignant cells like the ones on the screen now with dyskeratosis and mitotic figures. You can often get lymph nodes that are clearly worrying on macroscopic examination, and you'd be worried here for extracapsular extension. And often the cyst, you get these very thick solid areas with this sort of almost dirty cystic areas. Often you'll be presented with a core biopsy, and that's all you'll get. You'll get if you're lucky, it will be radiologically guided. So a good core like this, you'd feel very confident in assessing and you'd be able to do your immunostains. But you can imagine someone going with a big cyst, fluid-filled cyst, the surgeon feels they can have a go and they just get out the cystic fluid and it isn't accurate for you to diagnose. And here's metastatic SCC, so that cyst lining may not be representative of what's deeper down. So adequate sampling is essential. You may have to do ancillary tests to confirm that it's actually squamous differentiation, so it may not look keratinizing. So I often use P63. P16 has to be strong and diffusely positive, cytoplasmic and nuclear positivity greater than 70%. Okay, so what about this other carcinoma of unknown primary? This doesn't look particularly cystic. It's big, it's solid. You would think of lymphoma first. And then you might get a biopsy that shows zonal necrosis and really no keratinization. Are you sure it's carcinoma? Looks a bit lymphoid. But if you do a combination of a pancytokeratin, some squamous markers, I would suggest CK5, CK14, that not only shows you the extent of the metastasis in the lymph node, it will help you make sure that it's carcinoma. And also, if you add on to that P16, HPV-ish, and EBER, that might help you say whether it's coming from the base of tongue or the nasopharynx. So nasopharyngeal carcinoma will be EBV positive, P16 and HPV negative, and an oropharyngeal carcinoma will be EBV negative. So the Spanish group are trying to ask us as the world to say whether can't we just standardize our approach. So let's agree on a panel, a basic panel, say pan-cytokeratin, CK7, CK20, S100, CD45 and Vimentin, to actually say what have we got in this lymph node when we're looking at a carcinoma of unknown primary. Can we quickly exclude lymphoma, melanoma, sarcoma? And if it's sarcoma, what category does it fall into in relationship to CK7 and CK20? And if we use another panel and then say, okay, extended immunopanels, even done on cell blocks from cytology, you might be able to give even more information. So effectively, you want two things. You want to say, where is this primary coming from? And how can I help the oncologist treat the tumor? So can I identify where it's from? And does it have a mutation profile that might be clinically targetable? And we should be able to do that even on FNA. So the recommendations would be probably best to get a targeted core needle biopsy. try and save one of the cores in liquid nitrogen if you can. Apply a basic standardized immunohistochemical panel. And then when you know which category the tumor is falling into, have a go at a more advanced immunohistochemical panel and molecular diagnostics to advise management. Okay, so let's go back to lymphoepithelial cysts for a little while, this time intraparotid or oral floor of mouth. You look at the epithelial lining, it can be a mixture, and you can look at the inflammatory infiltrate, and often organized into lymphoid follicles, but it can be mixed and diffuse. So here is an asymptomatic parotid lump, and you might say, okay, lymphoepithelial cyst. But when you start looking here, you see that it's not your average thin uniform lining, and it's actually quite mucoepidermoid-ish. And if you did the MAML2 translocation, it would be positive. So if you're concerned that you might be missing a Warthin-like mucoepidermoid carcinoma, consider doing MEC-MAML translocation analysis. This is really quite sensitive and specific for mucoepidermoid carcinomas. I think one of the out of the 36 was a lymphoepithelial cyst, and all of these others were these lymphoid-rich mucoepidermoid carcinomas. So this is a salivary lesion presenting as a neck mass. I got a core biopsy, tiny amount of tissue, but enough to do some immunostains. It didn't look squamous. It was almost granular cytoplasm, had a bit of an idea that it was an adenocarcinoma, was CK7 positive and S100 negative, and showed up the translocation ETV6 for secretory carcinoma. So there's a lot you can do with a core biopsy and cytology specimens if you have your wits about you. Okay, so remember also other tumors that can present as like cystic lesions in the neck, like schwannoma. You can see these beautiful verrucate bodies, these palisading cells, even in the core biopsy. Now, this schwannoma presented as a neck mass, looked very nice, S100 positive, not a problem. But when it was excised, it was a bit lumpy, and the cut surface was really worrying. So it looks well circumscribed on imaging, cystic, as ancient schwannomas can be. But when we sampled it, it was really quite worrying in areas, very cellular, zonal necrosis, pleomorphic cells with macronucleoli, multinucleate cells, lots of mitotic figures, S100 only patchy positivity, so the core must have caught an area that was quite positive, and P53 highly positive, Desmond positive, and it was actually an MPNST with rhabdomyoblastic differentiation. So keep your wits about you. They're quite rare. They do show up, and your differentials are synovial sarcoma, a cellular schwannoma, atypical neurofibroma, and of course melanoma. Remember, paragangliomas, they occur in the neck, can often be cystic, can be worrying for metastasis, but should show these lovely packets of zelbalin with the sustentacular cells. And this is neuroendocrine marker positive, low proliferation rate. And this is the only time we can call these malignant is when we definitely see them in the lymph node, because even vascular invasion and atypia, we don't worry. Malignant paragangliomas, young age of presentation, often rapidly enlarging and associated with pain, and often in younger patients. Okay, so I've come to the end of that race through cysts in the neck. I'd like to thank Bill Barrett for some lovely images he let me use. And thank you for your attention. And I'm going to come out of this presentation, stop sharing, and hopefully we can have a conversation or questions if you'd like. Okay. Okay. So I'm waiting for Jeff, I think, to bring in Samir. And hello, Selvam. Thanks.
Samir isn't online yet,
Okay.
so perhaps I don't know whether Selvam has had a chance to look at any of the. Oh, it's coming in now. So let's get in there.
Great talk about cystic lesions of the neck.
So they're quite. I think it emphasises what Selvam was showing as well. How difficult this can be. How you really do need to use HPV, P16, sample, and clinical correlation. Really important.
Okay. I didn't see any question from the audience for this
Fine.
presentation. Can you hear
That's
me?
fine.
Yeah. How frequently do you encounter in practice cystic metastasis
I would
in
say
the neck?
very often. I think we see them very often. Selvam is our Mr. HPV man, but we see oropharyngeal carcinomas that are HPV positive present very often. I haven't got all the figures. Selvam will have them at his fingertips in the neck as a big, often as the first presentation to the GP or to the ENT clinic. So we see them very often. We see core biopsies 1, 2 a week. We see them very often, and we have a setup where they are sampled by the radiologists because they're notoriously difficult. I don't know if you have any comments about the HPV, particularly the HPV ones, Selvam.
Absolutely. Just to confirm your point, I've seen it been reported in the literature that the painless swelling in the neck is by far
Mm.
the most
Yeah.
common presentation of an HPV positive oropharyngeal carcinoma, more common than any symptoms in the actual oropharynx itself, including discomfort, pain, etc. Greater than 50%. And I think also the whole HPV era was quite useful in that. When it was first an issue, it always pointed to the oropharynx, and we would guide the surgeons if we found an HPV positive carcinoma to concentrate their efforts in, particularly in the oropharynx, not exclusively, but particularly in the oropharynx. I think there was still a percentage of patients, weren't there, Anne, who were still HPV positive
Yeah.
cystic metastasis in the neck, for which on penendoscopy and blind biopsies were still
Yeah.
unknown primary. But then in the era of the robotic surgery with access to mucosectomies and more thorough
Mm.
sampling, the number of truly unknown metastatic
Mm.
HPV positive carcinomas is
Yeah.
reducing, on year
Yeah.
on year. Yeah.
So did you agree, with the Spanish study, Selvam? I think it's not a bad idea to standardize that investigation panel and to try and work with colleagues to get an extra core for molecular if we can. But it's
Mhm.
quite difficult when you get such thin material, it's difficult to let it go. But I think in the future, we have to be thinking about either liquid based cytology or core biopsy and one core to be put into the nitrogen for molecular in the future. I
Mhm.
think we have to be
Mhm.
thinking of an SOP along those lines.
Yes, definitely. And I think we have a carcinoma of unknown primary tumor board or multidisciplinary team meeting, where a lot of these things, molecular
Yeah.
investigations are becoming very important for diagnostic purposes.
Yeah. But I think we should try and get as far along as we can the diagnostic pathway to say whether we
Mm.
think it's lymphoma, melanoma, so it
Sure.
goes quickly down the right pathway, because otherwise it
Mm.
can get bounced between teams.
That's right.
So I think it'll come to us first. So we have a duty of care, to try and speed up the referral. Okay. So shall
Thank you
I?
very much. Yeah, can you proceed with the next about the bone and fibrosis lesions of
I
head
will.
and neck?
Yeah.
Thank you. Thank
Let
you.
me know when you can see my screen. I hope you can see my screen. Can you
Not
see my
yet.
screen? Not
Not yet.
yet. Okay.
Not
I
yet.
think it's, yeah. Okay. I think I'll go again. Share. share. Here we go. Okay, how's that?
Yeah,
Okay,
thank you.
excellent. So here we go. And this is my most insecure talk, I'm being honest. I've got Selvam, who is a complete expert about these things. But anyway, as a generalist, I thought it was only fair that as a generalist, I talk to you about it and give you my approach. And then Selvam can remind me where I've gone horribly wrong. So, okay, so fibroosseous lesions, as a generalist, they don't half look the same to me. They really look similar. And they share a lot of radiological features. So I can only stress again, they have to be diagnosed with clinical, radiological, and histopathological information. So in the current WHO classification, fibroosseous tumours and dysplasias, I'd like to start with, are classified as follows. Cemento-osseous, segmental odontomaxillary dysplasia, fibrous dysplasia, etc. So I'm not going to discuss all of these. A, I'm not qualified, and B, they're not so very common. But if I can direct you to a special edition I found particularly useful in head and neck pathology, there's some beautiful illustrations here, and it really gives you a very practical approach to diagnosing these things. So let's look at fibrous dysplasia. So first and foremost, it's benign and it's self-limiting. So this is telling you that you don't want to rush in to any treatment that's going to leave a young child disfigured or affect the growth plate of the bone, because if they can bear with it, it will stop after puberty, or at least become much more manageable. It's it's quite young people usually in the first 3 decades. It can be any bone, often polyostotic, and often, well, sometimes associated with McCune-Albright syndrome. There's a low risk of malignant transformation, and there is an association with the GNAS mutation on chromosome 20. So all of these things tell us if we can get fresh tissue for the GNAS analysis and send it off to our not exactly fresh but undecalcified tissue, the bone pathologist can test for this GNAS mutation. So these are the cafe au lait spots that you see in association with McCune-Albright's, this cafe au lait pigmentation. So the onset, as we said, is in young people. In the head and neck bones or the jaw bones, the zygomatic process of the maxilla is the most common. It's an expansile lesion, and the teeth are not displaced, resorbed, or exfoliated. These words indicate an aggressive process that you need to worry about a malignancy. It's often poorly defined, which is not a happy situation on radiology a lot of the time. But in this case, you won't see a clear delineation sometimes, and there may not be a clear margin. So you get the keywords on imaging would be ground glass. You get this ground glass appearing on radiology, and orange peel phases, if you like, as bone is removed and replaced. There's a loss of the normal bone pattern and progressive growth with expansion. And it can mature, but it does regress with skeletal maturity. So the actual immature bone with a lot of fibrous tissue can be replaced by bone which is mature and lamellar, and actually the disease process can regress. So let's look at case presentations, because it's more easy to put it in your mind. It's a progressive, painless expansion of maxillary bone. The patient will go and say, my face looks asymmetrical. My face is swelling. And when the dentist or the maxillofacial surgeon looks in the mouth, the palatal arch is disrupted. This is pushing down into the oral cavity. You can see it here, pushing the teeth apart. And it will make the side, sometimes the gingiva can bulge outwards. On radiology, you can see a change if you look at the adjacent cortex. So the bone, the trabecular pattern of the bone is different, and the teeth roots are not resorbed. So this is affecting the maxillary bone, and you can see how much of the maxilla, if you compare, it's always very good to compare the two sides. So if you look at this side compared to this side, you can see how expanded it is here again. And here you can see it's blended, but there's a fairly sharp demarcation here. You can see the mass lesion, and it doesn't appear to be aggressive going into soft tissue, but it is expansile, expanding the bones. So it's slightly increased intensity on T2 and slightly decreased intensity on T1. So there are radiological features that can help, and it's often polyostotic. For us on histology, we can see a rim of host bone. So we know that this is quite a respectful lesion. It's knocking on the door. It's not just blasting its way through. And there isn't any zones of necrosis. This is immature bone. This is the more mature lamella bone, which has been there longer and has changed its lamellae in response to gravity. So it's been there for a while. Here, the disease process has been a little bit more aggressive, so most of the bone is immature. You may or may not get active remodeling. Here you can see osteoblasts on the surface of the immature bone, but the background spindle cells are invariably bland. There's very little mitotic activity, and the osteocytes sitting in the lacunae are quite bland looking with nice navy blue nuclei. So that would be a diagnosis of craniofacial fibrous dysplasia. So it all sounds very jolly, but we need to be careful with this diagnosis. We can miss low-grade osteosarcomas. We have to make sure it fits the clinical picture, radiology fits, biopsy fits, and in some cases, does the molecular diagnosis fit? And then we can be secure. And if we're secure, you can actually delay surgery until the growth is finished. Try to be conservative. You can often recontour the bone that's affected, or at least the plastic surgeons and maxillofacial surgeons can. But if it affects the orbit and displaces that bone or the nose, it's quite difficult to put right. Sometimes people are given bisphosphonates, but there's an increase then of this medication related osteoradionecrosis of the jaw, or MRONJ, medication-related osteonecrosis of the jaw. It's quite a low risk of sarcomas, and if the area is irradiated, there's a higher chance that malignancy will occur. And those with the GNAS mutations are thought to actually have an increased growth prevalence. So I'm just going to show you now a fibrous dysplasia that really isn't very benign and is actually a very serious disease. This is a 27-year-old man, and he had a massive mandibular tumor and multiple additional skeletal abnormalities, and they thought to have manifested in early adolescence. So this sounds quite okay. Well, we think we'll have a small lump in the mandible, but when you look what this poor man had to cope with, there's this huge mandibular mass related to his dysplastic condition. And look at his limb bones. So this dysplasia, this genetic condition, gave him a terrible quality of life. And so these bones were they weren't strong enough to take his weight. There was no proper maturation or lamellar bone formation, and him and I think it was other members of his family were affected. And this is the so-called gnathodiphyseal dysplasia. It's associated with an autosomal dominant gene. So to go on to less dramatic situations, let's look at ossifying fibroma or cemento-ossifying fibroma and the osseous dysplasias. These are the ones that are going to be more likely coming across your desk. So again, we need a clinical setting. So the cemento-osseous dysplasias are going to be more common in African and Mongoloid races. They can be three types: localized periapical, a bit more than just around the root of the tooth and it's focal or in one segment, or florid, where it affects more than one region in the maxilla and the mandible. They're often asymptomatic, and they may manifest when the patient has a complication from a tooth extraction or it's a chance radiographic finding. So again, it's a dysplastic syndrome. So instead of proper bone remodeling, you get disordered fibrous replacement, if you like. And adjacent lesions can fuse together and form a mass lesion. So on radiology, tooth-bearing areas become patchily sclerotic. The teeth are usually not displaced, and the tooth roots are not resorbed. So it doesn't give any impression of malignancy. So normally they're not biopsied. Radiology is often diagnostic if it's done by a specialist, but it can be supported by histology. But again, without the radiology, the histology is not diagnostic because it looks like any other fibroosseous lesion. So here's a 41-year-old black female presented with what could be a periapical cyst or radiculous cyst. Again, this trabeculation in the bone is abnormal. And you can see how well demarcated it is. It's pushing into the cortex, but it's really quite well demarcated, and the tooth root isn't resorbed or displaced. Okay, here and here. So what it looks like is this. It sort of makes you think of fibrous dysplasia, but this isn't superb decalcification. But mixed in with that bone and fibrous tissue are hard tooth tissue as well. So here you can see it almost looks like fibrous dysplasia, but there is some other hard tooth type tissue, cementicles, if you like, mixed in there. Completely bland. There isn't much mitosis or few mitoses, and no necrosis. When it's florid, it affects more than one zone of the bone, and you can get absolute great islands of hard tooth tissue admixed with immature bone. So the differential diagnosis is periapical granuloma, old Paget's, or cemento-ossifying fibroma. And you'd think about infection. And the problem is that these people are prone to get infection and get cysts, especially after tooth extraction. So they'll be given antibiotic cover. But as I say, it doesn't often come across your desk. So the treatment, it's not really possible to treat it. It's conservative, and you usually try and avoid surgery if you can. But if you do need to do surgery, it often is quite extensive to get back to the normal bone. Okay, so now ossifying fibroma, again, almost fibroosseous, but within a different pattern, and again respecting the host lamellar bone. They're very unusual to occur in the midface, but when they do, around the orbit, they can displace the eye and the bone. So here is a young girl. It's often more females than males. It can affect the orbital bones. And again, you normally see a very well demarcated area with a sharp cutoff for the adjacent bone. So there are no malignant features, and there are certain intensity categories on radiology. What you see on a biopsy, again, is a sharp demarcation. If this is the normal bone, this is the sharp demarcation of the lesional tissue. And you can have a mixture of fibrous tissue with cementicles and ossicles and islands of trabecular immature woven bone and cortical bone. Again, you see great respect for it's an expansile lesion. It's not particularly infiltrative. And there may or may not be osteoblastic rimming. There often isn't. But the osteocytes within the bone are bland, and the fibrous tissue is bland. So it doesn't look like a malignant process. Again, it can be cemento-osseous with lots of these cementicles and these cymomatoid bodies. So this is where the classification comes in, cymomatoid, trabecular, juvenile, etc., because of the age. But all of the nomenclature you need to look up in the new WHO category. It's been described for many years, females more than males, young adults, usually second to fourth decade. And usually the presenting complaints are non-specific. If it affects around the cheek, the maxilla or the orbital bone, you might get proptosis and double vision, nasal obstruction if it's in the mid-face region. It's very rare in the mid-face region, and a couple of cases have been described in the middle turbinate. So again, the main differential, is it fibrous dysplasia, in which case the gene AS mutation might help, or osseous dysplasia? There are some radiological differences about the demarcation. Ossifying fibroma will be well demarcated, for example. Mutation analysis may help. Ossifying fibroma go on growing after skeletal maturity. So again, the genetics of the bone tumours are coming more to the fore. And I won't linger much on that. You can have a look at the next WHO classification and see how the mutation analysis has exploded. So the treatment is usually to try and take it out conservatively. Up the nose and around the eye, endoscopic techniques have been used. You don't usually radiotherapize young people growing bones. You increase the risk of malignant transformation by 400, but you can stop the growth plate and cause great asymmetry and bad cosmetic result. The site seems to predict how they behave. In little lesions in the mandible, you can probably take them out quite nicely, but you may have to do major surgery for the mid-face areas. So a little area like this could be easily handled and may well be more involved with mature bone. As you can see here, again, quite bland and mixed pattern. So cemento-ossifying fibroma, I'm aware of the time. So again, just the combination of the cementicles and the differentials, again, fibrous dysplasia, cemento-osseous dysplasia, meningioma. Just to show you a bone invasive meningioma, they often occur around the orbit. You can get big lumps, bone hyperplasia associated with it. So this is one of unknown duration, quite a big bony lump. And within the marrow spaces was the characteristic spindle cell tumor with the cell whorls, recognizable as meningioma. Completely bland cytology. They can be progesterone receptor positive, and bone invasion seems to downgrade the prognosis or upgrade the clinical suspicion for recurrence. So it's important to know about those. Again, osteoid osteomas can occur. This is quite a nice article describing an osteoid osteoma where that can be a biopsy for the nidus can be terrifying. But again, you have to get the clinical context, the radiological appearance, and look for the true malignancy, the permeation of pre-existing bone, which you won't see with osteoid osteoma. So quite rare, benign, and then just a complete canter through giant cell tumours. So giant cell tumours can be straightforward interosseous giant cell tumours of like you would get at other sites in the body. And these again will be radiologically well circumscribed. They'll respect the host bone, expansile rather than permeative. And they will be, they may entrap host bone, but they're not forming it. And you can see the well characteristic multinucleate giant cells. Commonest sites, sphenoid, ethmoid, and temporal bone that I've just illustrated. So differential is cherubism that you can see here, so-called cherubism because they look like Raphael's cherubs with these nice cheeks. But you can see this poor child had both quadrants of the mandible affected and needed a big excision to put her face back to normal again, respecting the host bone. Otherwise, on small biopsy, it's just a giant cell lesion. So you need to put the clinico-pathological correlation in place. So this is cherubism, and they got a very good result. This is some colleagues at Chelsea and Westminster Hospital working for Facing the World charity. They got a very good cosmetic result, I think, with that mandibular resection for this child. This is a case study that I'll finish on. This, for all the world, patient came in with an ulcer in the palate. We were worried about squame. She'd had a history of breast cancer. So the most we were worried about, could this be a metastasis from breast? Could it be squamous cell carcinoma? And sadly, it was rather a large tumour. And what we were seeing in the oral cavity was the tip of an iceberg of a tumour that was centred in the nose, actually, pushing itself down into the nasal cavity. Now, the biopsy was this, and as you can see, there's no obvious bone formation here. There's a lot of necrosis. And we thought we were dealing with a poorly differentiated tumor, possibly sarcoma. We spent a lot of money and did a lot of immunostains, and we thought it was Vimentin positive, negative for everything else, and possibly a malignant peripheral nerve sheath tumor. So we sent it for sarcoma, second opinion. And the sarcoma people said, we don't think it's sarcoma, we think it's your problem, malignant mixed tumor. So when it's our problem, malignant mixed tumor, i.e. epithelioid derivation, wide local excision. So this is a wide local excision for that lesion. So hemimaxillectomy, orbital exenteration, again, the 6 margins, top, bottom, right, left, front, back, and you can see the palate. And then when we slice through it, you could see actually it was forming bone. So we took our slices, as Selvam has shown you, and I hope I've shown you, and we could see this tumor filling the maxillary sinus, destroying teeth, really aggressive, just about creeping into the orbit. And it was unequivocally bone forming, and it was an osteosarcoma. And a case report in the literature showed a very similar diagnostic issue. Someone had presented with this tumor in the retromolar trigone, if you like, at the back there, similar sort of site. And again, lots of chondroblastic osteosarcoma. And you could imagine our resection specimen representing this CT scan here. Selvam is brilliant at putting those superimposed, but you could just imagine this case report superimposing our case. Well, that's extremely rare. So you have to have your wits about you. You have to do your clinico-pathological correlation. Better prognosis for tumours in mandible and for the chondroblastic type because they're less likely to metastasize. And gnathic tumours behave better than those in the craniofacial bones. So I think I can leave there now and stop sharing my screen, and maybe we've got time for questions again. It's a bit
Again,
of
we're
a
just
race
waiting
through. I
for
hope I haven't
some.
said anything too awful, Selvam.
Quite the opposite, Anna. Thank you ever so much for giving that really excellent broad overview, which I think sometimes is absolutely necessary, as you say, to put everything into context. And I can't but you know uh, you cannot underemphasize the fact that you need clinical,
Absolutely.
radiological, histological, and half a dozen other criteria, and they all need to sort of support one another, I think. And sometimes we can be quite prone to letting one particular feature trump everything else, and I think we have to be careful not to let that happen.
Mm,
We have to respect all the various
yeah,
um,
yeah.
modalities and
And
criteria. Yeah.
and I deliberately put that osteosarcoma case in because you and I worked on it together, number
Mm,
one. But number
indeed.
two, it was sent back to us by the sarcoma people. So that's the thing. You can be experts, but you can get it wrong. If you've only got limited samples, limited clinical information, because we as head and neck people felt it was sarcoma territory,
Mm.
and they as sarcoma people felt it was head and neck territory, and it wasn't until the thing was out in its entirety that we could tell what was going
No,
on.
and this is again right. So without knowing the full approach of colleagues, you can be led astray. So I
Yeah,
seem to remember there was some P63 positivity,
that's
there was a bit of
correct.
SMA
Yeah,
positivity, and
they
that
added
can
one or
sometimes
two.
lead you down a pitfall, and then suggest it's
Yeah,
myoepithelial in origin. So you have to be
yeah. And I
very,
think it's
very careful.
important, yeah, it's important to say that no matter how expert you think you are, you're going to fall into these pitfalls. And so
Mm.
sarcoma people applied their sarcoma immunos, and we didn't, immunos that we would have looked at for head and neck and maybe discounted became more important. It's easy to
Absolutely.
fall into the traps.
if I've got one more minute just to sort of
Yeah.
emphasize this point, at a recent meeting, which I think you might have been there in our London group of head and neck pathologists, a very esteemed colleague shared a case of something not too dissimilar. It was a cartilage forming maxillary tumor with obvious atypia, um, and on incisional biopsy, and it went off for a specialist osteoarticular opinion, and they performed molecular analysis, including GNAS sequencing, and there was that GNAS mutation, which was common to fibrous dysplasia. And so you had an atypical chondrogenic tumor that was labeled as fibrous dysplasia, essentially solely on a single, point mutation, and there was no histological, radiological evidence for that. And obviously, when it came out, it was a card-carrying, chondrogenic osteosarcoma, which had a GNS mutation.
Okay.
The way that was defended was it may have evolved or developed from a fibrous dysplasia, but there was again no clinical, radiological, or histological evidence
Yeah.
of preceding fibrous dysplasia. So I think again another pitfall. We need to respect
Absolutely.
all the all the various treatments,
Absolutely.
don't we? Yeah.
Absolutely. So
Just a
Shamir,
quick question. Just a quick question. Speaking of giant cell tumor, is there any other tumor that may mimic it in the head and neck?
um, uh, giant cell tumors mimic giant cell tumors.
Right.
Yes, metastases can mimic giant cell tumors. You can have other bone myeloma can mimic giant cell tumors. Infection can mimic giant cell tumors. I think anything that's osteolytic can mimic a giant cell tumor, and that's what Selvam and I were just saying, Samir. You have to have all of the clinical information around you, the age of the patient, the site of the lesion, the history. Is it more than one quadrant? If it's multifocal, it's less likely to be a mass lesion, a tumor, that sort of thing. If it's multifocal, it's more likely to be a lymphoid problem than it's going to be a mass lesion. So there are a series of questions that we would like to know. Even recent dental treatment, you can get massive reactions to that. If you've got cementoosseous dysplasia and you have a tooth extraction, you can have massive bone loss and cyst formation. There's so many things it could mimic. But I think with the giant cell lesions, the point we're making, if you get a biopsy of a giant cell lesion, for me as a generalist, I would ask, is it definitely in the bone? If not, you can have a peripheral giant cell lesion or a reactive condition. If it's in the bone, I want a lot more information. Where is it? Age of the patient, how long has it been there? How quickly is it growing? And is that biopsy representative? Who took the biopsy? So, was the biopsy taken with the low hanging fruit, or did the radiologist say, take that area? That's an important consideration as well. Representative tissue.
Thank you very much. Thank you for these practical tips about giant cell lesions of head and neck. Thank you very much. I think we
Okay.
can now proceed with the last session in this part with the mesenchymal tumors of the larynx, please.
Okay.
Thank you.
Okay. Can you confirm you can see?
Not yet. I'm just having a
Not
blank
yet.
screen.
Okay. I have to try. I don't know what it is. I think it's telling me to stop sharing. So I think, can you see it now?
Not yet. It's still just a blank screen.
Oh, it's okay. And then I think I'll start again. Um, I'll stop sharing. I'm going to share my screen. How am I doing?
Not
We
yet.
can't see anything yet.
No. Share
Okay, I
screen,
don't know why.
entire screen. You have to click on the
Okay,
screen and then click share.
I'll do that. I'm clicking on the screen. I'm clicking on share, and
Right.
I'll
Switch to
bring up.
PowerPoint now.
Have you got it? Excellent. Okay.
Brilliant.
I just went over the same things. It seems to want me to convince it to come on. Anyway, we're here. Okay. So mesenchymal tumours of the larynx. So in order to set the scene, and because they're so rare, and I've got to fill 20 odd minutes, I'd like to show you a laryngectomy specimen. So I showed you the anatomical landmarks in the macro talk. So let's look at what happens when a patient has a laryngectomy. These are kindly given to me by my colleague, Mr. Peter Clark. So here the skin is elevated. So I want you to be thinking mesenchymal tumours, what can we expect? So there's a lot of mesenchymal tissues in there. So you've got the submucutaneous fat, you've got strap muscles overlying the larynx itself. And as the larynx, this is the larynx being dissected inferiorly. So the trachea, the stoma, is going to be brought forward. So this is the thyroid lobes coming with the larynx. And then they have to dissect it superiorly. So here's the outline of the epiglottis. There's the hyoid bone. So already bone, cartilage, fibrous tissue, fat. It can become very complicated. Here's the larynx being delivered. So you can begin to recognize the hyoid bone, the epiglottis, and this is the larynx removed. So this is the bed of the larynx. So you have skeletal muscle, you have fat, you have cartilage, you have bone. So there's a potential for many different mesenchymal tumours. And there's the stoma in place on the patient who had the laryngectomy. So sometimes when you have a high stage laryngectomy, you might not get clear margins, and the patient might need radiotherapy. But the point I want to start off with is that primary or radiation-induced sarcoma of the larynx is extremely rare. So I would be asking you to think about a spindle cell sarcomatoid carcinoma before you jump into sarcoma, unless it's a sarcoma of a specific type, which we'll come on to discuss. So a case series of big institutions, Mass General, Memorial Sloan Kettering, etc., found very few sarcomas over a 10 and 20 and 30 year periods. So 16 here, 11 here. So it is extremely rare. In radiation, a recent paper looking at radiation-induced sarcomas, they found about 8 in the larynx, and the histology were chondrosarcomas. So the interesting thing about sarcoma of the larynx is that the prognosis is relatively good compared to sarcoma elsewhere. And the reason being is it's in your neck, it's quite superficial, and it can often affect the glottis. So people present early with voice changes or mass lesions. At least that's the scenario. So the type of tumours, 80% are not Ewing's or rhabdo. So about 20% are Ewing's or rhabdomyosarcoma, and the rest are something else. So when we look at what that something else is, it's the spindly lesions, which makes it difficult for us because we have to distinguish them from spindle cell sarcoma, so carcinoma rather. So fibrosarcomas, leiomyosarcomas, MFH and liposarcomas, rhabdo and synovial sarcomas. So we're okay recognizing synovial with their usual biphasic pattern. It's the monophasic pattern that's going to cause us a problem. And rhabdomyosarcoma, we should be able to recognize. So of the larynx, of 300 cases, the majority, about 70%, occurred in the supraglottis or the glottis, subglottis much more rarely affected. And the majority were synovial sarcoma, leiomyosarcoma, fibrosarcoma, and liposarcoma. So of the sarcomas, these are most likely of all is synovial, and usually in the supraglottis or the glottis. So this systematic review suggests that you keep a diagnosis of laryngeal sarcoma in mind if you've got an elderly patient who doesn't smoke and he presents with a hoarse voice. He shouldn't have any neck nodes although alveolar rhabdo may present as a neck mass, you should keep a laryngeal sarcoma as a differential, especially if the biopsy suggests it is. And then you would look at the CT scan. You try to preserve the larynx. And if you can't preserve the larynx, then you will decide on a radical conservative approach, but follow-up has to be a long time, frequent and for a long time, because of the difficulty of getting these lesions out with adequate margins, as I hoped you've seen from the laryngectomy specimen. So laryngeal soft tissue sarcoma is rare. It actually does better than sarcomas elsewhere because they present early. And adjuvant radiation might be considered for patients with high risk factors. Okay, so let's look at laryngeal synovial sarcoma, systematic review in a recent paper. 39 cases, again, not very many, and 69% were male and 82% were young, less than 50. So the majority of those tumours were biphasic, which would be okay for us, but the fusion gene was less than 25%. Now, I'm not sure whether that was because they were decalcified. They did it on decalcified tissue. I'm not sure. But we should be trying to make the analysis of these tumours and the reporting of these tumours into an international database. That I do agree with. And then the rest of them, really, you're looking at case reports. This is a well-differentiated spindle cell liposarcoma of the larynx, very rare, but even had the translocation analysis done and the appropriate immunostains. I'd like to spend a little more time talking about chondrosarcs, which we see more often. So in the head and neck, about 16% will be in the nose. It's quite rare, really rare in the larynx. And when it arises in the larynx, it's usually cricoid cartilage. Again, it's elderly men. And you really need radiological evidence of bone permeation. You really need to see that, because the diagnosis of chondroma, distinguishing a benign and malignant condition, can be quite difficult. And it's a good prognosis if you get it out completely. They're considering a proton beam therapy for recurrence. So this was a hemi or a partial larynx removed for chondrosarcoma. You can see how well circumscribed nodular this lesion is. And the cartilage was quite well differentiated. You can see the clones of atypical chondrocytes. You can see permeation, so you can see chondroid being atypical cartilage surrounded by, on three sides, by bone, which what Chas Mangum taught, that's true permeation of pre-existing bone. So I'd like to tell you a story about this man who was retired, and he went along to his GP with a swelling in his throat, and they could see on imaging a lesion, a chondroid lesion in the region of the cricoid, and here it is. So they took that out over the years. So in 2011, it was low grade. We felt confident it was permeative, it was low grade. In 2012, it was still low grade. By 2017, it was becoming a little bit showing its true colours. We had low grade areas with a nice thick matrix. You could feel you could skate on that matrix. But this matrix is more jelly-like. So it was changing to a higher grade, from a low grade to a higher grade. By 2019, it was really gone off. So you saw the low grade areas that we'd seen since 2011, but now we had a much higher cellular tumour with very much increased cytological atypia and stromal changes. And so this time it was a grade 3, and this is what it did to his neck. So eventually he ended up having one of those commando procedures whereby they needed to take out a huge portion of the muscles of his neck with, there's the tumour here. And when we sliced through it, again, 6 margins, top, bottom, 2 sides, back, front, and we sliced through it, you could see the extent of this chondroid material. So that lump corresponds to this area here, just behind, adjacent to the epiglottis. And there's the larynx lumen. You can see he could hardly breathe because the tumor lobules were pushing against his airway. We could clearly demonstrate the laryngeal slices with imaging, which is quite a nice thing for the MDT to see. And this was the grade 3 chondrosarc. So it's a dedifferentiated, if you like. You have dedifferentiated chondrosarcoma, you have low-grade areas juxtaposed to high-grade areas. And the high-grade areas can be spindle cell or MFH or something like that. So there's quite a nice, actually, review article this time, I think from 2019 by Felito and colleagues. And they say, what are the key features of a chondroma? And it's usually a small size, hyaline cartilage, very low proliferation rate and low atypia. And your differential for that is chondrometaplasia, a low-grade chondrosarc, and a laryngeal hamartoma, but rarely. And then you might want to look at chondrosarcs, and you've got low grade, you've got high grade, you've got D-diff. They can have extensive myxoid change, and there can even be clear cell, like you see in the long bones, but again, considered low grade, but a different type. So he does this nice comparison. So bigger lesions are usually malignant, clearly with atypia and lots of mitoses. But it can be difficult, again, on a biopsy, and you have to put it all together. Just want to mention osteosarcoma, extremely vanishingly rare. 13 cases reported so far to my count, 12 male and 1 female, 1 post-irradiation. Non-specific symptoms, and as you can imagine, very dismal prognosis. So here's the tumour, and osteosarcoma usually has this horrible bone-forming tumour, no osteoblastic rimming, very atypical cells. This is cytology prep stained for alkaline phosphatase. So you can see these big, ugly bone-forming cells. Malignant fibrous histiocytoma is probably the most common soft tissue tumour, but only 3% in the head and neck. But it is one of the more common head and neck sarcomas. Again, females slightly more than males, and women are younger. Non-specific symptoms, they're usually localized and not metastatic at presentation. They look like MFH at other sides, horrible pleomorphic cells within a spindle cell background, macronucleoli. Just moving on now to adult laryngeal embryonal rhabdo. As you can see, a lot of these things are case reports. So there are 22 cases quoted in this most recent case report. Difficult diagnosis on biopsy, but classification is very important for treatment strategy. So if you get a rhabdo, you should really try and classify it molecularly. So in the head and neck, from our point of view, about 33% in the orbit and the oral cavity, and the face and neck, probably the highest incidence. Very, very rare in larynx. It requires clinical exam, including the neck. They're one of the few sarcomas that can metastasize to neck, and up to 23% will have metastasized at presentation. And you might, if it occurs in the nose or the top of the nose or in parameningeal tumors, can happen. Again, adequate biopsy and expert review. So there are 4 types, and I'm not a soft tissue specialist, so I'm giving you my generalist approach here. So I hope you're not disappointed. So there are 4 types, as I can say, 5 types rather, and the most important distinguishing features are between the embryonal and the alveolar, and these have different translocations, FKHR and PAX3 for alveolar, and PAX7 is usually younger patients, potentially a better prognosis. So again, to stress that the genetics is important to guide management. And now RMS is divided into fusion positive and fusion negative genes. So again, hopefully we'll have tissue that doesn't go into decalcification. So this is a alveolar type rhabdomyosarcoma, and you can see the loosely arranged strands here. And often they have these strap cells. You can see the nice skeletal muscle. fibrillations. And their embryonal rhabdo is really a differential for malignant round Bruce cell tumour. And you have to exclude rhabdomyosarcoma in your differential. I would advise up the nose as well as in the larynx. Always include a desmin. It will be usually desmin strongly positive, myogenin positive. And there's a nice article here from 2019 where they reckon that you can actually tell the difference between embryonal and alveolar rhabdo on histology with a differential of myoglobin and desmin, in that desmin will be strongly positive in embryonal and not so positive in alveolar, whereas myogenin is a more reliable marker for alveolar. But again, you rely on the fusion analysis. These are the heritable syndromes associated with an increased risk of rhabdo. And staging is quite interesting. So they are staged according to sites. So the orbit and the genitourinary tract and biliary and other sites. So it's quite interesting. So in head and neck, the stage might be different to that which occurs at other sites, but this is done by the specialist sarcoma team. You would refer to your local or regional soft tissue sarcoma MDT. So complete surgical excision, like I said, all very easily said, not so easily done in the larynx or the head and neck. So adjuvant chemo and radiotherapy you are well established, but when you're a child, external beam radiation, you can cause problems with cosmesis and growth of bones, and survival is related to stage. So it's getting better as the molecular characteristics are more understood and people can treat it more effectively. So just finishing on laryngeal carcinosarcoma, extremely rare. Again, elderly men usually. Often smoking and alcohol is recorded in these. It's an exophytic lesion with an intact epithelial surface on endoscopy. Don't really know where these come from. We think that both components probably come from one precursor cell in the latest literature. Again, complete excision, neck dissection, post-op radiotherapy, that sort of hints at how aggressive these lesions can be. But actually the survival rates, depending on the size and whether you can get them out surgically, is similar to conventional SCC. So this is what they might look like. You have epithelial components and mesenchymal components, both of which are malignant, so-called carcinosarcoma. High-grade aggressive lesion, lots of mitotic figures, often necrosis. So these are the concluding thoughts. They are so rare. Primary or radiation-induced sarcomas of the larynx should be reviewed by a specialist team, and I would advocate standardized reporting and an international database to improve data and inform management. And again, I think we should all be thinking, how can we get this tissue fresh frozen? And how can we get cytology from it? Do we sample it ourselves? Is it easier to take an FNA from the specimen as it comes into the lab, liquid-based cytology, and make a cell block that way for molecular? So anyway, I'll put that over to the floor. Thank you for your attention.
Thank you very much, Anne, for this nice overview of soft tissue tumors of the larynx. I didn't see any question from the audience so far. I just have a quick question about how frequently in the classical squamous cell carcinoma of the larynx you see mesenchymal differentiation, like spindle cell or
Yeah.
this carcinosarcoma component.
Yeah, that's an excellent question, and I'll get Selvam to comment as well. I've been working since 2000 as a head and neck specialist, and I have only seen one or two of these high-grade tumours with heterologous elements, and I've seen a few sarcomas. I have seen a synovial sarc. I've seen more chondrosarcs than anything. When you have a spindle cell carcinoma of the larynx, I think I would be more inclined to call it a sarcomatoid squame with heterologous elements much more readily than to diagnose one of these very rare sarcomas. I think everything has to be in place. And I think with the molecular situation now, we're getting better to understand it, because a lot of the sarcomas are carrying with them translocations now, which we didn't have before. I think it's quite difficult to get them out of the archive as well, because we don't know what they've been called. They could have been called different things based on a biopsy. But I would say that we see quite a lot of sarcomatoid squames. Of them, very few have heterologous elements. So the whole thing, it's very rare. Would you agree,
Okay.
Selvam?
Absolutely, yeah. Nothing to add to that, really. And I suppose the converse is also true, Anne, isn't it? That beware of aberrant cytokeratin expression in sarcomas
Absolutely.
and don't fall into that pitfall. And
Exactly.
uh, yeah,
Yeah, absolutely. So we would have all these tumours reviewed as a sense of sort of duty, really, by the sarcoma team. But the numbers that we've sent over there and had returned to us saying, get a grip, it's a spindle cell carcinoma, more often than not. We've had occasional exciting ones where they have been sarcomas, but it's quite rare.
All right. And soft tissue tumors, its epidemiology is similar to uh, other places. I mean, like osteosarcomas in pediatric and adolescent patients, chondrosarcomas in adults,
Yeah,
for
I
instance.
think I think it's quite different, and I think that the larynx is rarely affected by sarcoma, other than chondrosarcoma. Osteosarcoma is vanishingly rare. I think synovial sarcoma, as we said, it's usually adults. Can happen in children, but usually adults, usually elderly men. So it's a different demographic. It's a bit like things up the nose, if you ask me, Samia. Sarcomas that occur in the head and neck, or tumours that occur in the head and neck, tend to behave better than they do at other sites. So things like glomangioperiocytomas or things like that, they'll behave a lot better in the head and neck than they will in the elsewhere in the body. And we don't
Why?
really
Because of
know.
early symptomatology, early
Probably,
symptom.
yeah. I don't know whether it's as simple as early symptomatology, but when you look at the incidence of rhabdomyosarcoma in children, few occur in the head and neck. And when they occur in adults, they're often they do better because of the location, but it's not usually common in children either. So I don't know whether it's something. I don't know
Right.
whether it's the development, the hormones, the development, or whatever, because you find that in young adolescent males, for example, there's a great change in the larynx, the nose, and the pharynx as they grow. And there are certain things that happen to sarcomas when people are pregnant, or when there's a hormone incidence, etc. So it would be quite interesting to look and see whether there's a higher incidence of these tumors due to hormones or whatever. But overall, the head and neck's not a happy place for sarcomas.
Okay. Thank you very much. I think it was a great presentation as always. I think it's time for another short break, 15
I
minutes,
think
so
so.
we resume
Yeah,
in 15 minutes.
yeah,
All right.
yeah.
Thank you. Thank you very
Okay,
much.
thanks.
You're okay, Anne.
Good afternoon, everybody. Welcome back. I hope it was a welcome break. You're doing well. Onward and upward, as they say. So the next talk in the programme, or at least in our list, is I'd like to address these tumours and other lesions in the ear. So I was asked to try and summarise or give an overview of the ear chapter in the WHO book. And so there are 14 lesions discussed. And it used to be that the ear was divided into external, middle, and inner ear, all discussed separately. But now the middle and inner ear discussion has been combined. So there's effectively two sections within the ear chapter. That's the first new thing. And although there are a higher number of conditions than were included in the 2017 edition, a couple of things are benign. So they've included cystic chondromalacia, exostosis is back in, and I think that's the main changes. There are some changes to the neuroendocrine tumor of the middle ear, which I think we can discuss as we go along, and again, middle ear adenocarcinoma. So these are really the main changes. So MENET, the new name for adenoma of the middle ear, and middle ear adenocarcinoma, which is separate from endolymphatic sac tumor. So let's see if we can clarify some things about the ear. So for our sake, for us as clinicians, we still need to divide our ear into three parts. There's the external ear, there's the middle ear where the ossicles are. So the tympanic membrane divides the external ear from the middle ear, and the middle ear is where the ossicles are. And then the cochlea, the semicircular canals, is in the inner ear. So again, as in other cases with the head and neck, the site of the tumour, the age of the patient, the clinical setting is all important. So let's start with chondrodermatitis nodularis chronicus helicus. Why would we include this condition? Well, the main reason is that to do surgery on the ear is really quite debilitating for the patient in that it can be cosmetically quite disastrous. And so it would be quite good to know that it's really necessary. So chondrodermatitis nodularis chronicus helicus, or Winkler's disease, this mimics squamous cell carcinoma, but is actually a benign condition. And the cause is a bit controversial. The ideas about the cause is a bit controversial, and the most commonly accepted is that it's an ischemic sort of condition, possibly related to trauma or infection, and it's relating to hyalinization and vascular compromise because of the blood vessels. So when we look at this, what you see is the overlying epithelium is ulcerated, and the ulceration often occurs over a piece of the cartilage, which is here. And this will often, if you're lucky, and you can see it in the section, perforate through the ulcer surface there. So this is classical chondrodermatitis nodularis chronicus helicus. You might get pseudoepitheliomatous hyperplasia of the squamous epithelium either side of this ulceration, but this condition is benign and self-limiting. Occasionally, it doesn't heal very well, and then conservative surgery is appropriate. Now, squamous cell carcinoma of the external ear is really quite a serious consideration. The majority involve the pinna, and they're quite easy to recognize, really. You know, they present quite early because you notice this lump on your ear, which may become ulcerated or may grow very quickly. Usually more females than males, middle-aged, and the presentation is quite non-specific. So patients may experience pain, and if it's inside closer to the ear canal, there'll be hearing loss and drainage of pus and blood. The ear canal tumours are the most difficult to diagnose, and they are the most serious in that they can be mistaken for inflammatory conditions. Just thinking about this pinna, so as we've discussed before, this was a subtotal pinnectomy. It's marked superiorly, although in this case it probably wasn't necessary because we can see. And I would have inked the medial margin serially sliced from superior to inferior. And here are whole mount sections across the pinna. And there you can see the tumour arising around, going around the helix. And you can see that the anterior, posterior, and deep margins are clear of tumour. So for a wedge excision, that's my approach as we discussed in the macroscopic examination, the same for a pinnectomy. So let's consider now squamous cell carcinoma of the external ear. It's usually female, and here you can see this tumour, and actually you can't tell how bad it is clinically. On imaging, I think one of the main hopes of the latest WHO Blue Book is for clinico-pathological correlation. So this is what I've tried to do here. And you can see there's the external ear canal. There's this tumour arising in the ear canal. And this corresponds to the tumour that you can see here in the macroscopic specimen. So this was kindly annotated by a good radiological colleague. So you can see the condyle, you can see the mastoid air cells here, you can see the temporal bone. So this is a lateral temporal bone resection to leave the woman with the cosmetic effect of the external ear. So they've literally tried to take out they've tried to do the best cosmetic effect they could, but there was too much extension in this case. So the ones I showed you in the macroscopic lecture would try to take out just the ear canal and the temporal bone. With this poor woman had a total pinnectomy, part of the skin, and there is the temporal bone. So in 2010, so we've known for quite a long time that SCC of the ear isn't as nice as it looks, that 11% of patients present with lymphoid metastases, and of those, 66% may die of disease. And you can't really tell from the histological subtype, but the depth of the invasion and cartilage destruction with vascular invasion and non-cohesive invasion pattern were indicators of more aggressive behavior. So this is the temporal bone resection with just the ear canal. So you can see here the skin is orientated on foam. So this is what our clinicians do. And they've taken out the neck with deep lobe of parotid over here, anterior, posterior, and all the different levels in the neck. So level 5 is sometimes involved in the ear as well, and that would have been sent separately. And this is my block key, so I know which blocks I've put in for different areas of the neck dissection, so I can tell the extent of the lymph node metastases, if any. So this looks like a more considered, less aggressive approach, but when you look at the operation site, you can see how extensive the tissue loss is. So this is a lateral temporal bone resection. The ear, the outside portion of the ear is on the flap here, but there's been a very large tissue loss for that patient. So this is an SCC of the left ear canal, another one. You can't really see anything externally. When you slice through it from superior to inferior, you can see the tumour coming in, and it's extensively invading parotid and down into the temporal bone. So here's the tumour here. And if we look at a section, there's the skin, there's the tumour, destroying cartilage, extensively infiltrating discohesive margin into the bony ear canal and parotid anteriorly. This is just a slightly out of focus section again to show it's undermining the pre-existing skin. So the surgeon couldn't really estimate how far it had spread. So there isn't an accepted staging criteria for pathological staging criteria. So I have collaborated with colleagues in Australia and America to try and come up with a data set for the ICCR, which is currently under review. So PT3, tumour eroding the osseous ear canal full thickness with less than 0.5 centimetre soft tissue involvement, or tumour in the middle ear or mastoid, and PT4, tumour eroding the cochlea, petrous apex, medial wall of the middle ear, carotid canal, etc. So we're trying to offer a pathological correlation with imaging to stage these accurately, and the tumours are so rare that it would be very nice if we could standardise the assessment and reporting. Okay, so we're moving along the external ear. So the glands in the external ear that produce the wax are associated with tumour formation, and this is the most common ceruminous adenoma, and this is the characteristic glandular form. And again, you can there's a quite nice review in the head and neck pathology, and Lester Thompson has probably got the biggest series. So again, the mean age is in the 5th decade. It's quite rare in children. It's usually got a geographical correlation with the outer half of the external ear canal. It can be up to 4 centimetres, and the symptoms are non-specific. You can get malignant neoplasms arising from ceruminous glands. So ceruminous adenocarcinoma, adenoid cystic, and mucoepidermoid are all tumours of ceruminous glands. Okay, so again, you can see this ceroid pigment characteristic of the glands in the external ear, and they are negative for neuroendocrine markers. Okay. So another biopsy that you might get may be these inflammatory polyps. So we're moving now into the middle ear where the ossicles are. And when you have chronic inflammatory diseases, chronic infections, inflammation, you can develop rupture of the eardrum, and the effect of the infection can move into the middle ear. It usually gets better quickly, but people with chronic disease may have problems with hearing, and they can develop mucosal hyperplasia, which is our problem, and they can resemble, on otoscopy, they can resemble tumours. And the problem is, if you get an otoscopic description that you have a worrying looking inflammatory mass and mucosal hyperplasia, and you get a biopsy in a site that you're not comfortable with seeing very often, and you see glands which are distorted by the scar and the inflammatory tissue, and they show atypia, it can be mistaken for cancer. And I hope you've just seen what the diagnosis of cancer means in the ear. So the best treatment is surgical, and the surgery is really quite dramatic. So it's really good to be absolutely sure with the proper clinical correlation with what you're dealing with. So it's classified into acute and chronic. And chronic, you can have an effusion, it's with or without an effusion. You can have pus coming as a result of the infection or inflammation. There may be an eosinophilic reaction. So people with asthma and allergic conditions may have an eosinophilic otitis media, and this can be either associated with the so-called vaganers or granulomatous disease, or it can be just not. It can be eosinophilic inflammation by itself, or it can represent granulomatous lymphangitis. Okay. So eosinophilic otitis media was first named about 20 years ago. Again, what you would see would be almost like the allergic mucin that you see associated with nasal polyps, and it's associated with asthma and allergic rhinitis. So this eosinophilic granulomatosis with polyangiitis used to be vaganers, and with Churg-Strauss syndrome all have to be excluded. The hypereosinophilic syndrome has to be excluded clinically. You can't do that, but you need to check whether the anchor serology has been done, whether there are clinical information leading to a diagnosis of this before you make that diagnosis on a middle ear biopsy. Okay. So really, it's just to have your wits about you to make your clinical queries so that you know what you're dealing with, the age of the patient, the site of the biopsy, the chronicity of the condition, and whether the patient has any underlying clinical conditions. So the problem is you need to make sure that you have a representative biopsy. So an inflammatory polyp that comes back to you, recurs or comes back, should raise a red flag with you, and you need to go back and make sure that there's no underlying condition, and what you're seeing is the tip of the iceberg. So in this study, in 86% of patients, there was an underlying cholesteatoma. But in a significant proportion of cases, there's actually neoplasm. So there could be a glomus tumor or melanoma even. So it could even be a malignant condition under there. So if you have a recurrence of a polyp or a disease process that seems to be recurring, or you see the same patient's name a couple of times in a row, then it's worth trying to look at all the clinical information together, so you have an increased clinical suspicion that your biopsy is not representative. Okay, so this is quite an interesting tumour reported quite recently, and that's mixed epithelial and stromal tumour of middle ear. I haven't recognised this tumour. I think it's quite rare. It looks like an ovarian tumour, and I think the clinical significance is unknown. They've seen similar tumours elsewhere, like in pancreas and spleen, kidney. Slightly different immunohistochemical features in those sites. It is monoclonal, therefore a neoplasm, but I haven't seen it personally, and I don't know what the clinical follow-up means. Okay, so if we move on now to cholesteatoma. So we quite like seeing biopsies for cholesteatoma because it's quick and it's easy, and all we need to say is keratinizing squamous epithelium, no dysplasia or malignancy. But what does it mean for the patient? This stuff is lining the outside of the eardrum, and the keratin should go into the ear canal. When the eardrum is perforated, as is the case with acquired cholesteatoma, this keratinizing epithelium grows into the middle ear, and it can line the skull base and produce keratin that is being poured into a space from which it cannot be ejected. So it can form a mass lesion. It can cause problems for the patient with infection and for hearing and for facial nerve issues. And therefore, it's quite, for us histologically, it's nothing, but for the patient, it can be quite significant. We know that it can be derived from the rupture of the tympanic membrane, and that can be from a number of causes, from blast injury, iatrogenic through grommets, perforation after infection and retraction pocket development, repetitive otitis media, or a chemical otitis media, which is experimental. That would be a scientific projects. Now, that's acquired cholesteatoma. It will have a site. It's usually posterior superior attic, and it's seen mainly in older children and young adults. So there is a clinical scenario where you see acquired cholesteatoma. It's usually associated with severe otitis media, and that site in upper posterior middle ear is quite characteristic. So again, the appearances of foul oral discharge and hearing loss, and you can usually see on examination the tympanic membrane is perforated. So in congenital cholesteatoma, this can happen in children. You will see that the eardrum is closed, and you can see a collection of keratin the other side of the eardrum. And this is thought to arise from a developmental anomaly where keratinizing squamous epithelial rests get left behind in the middle ear and actually produce a mass lesion or cholesteatoma. Okay, so that's it for cholesteatoma. Moving on now to neoplasms. So middle ear adenoma was first described in 1975 by Professors Michaels and Hyams, who were working in London at the RNT&E and in the Armed Forces Institute of Pathology. And they looked at 20 cases which was confined to the middle ear cleft, looked benign, and they all did very well following excision. And there's been an argument about their nomenclature raging for quite a long time, started by Lester, who has the biggest series, and he wanted to call them NAME, neuroendocrine adenoma of the middle ear. But not all of them show neuroendocrine differentiation on immunohistochemistry. All of them show neuroendocrine morphology, but not all of them express neuroendocrine markers. And they're akin to carcinoid tumors, some of them, in that they can metastasize and recur. So the new nomenclature is trying to line it up with neuroendocrine tumors at other sites, is middle ear neuroendocrine tumor, MENET. So it was previously adenoma of the middle ear. There was an argument to call it NAME, and now it's MENET. So in the newest edition of the WHO Blue Book, this is what you see in its commonest middle ear neoplasm. It usually in the middle ear cavity, sometimes intermastoid, can entrap the ossicles or even erode bone, not because it's malignant, but because where else is it going to go? It's going to grow there, and it can entrap the ossicles. So you can see here, not much to see on otoscopy, bulging here. You can see the tumor in here, and that's the middle ear adenoma. It does tend to have two cell populations, but it lacks myoepithelial cell differentiation. So there's lots of work going on that tumor at the moment to characterize it and understand its biology. So often irregular cells, back-to-backing, can be quite worrying architecturally, but very bland, cytologically very bland. So they all look like neuroendocrine tumors, but they don't necessarily have to express the neuroendocrine markers. There's no evidence of aggressive behavior. Okay, so another recently described tumor of the skull base in the ear, and now it's been adopted by the sinonasal people because we've found a couple of cases up the nose, is the DECAF2 fusion carcinoma. What does that mean? Well, it's a non-coracinizing squamous cell carcinoma that carries this DECAF fusion. So we don't really understand what the fusion's going to mean. One of these tumours, one or two of them, responded quite well to immunotherapy, and there was hope that that fusion carried a better prognosis because it would respond well to the PD-L1 positive tumour inhibitors. But that's not proven to be the case on a bigger series. So there's about 29 now. I've just done a review, and I think there are about 29 reported cases, and it's not proven to be reliable that they will be responsive to immunotherapy. So this is a middle ear tumour that's papillary, that is malignant, and carries the DECAF fusion. Now, there are two other papillary tumours. So quite some time ago, they thought that the endolymphatic sac tumour of the inner ear actually was related to the papillary tumours in the middle ear. But actually, that's not the case. So the middle ear seems to be a garden for other type of papillary tumours that's not related to von Hippel-Lindau and not related to the endolymphatic sac origin. So Abbas Agami has described two papillary tumours, one that resembles an oncocytic nasal papilloma and the other one that resembles an intraductal papillary mucinous neoplasm that you might see in salivary glands. So one looks like a salivary tumour, one looks like an oncocytic papilloma. They look low grade, but we're looking forward to seeing what the family of papillary tumours are in the middle ear as we go global. Remember, all of these are quite rare, and we're looking at case reports. So if you see any of these tumours, it would be very nice to get in touch with the people who have a series like Abbas in Germany and Ilan Weinreb in Canada. Okay, so this study, two mutant novel variants, they seem to be carrying different mutations. So again, we're into the molecular age. So Abbas has been looking at KRAS and MKR and IBRAF mutations in those tumours. Okay. So a talk about ear tumours wouldn't be the same if we didn't actually formally discuss endolymphatic sac, because it's like almost like, I don't know, a movie star of ear tumours. It occurs inside the temporal bone, and it occurs in a specific site in the here in the associated with the semicircular canals. So that's the true origin of these tumours, is inside the endolymphatic sac extra osseous portion. So you can see where I'm going with this. This tumour will start growing in the inner ear. It will be able to get out into the middle ear and the posterior cranial fossa. So on radiology, it should be distinct from tumours occurring in the middle ear, like the ones I've described. So they are geographically distinct and they are histogenetically distinct as well. So endolymphatic sac tumour, first described in 1998. It's an aggressive papillary tumour and it's associated with the von Hippel-Lindau gene. Other names for it is low-grade adenocarcinoma of probable endolymphatic sac origin and endolymphatic sac tumour. So there was a series of patients with von Hippel-Lindau who actually they saw small tumours, some of which, most of which were on the left side, interestingly enough. And they followed these tumours, and all 10 were confined to the interosseous portion of the endolymphatic sac. They did not wander off into the middle ear. So that tumour is associated with the von Hippel-Lindau mutation and von Hippel-Lindau disease. So I won't wax too lyrical about the histology. You probably heard and read about it all before. It's the only tumour of the inner ear that's described in the literature. And you can see from this very nice review, you can have a look at the histology. Papillary tumours, usually a single layer of cuboidal to columnar cells, has distinct geographical occurrence and imaging, and they're positive for CK7, for GLUT1 and CA9, and that's membranous, and that's quite useful to distinguish between that and other carcinomas. So you have to exclude other papillary carcinomas, including thyroid, prostate, and squamous carcinoma, and other neuroendocrine tumours. So you always exclude, it's a very rare tumour, you always exclude metastasis, something coming back in from the nasopharynx or from the middle ear. And so imaging is very important. So as I say, treatment is surgical. So you can imagine what that means with the temporal bone resection, and radiotherapy if it is incomplete. So I'd like to stop there and see if anyone has any questions about the ear, and maybe we can have a team discussion about what we've done so far. Okay. I hope that Samir's connection has been re-established. Yeah.
No, that was absolutely brilliant, and thank you ever so much. I think it's
The
a
ears.
rare treat to have somebody of your experience and caliber who has amassed over a lifetime of knowledge and expertise in what is a very very rare and sometimes frightening area of histopathology
Yeah. It
to the
can.
rest of us. So thanks ever so much. Yeah.
I'm very grateful to Leslie Michaels. I mean, as I said, I were like Eddie and Peter were with you. He was with me, and I sat at his side for a long time, looking at these interesting things and seeing his temporal bone collection. But they're extremely rare tumours. We wax lyrical about them, and very few people see many of them. I think in our department we've seen one or two in the last 5 years. Yeah. So.
Okay, there is a question from the audience asking about neuroendocrine tumors. Is it just NET, neuroendocrine tumor?
In sorry, the middle ear adenoma used to be called middle ear adenoma. They're trying now to align neuroendocrine tumors in the head and neck. We used to like to keep ourselves separate from gut and everywhere else and lung. But now we have to come in with everyone else. So they're saying that they think that middle ear tumor is a neuroendocrine tumor. Even though it might not always express neuroendocrine markers, it does have neuroendocrine morphology and would be considered as a low grade neuroendocrine tumor. So a carcinoid, if you like. So what we're trying to say is, why don't we just call these tumors MENETs? So rather than call them an adenoma, they are of probable neuroendocrine origin. Therefore, we would like to join in with the other nomenclature and see whether these are going to behave. So then prognostication becomes like other neuroendocrine tumors elsewhere.
I
Does that
see.
make sense? Yeah.
Yeah, got it. Yeah. So, but it's indolent tumor. Good prognosis, right?
Usually, yes. You can get adenocarcinomas there. Again, very rare, but it's adenoma implies indolent. Yeah, it's low grade or benign.
Right.
Can be
Speaking
locally
of
aggressive. Yeah.
Okay, speaking of external ear, you discussed squamous cell carcinoma. What about basal cell carcinoma in the region?
Yes, it can happen. Squames are more common. Yeah, we do see them. They don't tend to happen very much in the ear canal. So basal cell carcinoma, I've just seen one basaloid squame. I haven't seen many basal cell carcinomas occurring in the external ear. I need to look more into that. It's an interesting question. But I think we've seen more basal cell carcinomas of the external pinna than I would of the ear canal.
Yeah. All right. That's it. Thank you very much. Let me check if there is more question.
Mhm.
Yeah, there is a question from the audience. Dalma is asking, can cholesteatoma be diagnosed if we have only a keratin lamels without any vital squamous epithelial cells? How would you report that if material was sent as a cholesteatoma suspected?
Yeah. Yeah, she is psychic because, or he is psychic. They have Alfio Felito has just asked me to write a review about that same issue. How do people report cholesteatoma when they only get the keratin? To be perfectly honest, I usually say keratin only, um, compatible with origin from, if you want to keep the surgeon happy. But if he tells you that he has taken it from the attic or the middle ear and he's been in there with his scope, I usually try to cheer them up. But I usually say it's keratin only. There's no infection or neoplasia. It's not diagnostic. It's compatible. But I think my
Okay.
bottom line would be keratin only, not diagnostic.
Okay, all right. Thank you very much. Thank you for this nice talk about ear lesions and ear tumors. Thank you very much. I think we are moving on to the next exciting
Yeah,
topic, which is salivary gland and
yeah.
sinonasal tumors.
Selvam.
Thank you.
Yeah.
Let's see. There we are. Let me just rearrange things. Thank you. No, thank you ever so much, and I hope we're keeping the audience engaged at this stage. It's been a bit of a tour de force, trying to accomplish some of these what seem to be rare tumors. The approach then of salivary tumors as a prelude to the sinonasal update, I felt a bit challenging, a bit difficult because it normally takes people a lifetime to accumulate experience and expertise and confidence in the diagnosis of salivary tumors, and I don't feel I can do it in any way any justice in half an hour. So what I thought I would do is sort of split it up into two bits, to give a bit of an overview of the diagnostic approach. And then follow that up with an update of some of the more newly recognized entities around the new WHO classification. Let me just get my pointer up. There we are. So, before I launch straight into the talk, just a bit of context, please. Really important to remember. that most salivary neoplasms occur in the major glands. And I suppose by far they occur in the parotid. So 80% occur in the parotid, and that's followed by the submandibular glands. And then the sublingual gland is only about 0.3%, with intraoral minor glands about 10%. Having said that, in the parotid and submandibular glands, the majority of them are benign. Only 15% of parotid salivary neoplasms are malignant, and 30% of submandibular gland tumors are malignant. And therefore, when tumors occur in the minor and sublingual glands, they are relatively more commonly malignant. So this is another way of saying they're rare in the sublingual and minor glands, but when they do occur, there's a greater chance of them being malignant. This is a collective from several centres in the UK that was collected by colleagues up in Sheffield University, asking various centres in the country what the relative frequencies of tumor types in salivary tumor types are in the head and neck. Blue is benign, and the sort of the pinks and reds are malignant. And as you can see, by far the most common neoplasm is the pleomorphic adenoma, and benign tumors outnumber those of malignancy. So pleomorphic adenoma followed by Warthin tumor, the most common benign neoplasms, mucoepidermoid and adenoid cystic carcinoma, the most common malignant neoplasms. And I'm sure the audience knows this, but I think it's worthwhile reiterating because as a senior colleague of mine used to remind me, common things occur commonly. And when we're approaching something, always exclude the more common tumors before raising the possibility of some of the more rare entities. So really, a lot of the introduction and the fine detail of a diagnostic approach to salivary neoplasms can be accessed through any standard text. And I don't, for 1 minute, claim to be any expert in it. But what I thought I would do is just maybe put forward to you some things of my own experience, really. Some of the things that I've gathered from colleagues, from senior colleagues, that I found helpful over the last few years that are not necessarily in the textbooks. And so, what I'm hoping to cover in the session is some of my experience, and then finish off with some of the new entities in the WHO. So, this is my very simplistic diagnostic approach. If you decide the neoplasm is benign, the next question to ask yourself is, why is it not a pleomorphic adenoma? Because pleomorphic, does mean that it has a diversity of different morphological presentations. I remember as a trainee going to sit to learn some salivary pathology with Professor John Eveson. And when I first arrived on the first day, he presented me with, several feet high of large trays of cases, of interesting cases for me to look through for the whole of the first day. And every single one of those cases was a pleomorphic adenoma. So you can see why, we accept a very broad range of entities to be included in the diagnosis of pleomorphic adenoma. So if it's benign, first thing is, why is it not a pleomorphic adenoma? Secondly, if a tumor is the tumor defined, is the tumor malignancy defined by the tumor type? And what I mean by that is, if you've decided that something is an acinic cell carcinoma, then by definition it is malignant. Or if it's a mucoepidermoid carcinoma, it is by definition malignant. Now, it is then up to us to then decide whether it's got high or low grade features, or whether it has undergone high or high grade transformation. But the point I'm making is that some tumor types are by definition malignant, and we do not necessarily have to agonize over whether it is a benign counterpart of anything. And then thirdly, is the tumor biphasic or monophasic? And what I mean by that is certain categories of salivary neoplasms have both a luminal component and an abluminal or myoepithelial or basal component. And if it is biphasic, then you have to include in your differential a whole host of tumors. And conversely, if it is not biphasic or monophasic, then in essence, you are allowed to exclude some of the categories of tumors. So this is where we're going in the next sort of half an hour or so. I'm hoping to briefly present some of the distinguishing, some handy hints, I hope, to distinguish salivary neoplasms with overlapping features. Things that I have struggled with in the past that, as a trainee, that may be useful. We'll talk about some new entities, and if time allows, I'll try and present some case presentations or maybe take it forward into the next session. See how we go. This is the comprehensive list of classification, both benign and malignant neoplasms, according to the 2022 WHO classification. But don't worry, I shan't be going through all of them. Of the new entities, I'll briefly discuss the microsecretory adenocarcinoma, but I'll start off with distinguishing pleomorphic adenoma from basal cell adenoma, and then briefly also then try and describe what I think are some of the distinguishing features between the adenoid cystic, polymorphous, and epithelial myoepithelial carcinomas, and then briefly introduce you to 3 newly accepted benign entities. Okay, the background to all this is the increasing reliance of molecular diagnostics in salivary neoplasms. And I think this is now starting to become commonplace now. And it is almost incumbent on pathologists to avail themselves of molecular testing where possible to support diagnosis in salivary neoplasms. And in a lot of instances, if not all, the cytogenetic diagnosis, the molecular diagnosis, does really help clinch the diagnosis, especially in cases where there are seriously difficult overlapping or non-specific features. Some of these particular rearrangements are more specific than others, and we can maybe have a quick chat about that. But in general, the MIB translocation for adenoid cystic carcinoma, likewise the MAML2 for mucoepidermoid carcinoma. You'll remember the ETV6 was the defining criterion for secretory carcinoma, EWSR1 for hyalinizing clear cell carcinoma, and now the new entity, the microsecretory adenocarcinoma with its MEF2C translocation. Having said all this, I think it was quite insightful and accommodating of the WHO to make all these cytogenetic criteria for salivary neoplasms a desirable criterion rather than an essential criterion. A desirable rather than essential criterion. So at least for the time being, none of the salivary neoplasms are defined exclusively by their molecular status. We still are heavily reliant on H&E morphology and to some extent immunohistochemistry. So I think that's worthwhile remembering. It may change in the near future, but it helps, especially globally, those of us who do not have immediate access to cytogenetic testing. Again, immunohistochemistry is used in varying proportions by various people around the globe. I must say that this is a typographical error that should say P40 negative. Apologies for that. P63 or P40 negative. But sometimes it can be quite useful. Immunohistochemistry can be reasonably useful. And when I reach for the immunohistochemical panel, some things that help define or exclude tumors are strong and diffuse S100 positivity for the polymorphous intraductal and secretory carcinomas, whereas more variable expression in some of the others. For many years, we were using the combination of P63 and P40 to help us differentiate between adenoid cystic and polymorphous adenocarcinoma, because you remember there is both P63 and P40 positivity in adenoid cystic, but apologies for the typographical error, P63 positivity, but P40 negativity for the polymorphous adenocarcinoma. But as things become, as biomarkers become less and less specific with time, the newly described microsecretory adenocarcinoma now also has this immunophenotype. So here we go with some of the, what I hope to approach, some of the overlapping histomorphological features. Remembering when I was a trainee, sometimes making the distinction between a cellular pleomorphic adenoma and basal cell adenoma quite difficult. I'll then briefly touch on what I find useful in differentiating adenoid cystic from epithelial myepithelial carcinoma, and then distinguishing adenoid cystic from polymorphous adenocarcinoma. So here we go, the pleomorphic adenoma. I'd like to commend this article from last year in Histopathology by Hernandez Pereira and others. I think they entitled their review article something like Pleomorphic adenoma, the great mimicker of malignancy. And I think that's really, really useful to remember because especially those of us who are not necessarily used to looking at plentiful pleomorphic adenomas can sometimes be misled by appearances like this, where we see the tumor sort of mushrooming out of what may be the capsule, a little bit like follicular neoplasms in the thyroid. This is common and is by no means an indicator of malignancy. That's perfectly acceptable in the benign spectrum of the pleomorphic adenoma. Likewise, the pleomorphic adenoma often has fat or undergoes fatty degeneration or metaplastic fat within the entity. So in this instance, for example, you might consider that the boundary of the pleomorphic adenoma is somewhere around here. So do not confuse the fact that you have epithelial islands and tumor stroma admixed within fat. That is not to say that it infiltrates that it is an infiltrative neoplasm. So accept a degree of adipose tissue at the periphery of the pleomorphic adenoma. Likewise, you might get islands of pleomorphic adenoma pushed into vascular spaces. Again, not a criterion for malignancy. And then when they recur, sometimes they can recur in a multifocal manner. This appearance doesn't mean that it is infiltrative. It's just that at the initial surgery, there might have been rupture with multiple foci being seeded. So it may look like a multifocal tumor, but it's just a multifocal recurrence in the pleomorphic adenoma. So I suppose the long and short of it is just remember that the pleomorphic adenoma can be a great mimicker of malignancy. I haven't got quite enough time to go into the diagnostic criteria for the intracapsular, the minimally invasive, and the invasive carcinoma X pleomorphic adenoma, but maybe there may be some time to discuss that at the Q&A session. In cellular pleomorphic adenomas, I find it quite difficult sometimes to distinguish it from the more solid basal cell adenomas. So here we have, apologies for the slightly faded slide, but a rather uniform solid neoplasm of essentially ovoid, bland ovoid cells, tightly packed and extremely solid. And in an instance like this, I would hunt around and maybe submit more blocks. And I always find the myxoid stroma, and in this instance, admixed with some more plasmacytoid myepithelial cells to be useful in pushing me into making that diagnosis of a cellular pleomorphic adenoma. Again, hunt around for ducts, etc. So you just need a little bit of foci of myxoid stroma with some plasmacytoid myepithelial cells to help you make that diagnosis of a cellular pleomorphic adenoma. If you're thinking along the lines of a basal cell adenoma, I suppose the next question is basal palisading of cells, and that is a useful criterion for distinguishing a basal cell adenoma from a pleomorphic adenoma. The kind of things that are not often mentioned in textbooks. Indebted to Higgins and Nicole Cipriani for reminding us that there is sometimes S100 positivity in the stromal component of basal cell adenomas. I'm not sure how often I reach for S100 in that instance, but it may be something that's quite useful. And then ultimately, if you're thinking along the lines of a basal cell adenoma, exclude a basal cell adenocarcinoma, because again, when you're thinking of making the diagnosis of a basal cell adenocarcinoma, it has to look like a basal cell adenoma primarily, but with infiltration. So if you're thinking basal cell adenoma, exclude basal cell adenocarcinoma. What about epithelial myepithelial carcinoma versus the adenoid cystic carcinoma? These are examples of the adenoid cystic carcinoma, a biphasic tumor, because it may not be immediately obvious in these photomicrographs, but when you do your immunohistochemistry, you will see a dual population of P63 positive basal cells and either CK7 or CD117 positive, more luminal cells. But you often get this sort of membranous stroma in adenoid cystic carcinoma. But another helpful point that sometimes isn't often mentioned is the sort of pseudolumina. So there are true lumens in an adenoid cystic carcinoma, but there are also pseudolumina where the epithelial component has sort of enveloped the stroma. What again my senior mentor Professor Morgan used to call crab claw nipping of the stroma. It looks like crab claws that sort of go around the stroma and nip it. Another useful pointer to help you make the diagnosis of adenoid cystic carcinoma. They're both biphasic tumors, the epithelial, myepithelial, and the adenoid cystic carcinoma. But in the adenoid cystic carcinoma, the abluminal or myepithelial layer, these cells tend to be a lot more hyperchromatic and angulated, whereas those in the epithelial, myepithelial carcinoma tend to be a lot more plump and often undergo enlargement of the nuclei and cell clearing. So again, not absolute criteria, but helpful hints. Look at the abluminal component. Is it hyperchromatic and angulated, or is it rather plump and more diverse? In the epithelial myepithelial carcinoma, sometimes the abluminal or the myepithelial component can be rather prominent and multi-layered and sometimes even spindled. Like here where it merges with some more sort of more aggressive looking spindle components. Is there anything that might help us distinguish adenoid cystic from polymorphous adenocarcinoma? Again, one's biphasic and the other one is not necessarily biphasic. So here are examples of the adenoid cystic carcinoma. And if we do either a CK7 or a CD117, it highlights this dual population of CK7, luminal component, and usually P63 or SMA or even S100 or calponin positive abluminal area. And this is, I find, quite helpful because it puts us into the category of, is this a truly biphasic tumor? And that helps us exclude certain other tumors. Another example here of the biphasic nature of P63 positive abluminal cells in an adenoid cystic carcinoma. Both polymorphous adenocarcinoma and adenoid cystic carcinoma have a propensity for perineural invasion. But again, one thing, again, not an absolute criterion, but in the polymorphous adenocarcinoma, the infiltration at the periphery can often be in this sort of single file pattern, and that may be helpful. And again, happens in both instances where you have sort of this targetoid pattern of perineural or perivascular invasion. In the targetoid pattern, again, look for single file pattern in the polymorphous adenocarcinoma. Something that's been mentioned in the text and in the literature as well is a useful point in distinguishing the polymorphous adenocarcinoma from an adenoid cystic carcinoma is in the way the former, the polymorphous adenocarcinoma, infiltrates the minor salivary gland. It tends to just seep in and just occupy the spaces in between the minor salivary glands without necessarily causing the normal myelin glands to sort of undergo atrophy and regression. In other words, it tends to sort of have not much by way of junction between normal background minor glands and tumor itself. And the S100 positivity is strong and diffuse in the polymorphous adenocarcinoma, whereas it is a lot more patchy in adenoid cystic carcinoma. So a bit of a rush there, but I just hope that these are some handy hints, some helpful hints that are not often mentioned in the textbooks that may help you distinguish what may be tumors with highly overlapping features. Let's go on to talk a little bit about some of the new entities. There are 4 benign and 4 and a bit malignant tumors. So the mucinous adenocarcinoma made its first appearance in 2015 and then was sort of dropped in 2017 and then got reinstated in the most recent classification. So with the benign entities, you may well be familiar with the sclerosing polycystic adenocyst, which has now become an adenoma, a recognized benign neoplasm. These are some of the salient features, the principal features. They are well circumscribed and often at least partially encapsulated. It is variably cystic. In other words, you do not need a prominent polycystic component. They can be quite solid in some instances, and the cysts can be quite variable in size. They're composed of proliferative ducts, myepithelial cells, and acini. So both components. So in effect, all stages of the trajectory. They have large hypereosinophilic cytoplasmic granules, and an intraductal apocrine proliferation may be present. And many authorities say that these prominent orange, densely staining granules are what help make the diagnosis. Here are the examples that are in the WHO website accredited to Professor Thompson as typical examples of the sclerosing polycystic adenoma. So glandular proliferation with intervening hyalinized component, and also under this subject, a more solid variant, so plentiful interlobular hyalinization, but at least at this low power, not necessarily needing to have prominent cystic degeneration. Perhaps some there, some cystic ductal degeneration, but in this case, a minor component. So although it says polycystic, I think although it's more commonly polycystic, it is not a defining criterion. And then grateful to Dr. Peterson for reminding us that it can have a range of morphological components within the same tumor, from cell clearing to apocrine to more solid areas, and sometimes a bit more sebaceous-like as well. Just to remind you that sometimes they can be microcystic. But here is what these authorities mention: this brightly orange staining intracytoplasmic granules, reminiscent of the more basophilic ones in the actinic cell carcinoma. But interestingly, if you look long and hard enough in a lot of other tumors, and in fact, even in some of the more reactive changes in salivary glands, you will see this changes in place from time to time. So helpful, but again, not an absolute criterion. So again, we have recognized the intercalated duct hyperplasia for many years, and we often write this off in the background. But now it is included and recognized as being either a hyperplastic phenomenon or a truly neoplastic adenoma. And this is a picture I took in preparation for this talk, just to remind us that with the intercalated ducts, they still remain biphasic. They still have a luminal and an abluminal component, and hopefully you can just about see some compressed abluminal or myepithelial cells in the background, and they still take along with them some of their intercytoplasmic granules. And these are helpful because in this case, a nice solid area. These are helpful because it is often in the intercalated duct adenoma that you look for these basophilic intracytoplasmic granules, and they sort of merge with the background acini sometimes, or incorporate some of those acini with their darkly staining intercytoplasmic granules. So a helpful diagnostic criteria. The striated duct adenoma, I can't necessarily say I've made the diagnosis myself. I've seen them in study sets and in meetings, but they should be distinguishable. And I've put this table together just to help us differentiate the intercalated duct from the striated duct adenoma. And I suppose the most important distinguishing feature is that the intercalated duct adenoma is bilayered, whereas the striated duct adenoma is a single layer with minimal intervening stroma, so much more tightly packed. You may or may not have come across the microsecretory adenocarcinoma. This is defined as a low-grade but malignant infiltrative neoplasm in the WHO. It is composed of microcystic tubules, and something that's characteristic are these more basophilic secretions within the microcyst, within the lumina, with flattened cells, oval hypochromatic nuclei, and an intervening basophilic fibromyxoid matrix. They tend to be not often circumscribed, but well delineated, but have edges that are infiltrating into the surrounding adjacent structures. This is the immunophenotype, and as I mentioned before, this joins the polymorphous adenocarcinoma as having the P63 positive, but the P40 negative immunophenotype, but it has a defining translocation, the MEF2C SS18, at least for now, the MEF2C SS18 translocation, which helps support the diagnosis. I'm grateful to our colleague, Dr. Bill Barrett from East Grinstead for providing these photomicrographs from his files. But it is quite characteristic. So even at this low power view, this is an intraoral case with the overlying squamous epithelium. And even at this power, you can hopefully appreciate that the tumor is composed predominantly of these microcystic areas. And even so, there are intervening lightly myxoid matrix between the two. And again, although reasonably well demarcated, he makes the point that it is infiltrative in places. Again, infiltrating or abutting at least the adjacent minor gland. And this high power view is rather helpful. The sort of bluish, lightest bluish secretions in these microcysts are helpful in making the diagnosis, but ultimately it is perhaps the MEF2C translocation that may help clinch the diagnosis. A diffuse S100 positivity, and it has a P63 component, as I mentioned before. More P63 positivity, and unfortunately, I haven't got the P40 staining to demonstrate its P40 negativity. Now, you will remember that WHO have called this a low-grade malignant neoplasm. As soon as the beta version went live, this group in a single case study as a correspondence in histopathology said, well, actually not all microsecretory adenocarcinomas are low grade. They report one with more aggressive or high grade transformation, which also did have the MEF2C translocation. Which brings me on to just a gentle reminder that, again, salivary neoplasms are notorious for having areas of high-grade transformation. And I've tried to put this in some sort of hierarchy. The tumor which most commonly shows a high-grade transformation is the acinic cell carcinoma, followed by the secretory, etc., etc. These have been quantified by Professor Skalova and colleagues. Before I finish off, which I think I should, because I think my time is coming up, just a practical point, really, and I'm hoping Anne will agree with me. This is common practice where a salivary neoplasm goes for an FNAC diagnosis and gets given an FNAC diagnosis according to the Milan criteria, and sometimes it may come back as a tumor with unknown malignant potential. And I suppose the reflex would then be to suggest a core biopsy. And sometimes it may be helpful, but oftentimes the core biopsy may not necessarily help to advance the diagnosis or to make a definitive diagnosis, even though it may have tissue which we may submit for cytogenetic analysis. So that's a helpful point, but we are able to do that on FNA cell blocks as well now, as Anne mentioned just now. And I know there is a growing trend amongst the histopathology community, therefore, to approach, if you can't make a definitive diagnosis on the core biopsy, to then maybe sign things out as either benign stroke low grade versus high grade, which then helps our surgical colleagues to decide how then to treat this, whether they need to go more radically, or whether they need to do a limited neck dissection, or whether they can limit it to a simple superficial parotoidectomy, or perhaps even a lumpectomy. So that may be a helpful hint in how we approach this. And I remember Nora Katabi and Professor Cipriani mentioning that that is their usual way of diagnosing these things. And I think that's maybe how we might go in future, because even if you have a pleomorphic adenoma with a degree of atypia in a core biopsy, you really need the capsule before you can pronounce on the degree of aggressiveness, or whether it's an intracapsular or a bit of a pleomorphic adenoma with atypia. So perhaps it's worthwhile applying a little bit of caution in being too definitive on a core tissue biopsy. And on that thought, I think I will leave it. Otherwise, I might run over time too much. So I think maybe we can stop it there in time for any potential questions. So I have to apologize really that was a real tour de force of what is a difficult area, which so I hope I did it I didn't do it too much injustice. Thank you.
It was excellent, Selvam. Very brave of you to even attempt that update from what I've seen in the WHO.
Yes, and some of these are exceedingly rare, and the debate still goes on, as with any classification of any tumor site. It is always an evolving classification, isn't it? And I'm not sure what
Absolutely.
your thoughts are in terms of, sometimes we cannot make a definitive diagnosis on core
Yeah.
biopsies. Sometimes we can, but often it's useful to exercise a bit of caution. I'm not sure if you would agree.
Absolutely. I think you put it in a nutshell, really. And I think it doesn't help when the surgeons have a go at sampling them themselves. And I think, you've got a much better shot if you've got a one-stop clinic or a radiologist with under ultrasound guidance doing the biopsies.
Indeed.
Oh, okay,
Thank
Well,
you.
so
Thank you for this nice talk about this complex topic, definitely.
no doubt
So,
there'll be a barrage of questions
just
or controversial
one of
comments,
your
perhaps.
last slides mentioned the role of core biopsy in distinguishing between benign and malignant salivary gland tumors. What about the role of FNA? What does it play? What is the role of FNA in diagnosing salivary gland tumors?
My thoughts are that as we move globally towards a more standardized approach to adopt the Milan classification, and I personally don't practice cytopathology. I'm not sure what your thoughts are, Anne, but just like the thigh classification in thyroid cytopathology, the adoption of the Milan classification is useful in the initial management, I think. So that those are my thoughts. Sometimes it's useful for putting it into a definitive malignant category, or even pronouncing with a degree of confidence the type of malignancy. But often there is some room for doubt. So again, be cautious, because there are huge overlapping features. So a basaloid cytomorphology doesn't necessarily mean it's a basal cell anything. An oncocytic cytomorphology, opens up a whole host of different things. Clear cell morphology, it still includes a whole range of benign and malignant entities. So yes,
yeah.
there is a role. Sorry, I won't. Yeah, and I'm sure you've got some
No,
comments.
I was just reminded at our MDT, I have to tell the surgeons off because they start giggling when the cytopathologists say it's a sump, SUMP, because in English that means somewhere where sort of residual oil is sort of anything's dumped. But we have seen secretory carcinoma diagnosed on a core biopsy, on a cell block from an FNA. We have seen that recently. I think that when the stars are in the right alignment, when you've got really good clinical correlation, when you've got an excellent biopsy, when it's not cystic, that you can definitely get very far with an FNA. But the rate, we're just looking at actually our series of core biopsies and cytopathology to see the rate of concordance of the final diagnosis. But I think it's here to stay. And I think, as you say, Selvam, using the Milan, doing cell blocks, all of that is here to stay, I think.
No, absolutely, and I think that's a really useful comment because I also think it might be useful to have a look at the rate of um, core biopsies that have progressed the diagnosis
Mhm.
more definitively, and I'm sure there will be
Yeah.
quite a few, but I
Mhm.
wonder how many would be. But I think our surgical colleagues find it helpful.
Yeah.
Essentially, it needs to be
Yeah, they
removed,
do.
but to what degree? I think
Exactly.
it is helpful.
Yeah.
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 Yeah, there is comment from Dr. Adela Chimich saying that she finds salivary gland neoplasms very difficult on FNA samples.
Yeah, we are. I haven't done cytology since 1996. I would not. I can't imagine how difficult it is to actually diagnose FNAs of cytopathology. But there's Ash Chandra. We're very lucky because we've got Ash Chandra, who I think is currently president of BAUS, and he's just been awarded an award by the International Association of Cytopathologists. So it's a special interest of his.
Mm.
So we're quite lucky, and he's looking, but I think it is extremely difficult. So she's not alone, and
Yeah.
I think you have to be use the terminology conservatively and try to construct your report around a recognized classification.
Yeah. There is one more question from the audience asking if we have only a small biopsy specimen with morphology consistent with adenoid cystic carcinoma, but there is no definitive signs of malignancy such as perineural invasion or invasion in surrounding tissue, how would you report and how much helpful is a MIB in such case?
This is on a core biopsy. Was that the question?
Yeah,
Mhm.
that was a question about, yeah, small biopsy, yeah.
I think very useful. I think if all the features go along to support it, uh, you know, H&E morphological features, in terms of its cytomorphology, if you have the right stromal component, you might even have the dual sort of population. If you haven't got perineural invasion, it's just may not have been sampled appropriately, or in some instances we see more rarely. I mean, most adenoid cystic carcinomas we see are highly infiltrative, but sometimes they can be reasonably well demarcated. So I think if you have the histological features and the MYB translocation comes back as being translocated, I think you can have a really high degree of confidence in making pronouncement of an adenoid cystic carcinoma.
Yeah.
Now, to what degree, how infiltrative it is, then maybe the radiology, the clinical information may help guide you to how infiltrative it might be. But yeah, I think you can. Would you agree? And I think you can be confident in
Yeah,
making a
I,
diagnosis.
I,
Yeah.
I think there are two MIBs to consider: is the MYB and the
Mm,
MIB immuno.
mm,
And I think
mm.
the MIB immuno MIB, key 67, is quite useful as well,
Yes.
because I think in
Yeah.
adenoid cystics it's usually quite high,
It
whereas
is.
in other neoplasms it's quite low. But
Mm,
that's the only comment. But otherwise, I agree
yeah.
with you entirely.
Mm.
Yeah.
I suppose it depends. If it's the cribriform, the tubulotrabecular,
Mhm.
may be easier to nail, but it's
Mm,
the solid ones that perhaps might be more
mm,
challenging in,
absolutely.
in 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 excluding any other high grade basaloid neoplasm. But again, the MYB translocation
Yeah,
will be highly useful.
very much.
All right. Thank you very much. Thank you for this nice talk. I think we can now proceed with the last, but not least, session about challenging cases in hand and neck pathology.
Thank
Please.
you. Uh, I'm hoping, do you have my screen?
Yes, thank you.
Yeah, okay, thank you. So I'm not going to attempt a WH update about noses because this is the last session, and you would have to sit looking at a lot of histology that all looks the same, with incredibly difficult translocations and molecular, and it's all been done so well in the literature by Justin Bishop, Abbas Agami, and Lester Thompson, etc., James Lewis, and all the Americans and the Europeans. So what I'd like to do, again, as a card-carrying, jobbing, head and neck histopathologist, is to share with you cases that I've found difficult, and maybe update your knowledge about the crossover area between where our work is influenced by the neuropathologist. So I remember talking in my the macro talk. There are areas probably along this line which would overlap with the neuropathologist at the top of the nose, in the temporal bone, pituitary, etc. So I'd like to talk about ectopic lesions, lesions that you wouldn't expect to find in the nose, and you might have to call in for reinforcements. So the first case I'd like to tell you about is a middle-aged man who came in my other life, where I worked at Imperial College. He presented to our head and neck team with a nosebleed, and the biopsy was taken by ENT surgeons, and the histology was seen by a general histopathologist. So the general histopathologist did the set of immunostains as you would expect, found it was CK7 positive and low molecular weight cytokeratin positive, CK20 negative. All neuroendocrine markers were positive, a low Ki67, and CD20, S100, all those things negative, and suggested a low-grade neuroendocrine tumour. So 2 specialists saw it, 2 different MDTs, and there was this sort of detached respiratory type epithelium, and then there was tumour in the background, and the tumour was quite concerning. It was pleomorphic, moderately. There weren't many mitoses, there was no necrosis, and there was a bit of apoptosis, and the 2 specialists said, okay, this is a poorly differentiated sinonasal carcinoma with neuroendocrine differentiation. So the patient went on to have radiotherapy and chemotherapy. 3 years later, he's alive. The tumour hasn't got any worse. So he went for endocrinology appointment because of galactorrhea, and then was reviewed at the pituitary MDT by the neuropathologist. And the neuropathologist spotted a tumour in the pituitary area. And the biopsy reviewed by the neuropathologist was positive for prolactin, and it was over 4,000. So he had an ectopic pituitary adenoma, or a giant pituitary adenoma, with an excellent response to dopamine agonists. This was a very chastening experience. Then another patient presented with a nosebleed with a very big tumour, again in a not dissimilar area, and showed similar features. And this, again, slight pleomorphism, no necrosis, no mitoses, ACTH positive, and this is a big pitfall. The pituitary adenomas presenting to us and to our surgical colleagues can look quite worrying. They can be locally aggressive. They can really be quite big. And if they're dealt with by non-specialists with inadequate clinical history, you can have an erroneous diagnosis of a metastatic carcinoma, olfactory neuroblastoma, sinonasal neuroendocrine carcinoma. So the tumours can be really big, and they're less commonly, they're away from the pituitary, and they can be ectopic. All the histotypes are represented. They're not usually malignant, but they can be locally aggressive. And I suggest that if you get findings like this, then you make friends with a neuropathologist and just run it by them and just say, am I missing anything here? So this is as if you have something rare, ask Lester. He'll have the biggest series, and this time he's got it with Raj Sitala and Susan Muller. So he looked at those. So the interesting thing to note is pituitary adenoma is negative for CK7 and CK20 usually, and they're all synaptophysin and chromogranin A positive. So the next study I'd like you to see is a 46-year-old woman. She presented with a severe headache and had a tumour in the clivus, the pituitary area, and had a biopsy, and the respiratory mucosa was uninvolved. There seemed to be reactive bone around an infiltrative tumour. So this infiltrative tumour had wasn't really forming glands. It had, if you like, it looks like plasmacytoid appearance, no mitoses. In areas, it looked like a paraganglioma, really, with these so-called Zellballen or nests of cells. Still no mitoses, no necrosis. CK7 absolutely positive. So we know that pituitary adenoma isn't usually positive for CK7. And in the very first case I showed you, although they said CK7 was positive, it wasn't very positive. It was a bit patchy. So this is diffusely positive for CK7. Pituitary adenomas are usually not. So what else could it be? And it turned out, looking at the clinical history, the woman had a mastectomy in 2013 and has actually had a grade 3 ductal carcinoma. So the pathologist went back and stained it for ER and HER2, which were positive, confirming that this was a metastasis from the known breast carcinomas. So very unusual. So only about 0.4% of skull-based tumours will be metastatic in that area. All types of cancer can be found there, but usually prostate or thyroid cancer is more common, and they often present with a sixth nerve palsy. So it may be that a site predilection, as I've said before, why don't we look at where it is and look at the clinical history? So in the clivus, you might expect a metastasis or chordoma or a myeloma. Chondrosarcs in the petroclival fissure, nasopharyngeal carcinoma with direct invasion of the clivus and retropharyngeal, but it would be centered in the nasopharynx. Invasive pituitary, and it's above the basophenoid, extends inferiorly. And cholesteatoma, that would go from the middle ear. Fibrous dysplasia, that would have characteristic radiology. And so would chordoma, chondrosarc, or myeloma. So you get the point. So what I'm saying is you don't make a diagnosis of a rare, unusual tumour without having the full history and a proper radiological assessment of what's going on with the patient and a knowledge that these things are out there and that really there may be geographical clues, there may be age clues, there may be a previous history to consider. Okay, so now let's go on to, this is a true story from my own department about 2 years ago. 32-year-old man came in with central vision blurring and headaches, and he went to an ophthalmologist and had high blood pressure. And he was only 32 and his blood pressure was 214/126. His CT head was nothing was seen. But 3 years later, he presented with ADH, inappropriate ADH secretion syndrome. There was nothing in his kidneys, and a dotatate scan highlighted a small mass on his right middle turbinate. And this was thought to be possibly significant. So that was biopsied, and when I saw it, I didn't really know what to call it. It was clearly a round blue cell tumour. A lot of fibrillary matrix in the background, bland, not really much atypia at all, and wondered what it was. So applied markers and found that it had paranuclear dot positivity for pancytokeratin, but it was CK7 negative, etc. And very strongly positive for neuroendocrine markers. So I wondered about olfactory neuroblastoma, but the S100 was odd. The staining was quite diffuse, but there were no sustentacular cells. So I thought, I'm not sure what I'm dealing with here. It's neuroendocrine positive, very low proliferation rate. So I sent it off to a specialist at our sister hospital at King's College and said, "Can you help me?" And he applied a whole lot more immunostains and found it was positive for NUN and TTF1. And he found neurofilament quite strong. And he felt it was a low-grade neurocytic type tumour. And the best fit was a neurocytoma, not an olfactory neuroblastoma, but neurocytoma. However, he did do a long essay about the lesion and said, like, it's so rare, and maybe this might be a very much lower grade version of an olfactory neuroblastoma, so like Hyams 1 olfactory neuroblastoma. So interestingly, olfactory neurocytomas have been linked with inappropriate ADH secretion, paraneoplastic type syndrome, not just our paper. And this was reported by my colleagues without letting me know, actually, which is clinicians sometimes do that. They sort of let you know as an afterthought anyway, especially when it's a rare or unique case. So a central neurocytoma, you'll agree, has similar sort of histology to what we could see, but it is really a well-recognized tumor in the ventricles. And an olfactory neuroblastoma, we are taught, has this characteristic vascular congeries in the background and has sustentacular cells and has mitoses sometimes. So anyway, I think they believe that these olfactory neurocytomas exist, and it's sufficiently different from central neurocytoma and from olfactory neuroblastoma to fulfill the criteria. But I think it's beyond my pay grade. However, the patient is doing well. The tumour's gone. The sodium's normal. His blood pressure's still a bit high, but he's doing very well. And now these things never come in ones. I had an interesting case sent up from Leicester, and this time it's more lobular, but the cytology reminded me of the case I've just shown you again. No real atypia, no mitoses, that neurofibrillary background, chromogranins, S100 really odd, cytokeratins negative. And the differential again includes low-grade olfactory neuroblastoma Hyams 1, olfactory neurocytoma. So my colleague this time in Manchester, Fede, who's a absolutely brilliant neuropathologist, very interested in pituitary and such lesions, thinks he wants to call this one the lowest form of neuroblastoma. But methylation profile was unsuccessful. Not sure exactly why, whether it's a processing issue or whether it was decalcified. I don't really know. But sadly, we couldn't confirm a methylation profile for olfactory neuroblastoma. Okay, so I'm changing tack. You can see how they all look pretty similar. So we've got another lump in the nose. Patient presenting, this time 46-year-old female, presenting with nasal obstruction. And she had a very odd looking tumour that looked indolent but sort of locally aggressive. And they decided they would sample it, and it was quite papillary and sort of granular. And on histology, maybe some of you are screaming at the screen now because you know what it is. So it's a sort of spot diagnosis. You have this almost ameloblastoma-like background, and you have keratin whorls here. And you can see it on a higher power with this reverse polarity, almost stellate reticulum-like. And there's keratin with ghost cells. And here it is cuddling up to the bone, but not really infiltrating it. It's quite indolent, expansile. And here again, you can get microcalcification, lots of this ghost cells, keratin, again, higher power there. And beautiful, you could photograph that for an ameloblastoma. So this is an extracranial craniopharyngioma, and again, a very rare diagnosis. Again, you associate these with brain tumours in children, but they can occur in adults. They can be ectopic, and it's quite a spot diagnosis. So once you're aware of it, you see it again. It's less than 40 cases reported since 1924, and it's usually inside the skull. As I say, 3% of all intracranial tumours. It's believed to extend sometimes along craniopharyngeal duct, and it can involve the sella turcica, the sphenoid sinus, and nasopharynx, as in this case. So it's usually children. Histological subtypes include the one you just saw, an adamantinomatous subtype, and papillary squamous. And so that was a very interesting case. Interestingly, the clinician had said when they operated, they had seen this brown stuff, so-called engine oil in descriptive reports. And treatment is surgical, but if you can't clean it all out, they would consider radiotherapy for recurrence. Okay, so again, this is another case report some years ago. So there is some malignancy associated with craniopharyngioma, but again, it is case report type material, but it's just to be aware of it and things that can occur in the nose. So I think this is the last one. I'm not sure. This was a 47-year-old patient, and this is a sort of segue into Selvam's talk and bring him back in to the arena. This was sent as a lesion in the nasal septum, so it was orientated with top and anterior. So we inked it differentially, just the bit that was clearly the mucosal area, and left the mass lesion, and we sliced it as shown. And this was unencapsulated salivary type tumor that looked for all the world like pleomorphic adenoma. And this has the respiratory mucosa is respected on the top, but you can see the characteristic chondromyxoid stroma, myoepithelial and epithelial cells. And they happen in the usually in the turbinate, but they happen in the sinonasal tract. And so don't be surprised. Don't think your cases have been mixed up necessarily. But again, you have to get all the clinical information together. You have to find out what the imaging shows and where the lesion is. So it's extremely rare. Non-specific obstructive symptoms. Surgery is the treatment of choice, and usually it can be done endoscopically. But if it's not taken out completely, it can recur. And those look like they're originating from the paranasal sinus may be indicative of higher grade disease. So I'll stop there actually and bring Selvam in, and also get ready for the case discussion. I hope you forgive me for avoiding the update on the small round blue cell tumours in the nose, and enjoyed instead the cases that I found difficult and enlightening, actually.
No, definitely, and I think we've all had experiences of cases of colleagues writing up case reports
Exactly.
without
You have to laugh.
necessarily
Yeah.
letting us know.
I just saw it in print when I did a literature review survey.
Yeah.
I thought, oh, interesting. Yeah, that's nice.
Which,
At least they
which
put
is
my name on
which
it, I
is
suppose.
disappointing, because
Yeah.
the most important person in the whole workup would
Yeah,
have been the person who made the diagnosis, i.e. yourself.
quite funny. I know it. Quite funny. Anyway, they were so excited by it. Yeah. Okay, so any questions, Samia?
Yeah. Speaking of this olfactory neurocytoma or low
Yeah.
grade olfactory neuroblastoma, what do you think about this entity?
I find it really difficult, Samia, and I'm hoping that the last one that has been called Hyams Grade 1 olfactory neuroblastoma has just been resected in Cambridge, and we have a colleague there, Robert Kennedy, and I've written to him and said, please, could you send some of the material? Is there any way we could get methylation status? Because that would be looking at the epigenetics is probably the way forward. They're very rare. Like, I've got those two cases, they're about 10 years apart or whatever, but maybe not quite that long, but quite a way apart, but they exist. And the S100 does not show sustentacular cells. But again, it's an overlap between the neuropathologists and the sinonasal pathologists, and neuroendocrine tumor occurring in that area in the clivus. So the imaging, we called everything in, and the consensus was that with the imaging, it was best regarded clinically as a low-grade olfactory neuroblastoma. They would endoscopically resect and watch, and if they thought it was coming back, they would irradiate.
Right. What about this case of extracranial craniopharyngioma, this unusual, peculiar case, I would say? Does it harbor BRAF mutations? Do you know?
I've no idea. I haven't looked into that actually. I think they're
I just
very
wonder
rare,
if,
yeah, but
papillary
it's worth doing.
craniopharyngiomas.
Yeah, it's worth doing. Yeah, I think I don't know that answer, but I will. I'll look. I will now go away and find out. Yeah, but I'm not
Okay.
sure.
But what about the origins? I mean, histogenesis of this tumor. We know the histogenesis of intracranial
Yeah,
craniopharyngiomas, right?
yeah. So it's a bit like the midline thyroglossal duct cyst with these things. There are certain structures within the brain that follow a tract, and so it may be simply an embryonic rest, or it may have developed from stem cells in the area. But nobody really knows, and she's quite older, but they reckon that it's probably been there for years and grown to a size that then it gives symptoms, but they think it may be an embryological rest.
Yeah, it makes sense.
Yeah.
Yeah. All
Mm.
right. Thank you. Thank you very much.
Okay. So I think, are we ready to start the cases, do you think, Selvam?
Um, I am if you are.
Yeah. Okay.
Samir, are we happy to go straight into the next session? I think we're running a
Well,
few minutes early, actually, which
we
is,
are
for me at
actually.
least, unusual.
Yeah. Yeah, we are, I think. What is the consensus? If there are no questions, should we just carry on? Are you getting a consensus in the chat? Are they saying let us go
Yeah,
home?
I'm
Or
following the chat. There is no any other question that is currently there, so we can proceed with the next session. No problem.
okay.
Will you be happy to kick off with the first case, please, Anne? Is that okay?
Yeah, yeah, yes,
Thank you.
absolutely. Let me share my my screen if I can. Um, do you have it, Selvam?
Yes, it's up.
Okay. So a male aged 48 years, and we just got this on the form. It's a 2 by 2 centimeter fibrous round sessile lump on the buccal mucosa UR4, which blanched on local anaesthetic administration. Tender and present for 2 months. Impression pyogenic granuloma or possibly sinister. Now that's pretty good information. We have access to a clinical photograph library. So I think looking at that, we'd probably think, whoa, maybe sinister, but you never know. So this patient was 48, he's non-smoker, no alcohol. And he had a first thing, he went along to his dental practitioner who did an OPG, and these remain a mystery to me, and I'm sure Selvam is seeing all the appropriate things, but they saw some bone erosion and some soft tissue extension and decided they'd do some more scans. So the scans were much more informative because this lesion was actually hot on PET, and it was causing a problem, an erosion of the buccal cortex with extraosseous soft tissue extension and displacement of the buccinator muscle, enhancement of the roots of the corresponding teeth, and attenuation of the palatal cortex felt to be odontogenic extraction. And then the UR3 tooth mildly displaced anteriorly. So this lesion was causing problems around the roots of the teeth and extending into soft tissue. So they took a biopsy. So immediately at 20,000 feet, you can see, well, it isn't easily inflammatory. It doesn't look squamous. It's not ordinary mucosa. And it looks spindly. It's not a pyogenic granuloma. It's not vascular enough. what is it? And on higher power, it was like really worrying. So you can see lots of mitotic figures. And there was inflammatory cells. So really, what do you do with this? So I threw a lot of immuno at it, and I felt that there was quite significant cytokeratin, and there was SMA. S100 there was quite a lot of S100, and the MIB was really high. There was no background dysplasia. He's a bit young. He's a non-smoker. He's not drinking alcohol. Desmond was also showing some scattered cells throughout. So I just thought, what is this? It looks malignant. It's probably a sarcoma. Let's send it off to our local sarcoma unit. Well, what came back was quite exciting. They got very excited about this case. They said it's diffusely positive for ALK. It's patchy positive for cytokeratin and MyoD1, and there was some expression of myogenin. Some of you may be screaming at the screen at the moment, but I was still none the wiser. And then they said there was EWSR1 gene rearrangement showing an abnormal signal pattern. Not clear exactly what that was, but no FUS gene rearrangement. So the bottom line came back saying that we think this is a high-grade spindle cell sarcoma with rhabdomyoblastic differentiation, and the morphology, together with ALK, favour a primary rhabdomyosarcoma of bone, incredibly rare, newly described, and our tumour is likely to have this EWSR1 TFCP fusion. So it's a TFCP fusion tumour. And there is a high incidence of fusions in primary rhabdomyosarcoma of bone, with two molecular subsets, our one and the other one, which is the MEIS1 NCOA2. So is there a difference between them? Well, yes, in that these tumours are usually diffusely positive. The ones carrying the MEIS1 NCOA2 gene fusion are usually very strongly positive for Desmond, and there's focal myogenin positivity, where ours, they can be spindle or epithelioid. Desmond and MyoD1 may not be helpful, but the helpful marker is ALK. So these tumours are ALK positive. And we should be aware of them because in this series, the craniofacial bones were overrepresented. So in this series of 12 cases, 8 occurred in the craniofacial bones. They all showed a bit of keratin, a bit of Desmond, and MIF4 or MyoD1 expression. ALK was overexpressed in almost all of them. And this fusion, TFCP2, was fused to either EWSR1 or FUS. So I'd like to make you aware of this case. So the case is stained focally for myogenin, diffusely for MyoD1 in this case, but diffusely for ALK. So I'm going to change my practice now and include ALK in any tumour that I consider to have rhabdomyoblastic differentiation in this odd clinical setting. So the final diagnosis was primary rhabdomyosarcoma of bone, and this may become possibly the world's third case report, or maybe there's a dozen or so. But I hope you agree, extremely interesting case, and shocking really, because Cyril Fisher once said, don't know why you want to do head and neck, they're all squamous cell carcinomas. And I think we just proved him wrong, even though it looked like one. It did look like one. I'll give him that. Okay.
Thank you for sharing this peculiar case. Definitely, yeah. But you ruled out metastatic cancer, right?
Yeah, he had. You're absolutely right. I didn't go into the details of all the investigations. They scanned him from top to bottom. It looked like a locally arising tumor. A PET scan was clear, other than in that area. So
Okay.
yeah, and that's how. And then the sarcoma people, given this clinical scenario with this particular immunopattern, including the diffuse ALK and the translocation analysis, they were happy that this is what it was. Yeah.
All right. Thank you. Some of the participants are impressed by the primary rhabdomyosarcoma of the bone.
Oh, right. Yeah. It's a very interesting, so am I, but it wasn't my diagnosis. So I'm just admitting how, how we need to work with each other and be aware of things, because you see, they're rare. And so as many people all over the world need to be aware of it. And if you see one, think of it, perhaps get the ALK, and then ask a friend who's got that molecular pathway analysis tools to help you.
All right. Thank you very much. There is a quick question. Which ALK clone was used? Is it the
No,
D5F3 or?
I'm afraid I don't know. I'm one of the pathologists who say ALK, please. And then I leave the clones up to somebody else, I'm afraid. But I'm not sure. And it's at Stanmore. It's not my unit, so I don't know what they use. But Roberto Tirabosco, Adrian Flanagan, they're in London there. And the Portuguese lady, Fernanda Amari, they are there and would be happy to take questions about ALK clones.
Okay. Thank you. Thank you very much, Anne.
Okay, so can I go ahead with the second case, Samir?
Yes, please.
Okay. Oh gosh, that's, technology has worked well so far. Don't let us down now. Hopefully, you can see some text on my screen now, or
Yep.
maybe not.
Oh, there you go.
Oh,
Yeah,
lovely.
that's fine.
Thank you very much. Thank you. So, I'd like to present this case, which came to us in the last sort of couple of years, really. A 39-year-old female who over the period of a year had periodic epistaxis, which ultimately got quite bad that she presented to the accident emergency department, which required packing. And on examination there, they identified a nasal mass, and that triggered some investigations. So what was identified was essentially a mass lesion that was around the middle turbinate, but had extended into the sort of the frontoethmoidal complex, but without, at this stage anyway, intracranial extension. And so what happened was a debulking procedure, and this is what we have. So the mass was uniformly of uniform appearance, like so, on low power. It was extensively ulcerated with quite a lot of fibrin exudate, at least in the debulking specimen. We could not find any surface epithelium, any respiratory epithelium to compare with. On higher power view, there was a uniformly cellular tumor composed of these rounded and sometimes occasionally spindle cells, often with a bit of cytoplasmic clearing, but and a small degree of nuclear pleomorphism. Occasionally, these tumors formed little clusters and strands and aggregates. And if you scanned a bit more around the place, there were some cells that had undergone nuclear molding, some large cells with a bit of pleomorphism, all in the background of a likely myxoid mucinous stroma. So at this stage, I suppose we were thinking along the lines of a salivary type neoplasm up in the sinonasal cavity. And I offered this is my first port of call, the Alcyon Blue PAS, just to demonstrate that it was truly glandular in nature. So we used that as our sort of intersectional control of the resident glands in the sinonasal cavity. But these glandular structures were evident in places. They were few and far between, but there was definite glandular formation despite this uniform solid morphology. The tumor was strongly and diffusely positive for cytokeratin 7. When I did the Ki67 proliferation index, I nearly fell off my chair because this is highly proliferative, as you can see, which was quite interesting because it wasn't quite reflected in the cytological aggressiveness or lack of the tumor. So this was interesting anyway. P63 was strongly and diffusely positive, with some components being more positive than others. I hope you can appreciate that. And there was again strong and diffuse calponin positivity. So at this point, I was sort of heading down the line of some sort of myoepithelial differentiation, sort of a sinonasal adenocarcinoma, perhaps a salivary type with a predominant myoepithelial phenotype. But I continue to hunt around more and more, and there's this inflammatory component. There's a bit of normal epithelium in this section here, um, but there emerged this sort of cribriform arrangement of tumor, highly reminiscent of adenoid cystic carcinoma. And this is a high power view of it. And I hope you can agree with me, at least on architecture, it does remind you of the cribriform arrangement of an adenoid cystic carcinoma. So at that point, having been a little bit excited, but also having been in the past disappointed with P16 positivity for true adenoid cystic carcinomas of the sinonasal tract, we reached for the P16, and it was strongly and diffusely positive, unlike primary adenoid cystic carcinomas of the sinonasal tract, which tend to be very patchy or has this biphasic population. This wasn't biphasic for the P63 as you saw, and it had strong and diffuse P16 positivity. And we followed that up with a high-risk HPV DNA in situ hybridization, and that led us to the diagnosis of this entity, the HPV-related multiphenotypic sinonasal carcinoma, which is a growing group of disorders in the sinonasal tract that has now been recognized in the WHO classification as an entity of its own. So just a few points about the background. When it was first originally described by Professor Bishop and colleagues, the name which was given to it was the HPV-related carcinoma with adenoid cystic-like features of the sinonasal tract, which was a bit of a mouthful, but I'm not sure HPV-related multiphenotypic sinonasal carcinoma is any less of a mouthful, but perhaps an improvement. Interestingly, the vast majority of HPV types that are responsible for this carcinoma is the HPV type 33, which is a high-risk type HPV. But interestingly, HPV 16 has been reported, but only in a very minor component. I think this is very interesting, especially for those of you who come from units where your DNA in situ hybridization or your PCR techniques are type specific for 16 and 18. In our institution, we use the high-risk cocktail approach, which does include HPV 33. So I don't think very many people know why it has a particular predilection for this HPV type as opposed to any other HPV type. That may have something to do with the way it presents in this particular phenotype. As in our case, MIB arrangements are not identified. And again, I think it's important to remind ourselves that although this is an interesting entity and is somewhat exclusive to the sinonasal tract, conventional adenoid cystic carcinomas are still far more common. One of the useful diagnostic criteria which are used for this is associated surface squamous dysplasia. Like I said, in our case, it was extensively ulcerated. We could not see it there. And as the WHO has stipulated, you need your specific high-risk HPV test. You cannot use P16 alone, and that really goes for all sinonasal tract HPV-related carcinomas. And at least for the moment, despite its rather shocking proliferation index, it has an indolent behavior. Although local recurrences are common, regional spread and tumor-related death have yet to be reported. So I just wanted to, reintroduced this interesting entity. Like I said, when it was first described, it was predominantly adenoid cystic, and then since then, a range of other salivary type phenotypes have been reported, including epithelial, myoepithelial, as well as ones that are slightly more non-specific adenocarcinomas. So yeah, I thought this was a nice case. Thanks to Anne for her contribution in reaching this diagnosis as well. Thank you.
That's a great
Thank
case.
you. This is another amazing case, huh?
Absolutely.
So we cannot talk here about the sort of de-differentiation in ACC, right? Or transformation of ACC because it's MIB negative and HPV positive.
Yeah, absolutely. Yeah, I take your point. So, is this, theoretically, could it have been an adenoid cystic carcinoma that has been
Yeah.
secondarily colonized, or had in its transformation pathway, one of the hits to, being
But at least in the
HPV?
breast,
I
at least in the breast, there have been cases of adenoid and salivary glands that undergo the differentiation or high-grade transformations, or so-called.
Yeah.
yeah,
This isn't
yeah,
high grade. That's the thing. This is not high grade, so there's no evidence of a high grade transformation. There's no
yeah.
evidence of to diet. In my understanding, Selvam, do you agree that to get high grade transformation, you need low grade of the original tumor, and we're not
Absolutely.
seeing it?
No,
Yeah,
and it's uniform, and it has the salivary phenotype, and it's so as I mentioned earlier, you have this growing diversity of different salivary phenotypes, and so I think that's why the multi-phenotypic terminology came into being. So,
that's it.
Right.
although most
Yeah,
of them were adenoid cystic-like, there
yeah.
are
And they started
polymorphous
mentioning it
adenocarcinoma.
here.
Yeah,
I
yeah,
think they just started testing everything. They just tested everything in sight
yeah.
and found
But
a few. Yeah,
but I don't know if you agree, and I mean there was surface ulceration, not much by way
yeah.
of
No,
zonal
no,
necrosis, but the
no.
MIB1 proliferation index
Yeah,
was was rather striking, and yet
yeah,
indolent behavior.
yeah.
I
Because
think
that's
that's again to
something
do
that
with the way.
for salivary looking tumours,
Mm,
MIB1 is really my favourite
mm,
immunostain. And you just get
mm,
me a MIB1 and you see how they're going to behave, I think,
mm.
for these things.
Yeah. There is a comment from the audience saying maybe HPV induced mutation on the oncogenic evolution.
Yeah, I wonder. So we talk about stepwise carcinogenesis, yeah, with
Mm,
early tumor suppressor genes being inactivated and later on oncogenes being activated. And maybe at one point, HPV
Yeah.
was a player along the
Yeah.
line. I don't
What
know.
about it was HPV 33? Is there any the patient was female, nothing gynecologically in this patient,
No,
like
no,
cervical
interesting.
lesion?
No, they're finding them in the nose. Yeah,
no.
it doesn't
And
seem
so
to be.
I can't tell you whether our case was HPV 33 positive or not because we used a cocktail of
Yeah,
probes,
yeah,
which includes HPV 33. So
yeah,
the only way we
Oh,
can confirm in our particular case, it's definitely a high risk type,
mm,
but whether it's
yeah, okay.
33, 16, 18, or anything else, I
yeah,
cannot say at this stage. Yeah.
yeah.
Yeah. There is also comment from the audience about high Ki-67. How to explain it?
Well, this is my pet theory, and I have no idea whether this is true, and I can't confirm it. So, in normal sort of squamous, as in cervical and maybe oral, stepwise carcinogenesis that's HPV induced, one of the mechanisms is that the virus hijacks the proliferation and the maturation components of the host cell. So it needs to hijack replicating cells in order to produce replicative infection. So I just wonder whether it has anything to do with that. So the virus, the viral oncoproteins, one of the ways it acts is to progress things through the cell cycle, through RB inactivation, etc. So
Yeah,
I think,
E67.
yeah, that's my pet theory, but I have no idea. Sorry.
Yeah. All right. So no more
Okay,
questions. I think it was nice case. Thank you very much. If
okay.
no more comments, Anne, you wanted to add something?
No, I'm going to get my case up. I think
All
my
right.
third. I think I'm on. Am I case two? Is that right?
Yes.
Three, please. I think it's two or
Three,
three.
case three.
Yeah.
It's my last, my case three. I've got
No,
two
no,
here
no,
and
no,
three.
I beg your pardon, and it's your second case. Your
My
second
case
case.
two,
Yeah.
This is
but the
total
case
case
three
three,
here.
but your second case.
All
Okay.
right, can I call it case two then? That'll be good because I
Yeah.
realised I should have called it case three. So can you see my screen?
Yes.
Yes.
Excellent, you can. Okay, great. Okay, and this is a really interesting story. I hope you'll enjoy it. It's a 27-year-old female who came with our issue is with her cheek, but she didn't actually come with her cheek. She came with a lump in her neck to the ENT department, and she just had a baby. And she was really well and very happy. She'd come because her grandmother had thyroid cancer, and she was wondering whether she had thyroid cancer or was prone to it, or and because she's had a child, I think she was thinking about inheritance, etc. But she just mentioned in passing that she had a lump on her cheek that was there, but seemed to be getting better. But would someone have a look at the lump? Um, at a previous hospital, she'd had the thyroid investigated, and they thought that there was a U2 right thyroid and a U3 left thyroid nodule, which is quite large, and nobody mentioned the cheek. So in the clinic here, they could feel the left 3 centimeter nodule, and they saw this cheek lesion, and investigated the thyroid and said, oh, the thyroid's fine, negative for thyroid antibodies. Um, Ultrasound showed the nodule in the left lobe of the thyroid was probably a hemorrhagic cyst, and there was probably a reactive lymph node on right level 3. They couldn't resist the odd lesion in the cheek. So they said, look, we'll just take an FNAC on the thyroid and we'll take an FNAC of the cheek. The hemorrhagic cyst in the thyroid was confirmed. The ultrasound of the cheek just showed this 6 by 3 millimeter ovoid lesion. It was odd. It was immediately deep to the dermis in the subcutaneous tissues. And the FNA caused great alarm and excitement because it was malignant. And the differential diagnosis was it looked like a neuroendocrine tumor. And could it be metastatic small cell lung cancer, metastatic gastrointestinal tumor or pancreas, neuroendocrine tumor, or could it even be a primary in skin, Merkel cell carcinoma? So had other investigations. There was nothing to see anywhere else. And bloods for metadrenalins and the bone profile, everything was negative. So she went to MDT, and the MDT discussed the MRI, saying that you've got a 6 millimeter lesion, seems to be clear of everything else, really not sure what it is. So nothing anywhere else. And the surgeon said, okay, let's take it out. And so that's what they did. So this is what I received, a 7 by 12 by 25 millimeter piece of tissue that I bisected. And you could see this nodule within that tissue is trisected. So this is the histology, and it looks like a lymph node, and inside was a high grade tumor with lots of mitotic figures. And this tumor was negative on TTF1, and it was positive on AE13, and it had this paranuclear dot positivity. And it was positive on CK20 with paranuclear dot positivity. BCL2 was positive, CK7 was negative, and I'm not really sure, I forgot why that was done, but it's, as you can see, positive, that was negative. I think I was looking at the lymphoid tissue actually. CD56 strongly positive, chromogranin positive, synaptophysin positive. So no doubt it was a neuroendocrine tumor and a carcinoma. And it was CK20 positive, as we said, CK18 positive, CK7 focal, S100 negative, TTF1 negative, Desmond calcitonin negative, and the MIB was about 70%. Well, looks high grade, looks metastatic. It was in a facial node, but the differential included Merkel cell, but that was really, really rare. So I thought you better look for a primary site. So dotatate scans showed only uptake in the lesion. Well, they didn't see any uptake really, just the scar where the lesion used to be, and uptake in the submandibular glands, and in the malar region where she'd had the operation. So what next? Really? Primary Merkel cell carcinoma in a facial node? Well, I have to do a lot of work before we can say that, because Merkel cell carcinoma usually affects old men, Caucasian men, in sites of chronic sun exposure. So where are these Merkel cells? What are they? So they live in the skin and in the hair follicles, and they think it's a two-hit phenomenon of UV light and polyoma virus infection sets off the Merkel cell carcinoma. So doing some more reading, okay, things were against it being Merkel cell tumor in that it's usually men, usually much older patients. Okay, it's on the head and neck, give you that. She is Caucasian. And it's in the right site for a head and neck Merkel cell carcinoma. And interestingly, they said if you've got Merkel cell carcinoma of the head and neck, sentinel lymph node biopsy may be helpful. And in the setting of a negative sentinel lymph node biopsy with a clear excision, they would recommend observation only. And then you can imagine I was going through the internet and I found this amazing paper that says, how do you tell the difference between metastatic neuroendocrine carcinoma and Merkel cell carcinoma? And there's this ELECTHIP criteria. So what these people did, they said, you look at the age, you look at the location, you see the extent of the disease. Is it localized? Is it widespread? You look at keratin expression, TTF1 expression, histological subtype, and whether it's polyoma virus positive or negative. So they are the criteria. So here is the paper, and you can see on a higher magnification that in Merkel cell carcinoma, the age distribution is younger usually than in neuroendocrine carcinoma, where the majority of patients are over 70. Excuse me here. So then it's usually localized, often in the inguinal area or the parotid area. So it's localized, often in the inguinal or parotid area, and male to female ratio isn't going to help. So then we look at the histological, immunological, and virological features for people that has Merkel cell carcinoma without primary tumor, which I thought might be what we have. So it should be small cell. It should have dot staining for AE1, AE3, and for CK20. It should have neuroendocrine markers positive, and it should be TTF1 negative, and polyoma virus should be positive. So this then, by doing these tests, they separated neuroendocrine carcinomas from Merkel cell tumors by this ELECTHIP criteria. And when we look at our patient, is she elderly? No, not really. And you needed five of these criteria or more. So we look at our patient, she elderly? No. Is it parotid or inguinal? Not really. The extent, yes, it's localized. Cytokeratin expression, yes, CK20 positive. TTF1 was negative. Histology was a small cell carcinoma, correct. And I sent it off. Daisuke Nanaka, a colleague at St. Thomas's, is Japanese and had colleagues who are looking at polyoma virus testing. And they tested this tumor for me in Japan, and she is positive. So the diagnosis is primary Merkel cell carcinoma in a facial lymph node. And I don't think I can call it metastatic, but it's primary or metastatic, most likely primary Merkel cell carcinoma in a facial lymph node. So that's my preferred diagnosis. And I thought that was an amazing case that I would share with you.
Yeah, absolutely amazing case. I agree. Yeah.
Yeah, okay. It's a nice story. You can imagine
Yeah.
the trauma of the team. You know, she's got a baby, she's very young. What do you do now? What do you do now? You know, it's difficult.
Yeah. Yeah, and then virus was confirmed, right? In this
Yes, in
case.
Japan. I had to send it off, sections off to Japan because we couldn't get it done in the UK. And I think I could have got it done in Belgium, but it would have cost something like €800.
Oh, I see.
Mm.
You know, there are two pathways in developing of Merkel cell carcinoma of the skin, either virus or chronic sun exposure,
Yeah.
two risk factors. So since she was young, what about her skin color?
She was quite fair. There was no history in the family apart from thyroid. She didn't seem to, I did not see her in clinic. She's described as, quite normal looking. She didn't use sunbeds or anything.
Okay. You didn't perform any genetic analysis or genomic profiling of the tumor?
No, I didn't. I suppose I could send it off for NGS. Yeah, I haven't
Because
done
they may
that.
respond very well to immunotherapy in case of further dissemination of the
Mm,
disease.
mm, okay. For
Yeah, immune
again,
checkpoint inhibitors were approved. I think atezolizumab was approved for Merkel cell carcinoma.
yeah, because at the
They-
moment the follow up has been negative. She just had this small nodule that happened in the face. It's been negative so far, but that's a good point.
Yeah, and
Yeah.
PDL1 is frequently positive as well. PDL1.
Okay. Okay.
Yeah,
I'll send it off
yeah,
for testing.
yeah. Just in
Thank
case
you.
of further dissemination of the disease.
Absolutely. Thank you.
Yeah, because they tend to be aggressive. Merkel cell carcinoma usually has very
Exactly.
poor prognosis.
Exactly. So I will. I'll take your advice and send it off for NGS and for
Yeah,
PDL1.
yeah. All right. Thank you for sharing this amazing case. Absolutely. All right. Shall we move on to the case number 4 or case number 2 by Selvam?
Yes, ready to go in 1 second. So hopefully you should see some.
So just a quick question. There is
Yeah.
how was polyomavirus tested by PCR? I believe
Yeah.
yes.
By PCR.
By PCR. Yeah, yeah.
Yeah.
Thank you.
Thank you.
Hopefully you can see my screen, and what you should see in front of you is a series of hall-mount slides.
Yes. Thanks. Lovely.
Excellent.
Yeah.
So this is my second case, and I put this slide up first because this is how it happened in in real life. I was pick up my tray of routine cases for sign out, open up the tray, see this, and think, oh great, a beautiful Warthin tumor. I can get rid of it quite quickly. And the first thought that came to mind was, oh, I wonder who cut this up and why did they put so many representative blocks through, when a couple would have done for a simple Warthin tumor. So I sit down to report it, and lo and behold, the clinical history was that of a 22-year-old female. So unusual, Warthin tumors usually occur in the more elderly population who are smokers and has a stronger male rather than female predilection. But it's not it's not unknown. It has occurred in this younger population. So I thought, fine, I'll go about reporting it. So I stick it under the microscope and think, oh yeah, fine. It's got multiple cystic spaces. It's got a beautiful lymphoid stroma. The lymphoid stroma is organized into its reactive follicles. The epithelial lining is somewhat bland. There's not much by way of proliferation. Okay, yeah, a little bit of tufting in places, but columnar and very often bilamina with this sort of secretions in the lumina of the cystic spaces. More of the same here. So you know, not terribly oncocytic. I've seen usually far more oncocytic in a Warthin tumor, but still largely bilamina. I hope you agree with columnar morphology. Elsewhere, highly attenuated and bland epithelial lining. Ooh, and in occasional places, there was quite a lot of mucus differentiation and some quite sort of plump cell areas in places. So, we all recognize that you are allowed mucus metaplasia and squamous metaplasia in Warthin tumor. And I quickly reached for the electronic patient record and realized that there was a recent FNA. And just to remind you as well that it's perfectly accepted to have quite a degree of mucus metaplasia in Warthin tumor. It has been reported enough anything from none to abundant that is accepted. I skirt elsewhere, and there is a bit of squamous differentiation as well. And again, in the background of a bit of fibrosis, and in the context of a recent FNA, I didn't make much about it. You do get quite a bit of squamous metaplasia. Here we have a bit of cholesterol clefts, so I wasn't too worried about it. I thought it may be accounted for by the recent FNA. More areas of squamous differentiation, but on the whole, looked relatively bland. Again, just to show you the odd mucus cell metaplasia or mucus cell differentiation in places of these cyst lining epithelium. Every now and then I felt, well, actually, these cells are somewhat large, a little bit irregular, and certainly losing its oncocytic appearance. And I felt a little bit uncomfortable. So, not terribly bilaminar here. And it was certainly starting to grow in size and start to be a little bit tufted, not quite ciliated, well, perhaps a little bit ciliated in places, and it's something I hadn't quite appreciated in the lining epithelium of Warthin tumors. And I started to get a little bit worried about it because cytologically it wasn't typical. And then you skirt a little bit more, and I thought, actually, there are foci here. There are foci here of perhaps a bit more atypical cells, but again, in the context of inflammation, I didn't want to overinterpret this. But I hope you agree that there is a degree of atypia here. How much of it could be explained by reactive changes, I didn't know. Um, and uh, some areas, again, with a background of a bit of inflammation, showed quite enlarged tumor nuclei and some rather worrying morphology in places. So I thought, okay, I better consult our cytogenetics department. And in the presence of both mucus cells and squamous cells, I thought we better get the mammal2 translocation done. And I walked the case up 2 floors to our cytogenetics department. I said, look, predominantly papillary cystic in places, but occasional solid areas. Could you sample it in both these areas? And they say, yeah, fine, we'll do that. They use mammal2 translocation studies using a break apart fish probe, and lo and behold, it showed mammal2 rearrangement both in the sort of the cystic lining spaces as well as in the more solid spaces. And so at that point, I thought, okay, so we're dealing really here with a mucoepidermoid carcinoma in both components there. And so really that would have explained why it's had these unusual features and occurred in a 22-year-old female. So my final sign-out diagnosis was that this was a mucoepidermoid carcinoma, a Warthin-like variant. And this was the first case of such that I saw. This came across our desk sort of 2017, 2018. I had to do a quick literature review, and yes, it had been reported in the past. And in both instances, the mammal2 translocation was absolutely key in reaching the diagnosis. And I put this as a bit of a background to the sort of the growing spectrum of mucoepidermoid carcinoma variants. We obviously know the classical and the clear cell type, the oncocytic, now the Warthin-like, but also there is a spindle cell variant. We know about the sclerosing, now the mucinous variant, the ciliated variant. One I haven't come across yet before is the mucoacinar variant, once with high-grade transformation, and earlier on today I presented the case of a central mucoepidermoid carcinoma. So I thought this was quite a nice case where the cytogenetic analysis was absolutely key in reaching the diagnosis. So it was a reminder to me to, despite how common it is to treat the Warthin tumor with a bit of respect, and always to consider the growing morphological spectrum of mucoepidermoid carcinomas. And for those of you who might be interested, I commend this very recent paper by first author Justin Bishop and last author Lisa Ruper, who are well known and highly respected in the field of head and neck pathology. It's sort of hot off the press, about 1 month old, where they entitle their study "The Mucoepidermoid Carcinoma May Be Devoid of Squamoid Cells by Immunohistochemistry, Expanding the Histological and Immunohistochemical Spectrum of Mammal 2 Rearranged Salivary Gland Tumors." And here in their series, they present a number of cases, including the Warthin-like variant and the sclerosing variant. The oncocytic variant was included in the series, but they also included a number of other tumors, which I suppose, according to conventional criteria, we may not have been thinking about mucoepidermoid carcinoma, but Bishop and colleagues suggest that, look, the mammal-2 translocation, at least for now, is specific for this salivary type tumor, and so we ought to consider expanding the morphological spectrum of mucoepidermoid carcinoma. So back to slides, just to remind you that this is, I thought, quite a nice case of a Warthin-like variant of mucoepidermoid carcinoma. The literature is somewhat devoid about how to grade these things. I suppose you can't grade it according to classical criteria, but I think if you did apply the classical criteria, this would be indeed low grade. And as I showed you earlier, this was reasonably well encapsulated. It was done as an extracapsular dissection, and so we couldn't really pronounce on infiltration into the surrounding parotid parenchyma. This patient, I understand, went on to have a completion parotidectomy, and there was no residual tumor in the completion parotidectomy specimen. So I thought this was a nice, interesting lesson for me anyway. Thank you.
Thank you, Selvam. I agree. Yeah. And you wanted to comment?
No, I just said that's so important, that lesson. I've just got a referral from very experienced people in another hospital that is a head and neck unit, which it looked like adenolymphoma. I showed it to you, Selvam, and
Indeed,
it came back as mammal 2 translocated. But Selvam and I were just thinking whether or not it's true that these are representing variants of mucoep, or what this is.
I think I just wonder, and I say this with a great deal of hesitancy, because I just wonder whether at some point things individual biomarkers start becoming less and less specific for individual entities as time goes on, and I just wonder whether at some point how much morphological variety do we accept in a single entity based on a single gene translocation is on in my. There's something for us to think about.
But what about the outcome of this peculiar case? I mean, given the difficulty in grading the tumor.
Yeah. So the last I know, so yes, obviously, like I mentioned, this patient went on to have a completion parotidectomy and a limited selective, a super selective neck dissection, essentially just level 2, and there was absolutely no residual tumor and no evidence of metastasis. So I think just a regular follow-up for this young patient, just to make sure that that the lymph nodes ultrasound follow-up it would be important, and I think that's the only way, really. Interestingly, it was done as a extracapsular dissection, a lumpectomy, because the FNA, and understandably, was fairly confident of a Warthin tumor, despite it being in a 22-year-old female non-smoker.
Yeah. All right. Thank you. Thank you very much for this case. Just let me check if there is any question. No, just comment great cases. No specific comments from the audience.
Okay, I'll load my screen.
Thank you.
Can you see the screen?
Yes, thank you.
Excellent.
Yes, we can see.
Okay, the last case, we've made it. Okay, so this is a 12-year-old male who presented with, not to us, with several years' history of nasal obstruction, discharge and loss of smell. And it didn't get better on topical steroids. He'd had a cleft palate, otherwise nothing of note. And then they found this big unilateral solid, smooth nasal polyp. It wasn't ulcerated, and it seemed to be attached to the right posterolateral wall and deviating the septum. So, I mean, that's a pretty significant polyp, pretty big. But you can see it was more pushing than infiltrative, and it didn't have high-grade radiological features. There's the CT scan. There seemed to be some calcification within it, and so a biopsy was sent, and it was seemed to have a lot of bone fragments in this biopsy, and you couldn't really tell very clearly um, what what the mass was doing. It was fragmented. On higher power, it had really strange mixture of things. So here's the surface respiratory epithelium. This thing seemed to be respecting it. It wasn't, there was no necrosis, there was no mitosis, but it seemed to be respecting the overall respiratory epithelium. There was a lot of this fibrous, collagenous tissue. There were areas where this mesenchymal tissue was forming bone. There were strands of well formed bone. There was definite cartilage with a little bit of atypia, but otherwise, fairly, it looked like a growth plate, really. That's what it looked like. And the mucosa adjacent to it. And this was another area. So polypoid, it mixed cartilage, bone, fibrous tissue, no mitoses, no necrosis, and really strange architecture and morphology. And it was sent for me to me to see what I thought. And my instinct was, I thought this thing was benign, but I hadn't seen anything like it. And it felt like it was all the tissues that should be there, but all mixed up. Anyway, it was pancytokeratin negative, EMA, no cytokeratin expression, CD99 negative, very low MIB, and I just felt that it was very strong and diffusely positive for S100 and Vimentin. So I felt the words that came into my head is, what are you thinking of? You're thinking that it's all the tissues that belong up the nose, but mixed up. Well, that's a hamartoma. And searching through the literature, I thought to myself, well, I have to investigate chondrosarcoma in young people, fibrous dysplasia with odd metaplastic areas, a neurogenic tumor because of the S100. Is it a funny form of meningioma? Is it a chordoma? So I didn't think it was a chondrosarc. I thought the chondroid areas were too well differentiated and not atypical. I didn't think it was an osteosarc because the bone it was developing was actually quite normal looking, and there were no weird atypical osteoblasts. I didn't think it was a chordoma. It was in the wrong site, and it didn't have the phyzoliferous cells and these cords of cells in the mucinous stroma and the so-called bubbly phyzoliferous cells. They weren't there. And I didn't think it was a D. diff chordoma because it wasn't wild enough, and I didn't have great big ugly cells with macronucleoli. And I didn't think the immunopattern was right. And I didn't think it was fibrous dysplasia because I'd never seen those whorls of collagenous tissue and all that cartilage associated with fibrous dysplasia. So I was really coming to a loss as to what it is. And then I found this paper. By putting in the word hamartoma, here is nasal chondromesenchymal hamartoma in older children and adults, because this lesion is associated with babies usually with feeding difficulties. So you can, I hope you agree, the photographs I showed you were very similar to what were being illustrated here. And the S100 and the Vimentin were diffusely positive, and the immunoprofile was exactly the same. So it's very rare. It's usually young infants, and it's now recognized to occur in older children and adults. And the thing is, people don't know where it's come from, wonder whether it's environmental, chronic inflammation, cytokines, growth factors, are all these playing a part. But the genetics of this lesion in 2014, people described the DICER1 mutation, which is associated with the pleuropulmonary blastoma tumor predisposition. So the people with DICER1 mutations, they can get tumors in testis, in kidney, in thyroid. They can get goiters of thyroid. They can get problems in the lung. So there's a germline mutation. So that's what I think this case was. But there's a caveat. A few weeks ago, um, there's a very recent update where they're saying that in order to effectively resect these tumors, you need a multidisciplinary approach and etc. etc. I agree. But I got a second case just a few weeks ago, and it was a nasal polyp shown to me by a colleague here. And it was described as loosely attached to the middle turbinate, excised completely. Previous excision at the Royal National Orthopaedic had been described as inflammatory in 2016. He didn't smoke, he didn't drink, and he had this nasal cavity biopsy. So, fortunately, it looked like a very weird nasal polyp, and we photographed it. So, that's the macroscopic description. And this is what it looks like. So, I got the histology back from 2016, and it had a lot of this bone in it. And you can see there isn't much cartilage or the pink stuff that we saw before. And there's inspissated mucin. And this was the one that I saw. I had an awful lot more cartilage. And again, this is just a biopsy. But I thought, I think it might be one of these, and I'll send it for a DICER mutation study. So this is it on higher power. So inflammatory polyp, lots of bone, a bit of mesenchymal stuff, a lot of chondroid in the recurrence. And sure enough, there was 2 DICER mutations. So I was quite triumphant. And the patient has been referred to a local genetics team, and will have genetic counselling for the other tumours. So they need surveillance for tumours in testis, kidney, lung, etc. So I'd like to raise awareness about this. So I've seen 2 in my career, one in, I think it was 2013 or 2012, and the other one just a few weeks ago. So chondromesenchymal hamartoma. So interesting.
Thank
DICER
you.
one,
Thank you, for this peculiar case again. Yeah. Why wouldn't you call it teratoma?
because it's not. There was no other elements like squame or anything. It was more hamartoma than teratoma. And that was my reasoning, is the fact that it looks like a rearrangement of a dysplasia, if you like, a hamartoma, rather than a true difference in differentiation of stem cells.
Okay. There was one more question related to the previous
Yeah.
case of mucoepidermoid carcinoma with Wharton-like appearance. The Rafif is asking, would you perform mammal 2 in tumors that look classical Wharton tumor?
Oh, interesting. Well, yeah. Well, to be honest with you, we in our setup, uh, we do. Well, I do as additional confirmation, only because I suppose we are set up for such easy access to gene rearrangement testing. If it was a more difficult pathway for referral, to getting these tests done, if it was a typical classical one, obviously you would consider the mimics. What might be the mimics? Sort of clear cell changes in other tumors. Um, yeah, probably not. So I think the bottom line is, yes, I think we do as a reflex test because we have easy access. But in areas which do not have easy access, I'm not sure what the additional benefit might be to reaching a histological diagnosis.
There used to be an argument that the higher grade tumours may be
Yep.
fusion negative, fusion
Negative,
positive,
that's right.
but now I don't. I think that's been disproven.
Yep,
But
that's
as you
right.
say, in an ordinary low grade classical mucoep, do you really need it?
Hmm.
But we do because it's just upstairs. Yeah.
Hmm.
Okay. All right. Thank you very much. I think it's time to proceed to the last case, huh?
Yes, if we have time, I think we do. Do we? Let's see.
Yeah.
Okay, finally, as we're reaching the end of the day, just to finish off, a case of a 35-year-old male, a jaw lesion this time, a 2.5 by 2 centimeter non-corticated radiolucency in the maxilla. So immediately, when you think about non-corticated, it hasn't got a nice thick rim around it. Um, it suggests a more faster growing lesion, which should raise a bit of concern. So the orthopentamogram, you can see a vague radiolucency in this region here, not altogether helpful, but in the cone beam CT, it shows this expansile lesion with a few areas of mineralization within the radiolucency, but which has expanded and significantly thinned and perhaps even perforated the buccal cortex. This is the tumor. So on low power view, irregular islands of uh, epithelium, which are on the whole reasonably uniform. But as we go towards the periphery, uh, notwithstanding there is a bit of crush artifact, the architecture seems to be a little bit more organized as more strand-like in places, and you can get the impression that this thing is reasonably infiltrative. Looking around elsewhere, I stumbled upon islands which were quite happy to confirm as odontogenic in nature. So remember, we talked a little bit about the reversal of basal polarity in the basal component with the palisading of cells and this well-defined basement membrane-like area. Elsewhere, there was again some cell clearing, just to highlight again the fact that there was peripheral palisading. No definite stellate reticulum-like areas, but it has the hint of odontogenic epithelium. Um, a degree of cytological atypia and loss perhaps of the more reversal of nuclear polarity. But in areas, what was striking was the sort of the clear cell morphology, lots of cell clearing, even in the context of the basal palisading and reverse nuclear polarity of some of the larger islands. So I knew at this stage we were in odontogenic territory, and there was a reasonably large differential diagnosis here, which included conventional medulloblastoma of all things, because we know that cell clearing is allowed in a medulloblastoma given the appropriate context. This tumor was strongly diffusely positive for keratin 5-6 and keratin 19, but was strikingly negative for keratin 7. So I thought, well, okay, now maybe I'm quite happy to exclude clear cell uh, carcinomas of salivary origin, given this particular immunoprofile. Again, cannot be absolute, but it helped in this case. So again, rush upstairs 2 floors to our cytogenetics department, and lo and behold, it was EWSR1 rearranged, which is not entirely specific for anything these days, not least for Ewing sarcoma, but also the clear cell carcinomas of salivary origin do share this translocation. But given the context of its primary intraosseous region, the odontogenic background, the peripheral palisading, etc., we was quite clear that this was a case of a clear cell odontogenic carcinoma. So I'm not sure whether the audience are familiar with this. This is a rare tumor of odontogenic origin. It's on the whole reasonably slow growing, but highly infiltrative and reasonably aggressive and very difficult to get round. And most patients succumb to it. But in the literature, there's probably just over 100 cases reported. The mandible is by far the more common site compared to the maxilla. EWSR gene rearrangements with multiple different partners have been reported in more than 90% of cases. There's usually reasonably obvious perineural infiltration. I couldn't identify any in our particular case, but we definitely had this infiltrative nature. Recurrences have been reported in about 40%, and interestingly, about 10%, 10 to 11% of these patients succumb to the disease. Just very briefly, the main differential, as I mentioned earlier, is the hyalinizing clear cell carcinoma of salivary origin. And there are 1 or 2 handy hints that will help distinguish between the two, not least the cytokeratin 7, as well as the sort of the background. So with the hyalinizing clear cell carcinoma, a rather useful hint is to look at the stroma, the stromal component, composed both of hyalinized areas juxtaposed, against more myxoid areas. This is typical for the hyalinizing clear cell carcinoma of salivary origin, which we didn't see in the one of odontogenic origin, and the obvious glandular elements in the one from the salivary origin. So I just put this in just as a nice contrast of clear cell carcinomas in the head and neck region, one of salivary origin and one of odontogenic origin, just to make the point. Um, and I think at that point, just to show you how the keratin 19 in our case of hyalinizing clear cell carcinoma of salivary origin was completely negative. So keratin 19 and keratin 7 uh, of these two cases are almost mirror images of each other. So we don't often see it. We are highly aware of the clear cell odontogenic carcinoma, but I thought I'd just include it just as a way to finish off some of these interesting cases at the end of the day. So I think that's all really I wanted to say about this case.
All right. Thank you, Selvam, for sharing this interesting case as well. This is a good addition to your previous presentation on odontogenic tumors, I think. Nice
Very
case.
good.
What is the clinical outcome of this case? Maybe I missed
So
it.
this
Sorry.
no, no. So this patient went on to have an oncological resection and a limited neck dissection. From what I remember, I think it was quite an advanced case. Uh, Positive margins were reported, but no local regional nodal metastasis. And I think our tumor board decision was to recommend adjuvant radiotherapy in this case. The numbers of cases are so small. We don't really know how many of them are going to be radio responsive. We know these are infiltrative, and we know on the whole they're reasonably slow growing. But given the widely infiltrative nature in this particular case and in other reported cases, that was our decision. But rare tumors, we don't really know. We haven't got large-scale series
Yeah,
or
yeah,
any controlled trials for that matter. So again,
yeah.
I think these patients have to be followed up for a long period of time, with all these odontogenic tumors.
Okay. Any comment from Anne?
No, that's an excellent case. I had clear cell carcinoma occurring in the retromolar trigone that Selvam's helped me with, and that was a very small tumor, and they did quite a big resection, but she already had lymph node metastasis, and it's gone to lung and liver. It's a very interesting case, but they share the translocation. But Selvam's findings very interesting to me. That CK7, CK19 is quite interesting to me. But they do share the translocation, salivary clear cell hyalinizing tumors and clear cell odontogenic tumors, and they're thought to be indolent in the salivary gland. But the case I had was actually unexpectedly aggressive. So I think they're unpredictable critters, really, I think. Yeah.
Okay. Thank you very much. Thank you for presenting these 6 amazing cases, I would say. And this is really a good addition to all your talks that you have provided today. And people are still, more than 50 people is still online. And I cannot see any other question from the audience. So if no more questions, I would really thank you very much for your great contributions and for making this event very interesting and very successful. So once again, thank you very much for today's sessions and presenting all the interesting cases. I appreciate it very much. All the images that you have presented are amazing, from the macroscopy from the very first session this morning until the very last one, with all these cases that you have presented. Although many of them are really rare and not likely to be seen in real in practice of general pathologists, but still being aware of rare entities is also very useful. I agree. I think.
Yeah. You never know. And if you get a case, they now know where to send them. Get in touch. Yeah.
Yeah,
Yeah. Yeah.
absolutely. Thank you very much again, and I wish to thank Jeff for making the event possible, for his technical and logistical support, and of course, thank you to British division of the International Academy of Pathology as well, and my local colleagues with Faruk from Bosnia, and of course to all the participants that make the event this year possible. And I do hope that the event this year is the last one that is exclusively online. I hope we will switch to hybrid events with live sessions in Sarajevo and Bosnia. And of course, you are welcome to come to visit. Anne was there once, and
Yeah, I
Selvam is
loved
also
it.
very welcome to come.
I loved it. I love
Thank
Sarajevo.
you.
I remember
Yeah,
drinking tea in the mountains, and I remember dancing with all the
yeah,
Serbian and
yeah.
Croat
We,
colleagues.
we,
Yeah,
we do remember as well. So you are
absolutely.
welcome. And again, thank you very much for your contributions to this event today. Thank you so much.
Thank you. Thanks
And wish you
everyone
all
for
the best.
tuning
Yeah,
in.
wish you all the best, and wish you a pleasant rest of the day.
Thank
Thank you
you.
very much.
Thank
Thank you.
you. Thank you. Jeff, thank you
Thank you,
very
Jeff.
much for your support as well.
That's us. We're finished, I think. Yeah.
Great.
There you go. All done. You're all worn out. You're all muted. And you're muted. Don't know why. No idea why. Very odd. I think it's the computer god saying you've all worked so hard, you need to go home. I have no idea. Oh, let me see. In sound levels. Ah, found it. There you go.
There you go.
Yay.
Because it wouldn't let me do anything. Yeah,
I
it's
don't know why
probably
that
just
comes
as well. That's a Jeff technique to keep me quiet. Yeah, I can see that. Yeah, that's good. That's good. That's good. My husband would love that. Yeah, absolutely. Put me
Is
on
Samir still in the group, in the chat, Samir, are you there?
Yeah,
Yeah, I'm here. Yes,
What time is it for you, Samir?
it's 8:10. 8:10.
Right, in the evening. Yeah.
Yeah,
Okay.
yeah. Thank you very much again. I appreciate all your efforts to make this event really great. Thank you so much.
I hope, as I say, I hope it's well received. And thanks, Samir. Lovely to see you
Yeah,
again.
I'm sure I already received 2 messages just shortly after, and the people appear to be very happy for the event. They appreciate your efforts and your lectures, really.
Excellent. I'm glad. Because I mean, I think it's rare, but I think Selvam's that last case was great because it brought together a lot of stuff. I mean, they may not see it, but they might, and they need to know what to do.
Yeah,
Yeah.
exactly.
Yeah.
It's always difficult though, Samir, to know how to pitch it as well, isn't it? Because you want to present rare cases to keep
Yeah.
everybody interested on the one hand, and you don't want to present communal garden cases too many. And it'll be useful for some people, but
Yeah.
maybe some people may get put off if it's too simple and straightforward. I don't know.
I
think
agree.
you
Yeah,
did
absolutely.
well. Yeah.
So a mixture of everything
Yeah.
would be useful. Great.
I
All
think
right, guys.
it was nice working with you, Selvam. It went well, I think. I can't
Likewise,
believe
I
we
think,
got
Anne.
through it. Yeah.
I hope you're going to go home now and don't start looking at your
I've got
in tray
3
on it.
things I need to sort out before I go home, but it's not too bad. I've got my gin and tonic and Strictly. I'm hoping to get home in time for Strictly.
Well, I'm going to crack open a bottle of whiskey now, I think. I don't know
Just
what
do
else.
it, Selvam. Well done. I've got my gin and tonic. I bought these £2.50 gin glasses. I'm going to fill that up tonight. I tell you when they get in. But anyway, Selvam, it went better than I could have imagined. Thanks to Jeff as
No,
well. So.
yeah, absolutely. I think it all worked really well, Anne.
Yeah.
I don't think, well,